occurs on the palms and the soles of the feet. Early symptoms can be just like tingling, burning. It could be redness or swelling. For some people, it gets more severe. They get blistering, they get pain, bleeding, difficulty walking as a result of these, requiring drug holds. But proactive management of this is really critical. And so we spend a lot of time in the clinic talking to patients about what we can do to moisturize using, urea-based creams, avoiding, ointments or lotions or soaps that have a lot of fragrances or alcohol in them, getting comfortable shoes, reducing the friction, soaking their feet, avoiding sunlight, or at least protecting your skin as much as you can with hats and long sleeves. And then certainly we can treat these situations with steroid creams, lidocaine cream, pain relievers as needed. 40% urea cream tends to be a go-to for us. And often I'll send that to patients in advance so they have it on hand should they need it if symptoms progress before they see us in the clinic. Next slide. Wound healing. So similar to what we talked about earlier with bleeding and clotting risks, patients also have an increased risk of poor wound healing. Thinking about their comorbidities is important here as well, because that further increases risks such as diabetes or peripheral artery disease. What's their nutritional status? Are they a smoker? Do they have chronic steroid use? And so again, this is a lot of patient education around if you need to have any dental work, any procedures done, if you're getting a biopsy or even a skin thing, please let us know in advance. We might need to hold your therapy. Likely we would hold your therapy for a period of time, depending on the invasiveness of the procedure. Ensuring that patients have good wound care. If they're someone who's a diabetic or have peripheral vascular disease, certainly adding this in will, require very, very close monitoring of these patients, good blood sugar control, and partnership with other subspecialists, as well as, monitoring for infection in these patients. Next slide. So I want to just briefly talk about overlapping toxicities with combination IO and TKI. I mean, obviously, as you saw, many of these toxicities do overlap. And so we spend a lot of time having to tease this out as clinicians, like which drug is it? But generally, the strategy has been in our practice to hold the TKI first, and repeat labs or monitor or closely follow the patient. Once the immunotherapy is given its fixed dose, it's also harder to titrate. There's no ability to titrate immunotherapy for the most part, but TKIs, we can titrate dosing. So we utilize that in our toolbox and our strategy. Certainly using, laboratory monitoring on a weekly basis, monitoring symptoms, bringing patients in between cycles as needed, aggressive tracking of their bowels for GI events, et cetera. So this is really it's a delicate and intricate sort of balance as you're managing when patients are on combination IO and TKI therapy. Next slide. And so I talked a lot about patient education, and I think this is really critical, particularly because some of our patients who are coming in, they don't necessarily realize how mechanistically these drugs work. We spend a lot of time explaining that, and then that sort of trickles down to what the side effects are that they might experience. But it's really important to equip our patients with tools, resources for them to be able to understand, to be able to manage, to know how to educate other providers. If they show up in the emergency room, make sure that those providers know that you're on these therapies, because the differentials for whatever symptom you might present with is much greater when they know that you're on a drug like immunotherapy or a TKI. And so I think, equipping our patients with resources and tools, as well as how to reach us, making sure team members know to contact our office, is really important. And then for providers here as well, I've just put in some of the references that we've talked about, such as NCCN guidelines to guide the management of these toxicities, as well as CTCAE grading criteria. Next slide. And that's it. Thank you. Thanks so much for having me.
So much for this wonderful talk. And indeed, managing toxicities is not less important than guiding the treatment, because this is essentially what is left with the patient. And thanks for these incredible insights on immunotherapies, which are novel predicting GU cancers. And thank you for being with us today. We're going to move to our next speaker. Our next speaker will be Dr. Ilya Timofeyev from Russia, who is a director at the Bureau for Cancer Research, is the ASCO Central and Eastern Europe Regional Council member, and we have a pre-recorded video of Dr. Timofeyev. Unfortunately, he couldn't be live with us, but he gonna share insights on real-world evaluation of treatment approaches and immunotherapy outcomes in Russia.
Good morning. My name is Ilya Timofeyev. I am Director of Bureau for Cancer Research, BCARE. First of all, I'd like to thank Organizing Committee for your kind invitation. On behalf of my co-investigators, I'd like to present results from real-world data studies in Russia. I will share my screen. Okay. I would like to start with the trends in kidney cancer incidence in Russia over the last 15 years. Unfortunately, we have seen an increase in the absolute number of patients by 33% over this period. What does the future hold? Back in 2021, together with my American colleague Lola Rahib, we prepared a forecast for cancer incidence in Russia through 2039. The results are troubling. We expect a substantial rise in all GU tumors, kidney cancer included. By 2039, the number of newly diagnosed kidney cancer patients will increase about 1,500 cases per year. This projected growth is a serious cause for concern. The trend will be especially unfavorable for men. As you can see from the slide, GU tumors are projected to rank among the top 5 most common cancers in men, with kidney cancer itself taking 4th place in this unfortunate ranking. A similar trend is evident in the United States as well. That's why I often say we are facing nothing less than an epidemic of genitourinary cancer. But there is also good news. If current conditions are sustained and new treatment options continue to be introduced, our forecasts suggest a meaningful reduction in kidney cancer mortality in Russia. By 2039, we expect around 2,000 fewer deaths each year, a very encouraging trend, in my opinion. Is the incidence of non-clear cell RCC changing? The reported prevalence of non-clear cell RCC has varied across studies for years, partially due to evolving World Health Organization classifications and improvements in pathological diagnosis. A retrospective analysis was conducted at 9 cancer centers across different parts of Russia. Patients diagnosed with RCC between 2022 and 2023, confirmed histologically with detailed pathological descriptions, were included. The primary outcome was the period prevalence of non-clear cell RCC, defined as the proportion of non-clear cell RCC cases over a 12-month period. A total of 2,835 adult patients were analyzed, with a mean of 315 patients per region annually. Of these, 540 patients were diagnosed with non-clear cell RCC, yielding a period prevalence of 19.05%. So we have 19% of patients with non-clear cell RCC each year. The most common histological subtypes were papillary and homophobe RCC. Another question: how many patients are diagnosed with advanced disease or later progress to metastatic RCC in Russia? Based on results of our RANSOR-5 study and Russian registry study, 60% of patients will have advanced disease, and these patients will require systemic therapy, 60%. Therefore, it's crucial to bring new treatment options into clinical practice. So what therapies for metastatic renal cell carcinoma are currently available in Russia? Each year, Russian Society of Clinical Oncology, RUSCO, updates its national guidelines for kidney cancer management. As you can see, immunotherapy combinations are already approved and recommended. Also, in some cases, monotherapy with tyrosine kinase inhibitors is still used. However, it's important to know that belzutifan and tivozanib are not yet approved in Russia. And now, on the next slide, we will look at something interesting. The actual number of patients receiving immunotherapy. How many patients in Russia are on immunotherapy now? Are you ready? Okay. According to a recent big data analysis, in the second quarter of 2025, about 64% of patients in Russia received immunotherapy-based combinations. The most commonly used combination was pembrolizumab containing combination. Interestingly, unlike in many other countries, the avelumab plus axitinib combination remains actively used in Russia, while nivo-based combinations are prescribed less frequently. Unfortunately, nearly 1/3 of patients are still treated with tyrosine kinase inhibitor monotherapy in the first-line setting. Russian oncologists prefer to use these combinations in patients with favorable IMDC risk. Let's look at how patient outcomes have changed since 2010. This is our first study, RANSOR-5, which assessed overall survival in the general population of Russian patients starting from first line in 2010. Unfortunately, at that time, most patients in Russia were receiving only interferon. 5-year overall survival was just 8.2%. 3-year overall survival rate was also poor and was around 19%. So at that time, the results were, to put mildly, unsatisfactory in Russia. 5 years later, we reassessed overall survival in the RANSOR-3 study. By that time, we had entered the era of targeted therapy. Also, access across post-Soviet Union countries was still bad. We did observe some improvement in 3 years survival compared with early data. Nevertheless, the results remained disappointing. As you see, 3-year overall survival rate was just 21% in Russia and 25% in Kazakhstan, 10%, just 10% in Republic of Belarus. At the end of 2015, nivolumab was approved in Russia as a second-line treatment for metastatic renal cell carcinoma. This approval truly marked the beginning of a new era of immunotherapy. As I mentioned earlier, modern immunotherapy combinations are now being used in the first-line setting in about 60% of Russian patients. So it's important to evaluate how this translates into real-world outcomes. You can see we conducted a study designed very similar to early ones, RANSOR study, which this study included 233 patients with different IMDC risk from real practice patients who received first-line therapy starting from 2019. In this analysis, the median overall survival has not yet been reached. More than half of patients are alive till date. And importantly, we observed a twofold increase in the proportion of patients surviving 3 years compared with previous data. As I showed, we have 20% for 3-year overall survival rate, and now 62% of patients are alive at 3-year follow-up. The median progression-free survival was also very good, 15.2 months, and this number was very similar to prospective international studies. Another more major Russian real-world study included 126 patients who received IO-IO combinations or IO-TKI combinations. The median overall survival was at least 2 years, and the median progression-free survival was 22 months in IO-TKI cohorts. So this data is encouraging. A separate observation study evaluated the efficacy of the lenvatinib plus pembrolizumab combination in real-world Russian practice. The results were impressive. My colleagues reported a median overall survival of 48.9 months, and the median median progression-free survival was 24 months. Outcomes very much in line with those seen in the prospective CLEAR study. However, the objective response rate was somewhat lower at 46%. However, this is a real-world study and very complicated population of patients. Patients with brain mets were included in this study also. It's important to remember that in the CLEAR study, only 9% of patients had a poor IMDC risk. In real-world practice, however, this group is much more common. That's why real-world studies are so valuable. They allow us to evaluate how new treatments perform in everyday clinical settings. And we conducted a similar study. In this, our observational study, we focused specifically on patients with intermediate and poor IMDC risk. Notably, 53% of enrolled patients fell into the poor risk category. Even in this challenging population, the results were encouraging. The median progression-free survival was 19 months. The objective response rate reached 48%, and the median overall survival has not yet been reached, all of which highlight the activity of the lenvatinib pembrolizumab combination in daily practice. Okay, one moment. As you know, the combination of avelumab and axitinib is not widely used in many countries compared with other combinations. And I believe that's a missed opportunity. Our ambidextrous prospective and retrospective renal study demonstrated encouraging results. The median progression-free survival was 14.9 months with an objective response rate of 44.3%. Importantly, only 19% of patients in this study experienced treatment-related adverse events of grade 3 or higher. Real-world studies often give us insights that randomized trials cannot. In this sub-analysis, we asked a practical question. Do bone or liver metastases impact the efficacy of avelumab and axitinib? The survival curves provided a clear answer. There was no meaningful difference. The combination demonstrated efficacy regardless of the site of metastasis. Overall, the findings from all real-world studies are consistent with the results of the Javelin Renal 101 trial, confirming the activity of the avelumab-axitinib combination. And now, speaking of axitinib-based combinations, I'd like to share the results of comparative analysis from real-world practice. In this study, we compared patterns of disease progression between patients treated with dual immunotherapy, nivo-ipi, and those receiving immunotargeted therapy. As you can see from the data, New metastatic lesions appeared more frequently in the nivolumab-ipilimumab group, most often in the lungs, lymph nodes, and bones. By contrast, patients treated with axitinib-containing combinations tended to progress through enlargement of existing lesions, with new metastases more commonly appearing in the lymph nodes and adrenal glands. So this data is also interesting, and probably this data could impact on our choice of second line of therapy. In conclusion, the incidence of renal cell carcinoma is rising in Russia and worldwide, among men especially. The prevalence of non-clear cell RCC has increased in clinical practice, and we need clinical studies for this cohort of patients with papillary, chromophobe, TFE3, etc. Since 2010, real-world data show significant improvements in survival outcomes, largely driven by the introduction of novel therapeutic options. Real-world evidence from Russia aligns with findings from international prospective studies, confirming the importance of this observation. We need a real-world studies, and we have to receive the real-world evidence. So thank you very much for your attention. Thank you again for invitation for very interesting event, VIRO, and I hope more and more oncologists will be involved in treatment of this disease, kidney cancer. I hope we will meet in personally in June ASCO. Thank you very much.
Thanks, Dr. Ilya, for this wonderful presentation. And indeed, hopefully we're going to meet in person and the next event will be on site. It's really important on what is in the real world and how the outcomes differ from the clinical trials we see in the West. And let's continue to move in the other aspects of the GU cancers. And our next speaker, I can see is already here. Let's welcome Dr. Armine Badayan from Armenia, who is the acting director at Radioisotope Production Center here, and will speak about radiological assessment of small renal masses. Dr. Armine, welcome, and let's see.
Can you hear me? Hi, can you hear me?
We can hear you very badly. Maybe we can adjust the microphone. Can we ask to just rejoin? If you can kindly turn it off and then rejoin again. I think we'll wait for you, don't worry. I can see joining. Can you speak up again?
Hi, can you hear me?
It's way better.
Yeah, it's okay.
If you're having a microphone, I think it will be better without.
I just take off the headphones.
Okay, we'll try to hang this. We're seeing your screen. I'm giving the floor to you.
This is a great honor for me to present on the topic of renal masses with a particular focus on small renal masses. These lesions are frequently encountered in daily practice, and while many are benign and easy to characterize, they require careful evaluation to rule out malignancy. In this presentation, I will review their imaging features, classification, and the role of differential modalities in diagnosis and management. So let's start. Small renal masses are defined as lesions under 4 centimeters. They can appear either solid or cystic, and importantly, they may be benign or malignant. 20% of 1 to 4 centimeter solid tumors are benign, and 40% of under 1 centimeter tumors. So, how can I fix it? Can you hear me? anybody can you listen me? Can you? Hi everyone. Is it better now? Is it good now? So can you listen me? 20% of 1 to 4 are benign and 40% benign. Near 80% of all renal cc's and near 7 cc's under 4 centimeter. The most common lymphomas, oncocytomas, and RCCs. Common, benign, and typically is on quickly to clinically significant. And just to remind you, renal to Bosniak system, Bosniak for benign and don't need further.
Okay, can you hear me?
Hello, welcome back. We can already hear you. That's great. So please welcome back Dr. Zhang, Chief Physician, Associate Professor, Deputy Director of Department of Nuclear Medicine, Peking University First Hospital. Now we can already restart again. Sorry for a little bit delay and technical problems. We will share your screen and help you out. Thank you so much.
Screen. Turn to the next slide. Okay. Third 20 until meaning 70 to 8, but most are intolerant in nature with limited metastasis. You know, the in the diagnosis characterization and the station of the treatment are the major histologic subtype. Also, they can, you know, the CT is the main and most widely used imaging technique for SM categorization and has a 90% sensitivity for detection of RCC for SMs and almost 100% detection RCC for renal masses that greater than 2 centimeters. But MRI offers the added benefits of no radiation, exposure, and improved characterization of cystic lesions. Lesions and smaller than 2 centimeter and histologic subtypes of SCC. Okay, the next. As for the PET-CT, we commonly use the FDG. It is a glucose analog. It's based on the semi-quantitative assessment of glucose metabolism. Its advantages propose the surrogate for tumor aggressiveness, and the SU max of lesions in patients with advanced ICC is independently associated with overall survival and related to higher forming grade and fire stage and cyclone features. But it has also have disadvantages. It includes due to the physiologic uptake in renal parenchyma. Okay, the next. Use the FDG. Okay, the next. Okay, the next. Okay, we just show the results that in CCRCC and PCRCC, high-grade tumors had significant grade SU max than the lower grade tumors. Also, they can see the hormone grade G1 to G4 has different FDG uptake, and the G4 has the most significant FDG uptake in the CCRCC. These 3 articles are from okay, the next. These 3 articles are from our team. Okay, the next. The first is we can see the elevated tumor to liver standard uptake value, means the TLR can and the T the article. Okay, the next. Okay, you can see the metabotic parameters such as SU max, TR, and TKR were significantly different from any 2 of the 4 different grades, except those between WHO grade 3 and grade 4. Okay, the next. About the CA9 is a cell surface. It's a cell surface marker that is overexpressed in VHL-mediated pathways and expressed in nearly 100% of CCRCC. Average sensitivity and specificity of 86.2 and 85.9 respectively for identifying CCRCC. We now use the antibody and the peptide for the new probes to detect the CCRCC. You can see this article is published on the Lancet Oncology. It's just tells the story about the zirconium 89 for PET imaging of clear cell renal cell carcinoma. It's a prospective open label multi. The next, okay, thank you. But the patient needed to receive one dose of the probe by IV injection on day 0, but they needed to perform the PET-CT imaging up. But the result is very exciting. We can see the for tumors, it's just to show that for tumors smaller than 4 centimeter, sensitivity was 85. Specificity was nearly 90%. This could be a promising tool that could lower small SIMs and CCRCC. Just the next slide will show you the figure A is 40-year female with a 62 millimeter lesion in middle left kidney. Okay, it's a gallium 86 labeled by bicyclic peptide C1 that targeting C9 is work of our team. It is the C1 scan shows significant radioactive uptake in the lesion located in the upper row of the left kidney. SU max is 3.5. In contrast, the FTG scan demonstrates only mild FTG uptake in the same lesion. SU max is 2.3. It's our published data. C1 and FTG. Both C1 and FTG showed high uptake in the right lung metastasis, the left adrenal gland metastasis, and the right scapular metastasis. But the C1 provides clear visualization of the brain metastasis. Okay. About the PISMA PET-CT, the expression of PISMA on the neovasculature of many solid tumors include especially the clear cell histology. We can see research data showed that 76.6 RCC and 30% of chromophore RCC samples show expression of PISMA, whereas papillary RCC samples are negative. So we can see just the showcase of the PISMA capacity in the use of restaging of CCRCC. We can, in left figure, we can see the manipulations and the lesions in the left side of the lobe. And the right figure, we can see the brain metastasis and the lung and the bone metastasis also can obviously seen in the PET-CT imaging. Okay, this just shows the PET-CT, PISMA PET-CT in discrimination the pathological characters in primary CCRCC. Okay, the next. The CCRCC G1 and G4 has the very different PISMA expression. The G4 has the obviously PISMA expression in the tumor. Okay, about the Nectin-4. Nectin-4 is a type 1 transmembrane protein. The OI expression of Nectin-4 has been identified in a variety of cancers, including urothelial cancer, but it's not expressed in the RCC. So the molecular imaging targeted Nectin-4 could be used to differentiate from RCC from UC. Okay, the next. It's also the work of our team. It's to be the high-grade urothelial carcinoma. So it's the work of our team. The next, with in the right pelvis, we can see increased the glucose metabolism and negative Nectin-4 expression. The right pelvis is the pathologically proved to be the renal cell carcinoma. So about the spot CT, and the system may be used to assess the breast, cardiac, and the parathyroid pathology. But its system may be accumulates in cells with high mitochondrial content and low MDR pump expression, which are characteristic of renal. Okay. It's also a work from our team. 26 women with tumors in the 2 kidneys, but with no FDG, FDG, but it can show the mild maybe uptake. The pathologic results was the eosinophilic solid and cystic renal cell carcinoma. So, and this is similar to the oncocytoma. Is a special subtype of the RCC. Okay, as for the novel PET imaging for SIMS, small renal masses remain difficult to characterize with any invasive approach and non-invasive approach. Molecular imaging of either metabolic processing and or specific targeting offers tremendous opportunities to better risk stratify decrease surgery for non-malignant pathology. Okay, the last one. Okay, thanks for our colleagues from our department, and thanks for your attention. Okay, thank you.
Hello, everyone. Can you hear me? Okay, let's start. Can I continue? Okay. Hello, I'm Armine Badyan from Armenia, and I'm an acting director at Radioisotope Production Center. This is a great honor for me to present on the topic of renal masses with focus on small renal masses. These lesions are frequently encountered in daily practice, and while many are benign and easy to characterize, others require careful evaluation to rule out malignancies. And in this presentation, I will review their imaging features, classification, and the role of different modalities in diagnosis and management. Small renal masses are defined as lesions under 4 centimeters, and they can appear either solid or cystic, and importantly, they may be benign or malignant. 20% of 1 to 4 centimeter. Oh, can we just change the slides? Yes, this is the right one. 20% of 1 to 4 solid tumors are benign. 40% of under 1 centimeter tumors are benign, and near 18% are renal cell carcinomas with dominating clear cell subtype. And near 70 to 18% of RCCs under 4 centimeters are low-grade tumors. Next, please. The most common small renal masses are cysts, angiomyolipomas, oncocytomas, and renal cell carcinomas. So since cysts are common, benign, and typically easy to characterize, I'll move on quickly to solid renal lesions, which are more clinically significant. And just to remind you, renal cysts are classified according to Bosniak system, which ranges from Bosniak 1 to Bosniak 4. Bosniak 1 or 2 cysts are considered benign, and they don't require further imaging or follow-up. Bosniak 2F cysts are slightly complicated cysts, and the follow-up of imaging is performed at 6 months after diagnosis, and then needs to be repeated after 12 months, counting from diagnosis, after on annual basis for up to 5 years. Bosniak 3 or 4 cysts measuring under 2 centimeters, active surveillance is now suggested as preferred strategy, and those between 2 and 4 centimeters, active surveillance and surgery are suggested as equal options. So let's, the next slide, please. And the next. Let's go forward and talk a little about angiomyolipomas, which are very tricky lesions, and sometimes they can be interpreted wrongly and cause unnecessary surgical interventions. Angiomyolipomas can be divided into 2 large groups. Those are typical ones, triphasic. That means that they contain all 3 types of tissue, fat tissue, muscle, and vessels. The other large group is atypical AMLs. They can be monophasic or epithelioid. Monophasic AMLs, that means that they contain only 1 type of tissue that can be smooth muscle or fat tissue. And epithelioid AMLs contain epithelioid cells, and this type of AML is predisposed to malignancy. Approximately 5% are lipid poor. 80% of the cases are sporadic, and 20% are associated with phacomatosis. On ultrasound, we see them as hyperechoic lesions with posterior sonic attenuation. The next, please. On ultrasound, we see them as hyperechoic lesions with posterior sonic attenuation, and during the Doppler, the flow is intratumoral and focal. Next slide, please. On CT, fat-rich tumors, Housefield units are less than -20 Housefields, and dilated vessels can be seen. Unlike RCCs, calcification, necrosis, or cystic changes are extremely rare. And the next, please. Here is a case with classic small, fat-rich angiomyolipomas. This examination is with contrast enhancement, but non-contrast CT is enough for diagnosing this kind of AMLs. Ultrasound is also enough to have a certain diagnosis. And the next, please. For lipid-poor AMLs, unenhanced CT has very limited role. On MRI, lipid-poor AMLs, they must have tumor to spleen ratio less than 0.71, and signal intensity index must be higher than 16.5%. These indexes are reversed in invisible lipid AMLs. And a really helpful tool to differentiating AMLs from RCC. This is an internal to external circle ratio on contrast-enhanced CT. Please, the next. This is a study addresses a clinical challenge, differentiating small fat-poor AMLs from RCCs using contrast-enhanced CT. A total 212 tumors were analyzed retrospectively, and 35 fat-poor AMLs and 177 RCCs. Researchers examined morphological features on contrast-enhanced CT, such as angular interface sign, overflowing Beer sign, tumor diameter circularity index, and internal to external circle area ratio. And this showed the highest diagnosing performance with AUC near 0.899, and this is significantly better than other parameters. This study demonstrates that ISCR is a valuable parameter in contrast-enhanced CT to differentiate small fat-poor AMLs from renal cell carcinoma. Next, please. And to obtain this index, the MIC, and it is the largest possible circle that fits entirely inside the shape, touching its boundary at one or more points, should be divided by the MCC, and this is the smallest possible circle that completely contains the shapes with all points of the shape lying inside. And multiplied by 100%. And the smaller result is the higher probability that the lesion is an AML, because as we know, small renal cell carcinomas, they mostly have ball-like shape. And the other one, the next, please. And this is just an example of overflowing Beer sign. It is also a very good sign to differentiate AML from RCCs. Next, please. Next slide, please. Here is a case of lipid-poor hyperattenuating angiomyolipoma, which is hyperdense on unenhanced CT. And after contrast injection, we can see little drops of fat, especially in nephrographic phase. And this helps us to have a diagnosis. Next, please. The other case of lipid-poor angiomyolipoma on unenhanced CT, it is slightly hyperdense on the first photo, on the leftist photo, with thin hyperdense rim, and Housefield units are greater than 10, and we can see early wash in and wash out in corticomedular and excretory phase. The same case in MRI. The left image is on T2 weighted images, and we see hypointense lipid-poor angiomyolipoma with hyperintense rim. On the right photo, we see that the lesion seems larger, and this is because of suppressed fat. Next, please. Oncocytomas are benign tumors representing about 3 to 7% of all renal neoplasm, and it mostly commonly occurs in older patients, particularly the 7th decade of life. Next, please. And some good news for radiologists: there are no precise radiologic criteria to distinguish oncocytoma from RCC. The growth rate of oncocytoma are nearly the same as RCCs, and definitive distinction requires immunohistochemistry. Next, please. On ultrasound, the lesions typically appears as a well-defined solid mass with variable echogenicity, and in some cases, a central scar may be observed, though this finding is not specific. And importantly, ultrasound has limitations in reliable distinguishing such lesions from renal cell carcinoma, which makes further imaging and histological confirmation necessary. Next, please. On MRI, these lesions are typically hypointense on T1 weighted images and hyperintense on 2T weighted images relative to the renal cortex. And the hypointense central stellate scar may also be visible on T2, which can aid in recognition. After contrast administration, the lesion usually demonstrates homogeneous enhancement. Next, please. On CT, lesions smaller than 3 centimeters usually show homogeneous attenuation, while those larger than 3 centimeters tend to appear heterogeneous. A central non-enhancing scar may sometimes be seen, but this finding can overlap with renal cell carcinoma. And a characteristic feature is segmental enhancement inversion. Next, please. Segmental enhancement inversion refers to a characteristic imaging finding where different regions of renal mass demonstrate opposite enhancement patterns between the corticomedullary and nephrographic phases on contrast-enhanced CT. On the corticomedullary phase, one portion of the lesion enhances more strongly, while another portion enhances less. In the nephrographic phase, the relationship reverses. This is a case of oncocytoma with unenhanced central scar, but as you can mention, this is very difficult to differentiate from renal cell carcinoma because they have exactly the same pattern. Next, please. And let's go to RCCs, and the most common subtype is clear cell carcinoma, accounting for 70% of all RCCs. And these tumors arise from renal cortex and often expansive. They are hypervascular, heterogeneous due to necrosis. And on the second place is papillary cancer, accounting 10 to 15% of all RCCs. Typically, they are homogeneous, hypovascular, and can mimic cysts. Chromophobe RCCs are accounting near 5% of all RCCs, and they can have a central scar similar to oncocytomas. Next, please. CT is the cornerstone of SRM evaluation. We need thin slices and 3 crucial phases. The first one is non-enhanced phase, corticomedullary phase, that is 25 to 18 seconds for subtyping RCCs, nephrographic phase, that is 19 to 120 seconds after contrast injection. The next 2 slides, next please. The next 2 slides is to show the importance of right phases. On the left image, the hypodensive area is very difficult to demarcate and to differentiate from medulla. And on the right image, we see hypodensive lesion that is clearly separating from surrounding renal medulla. The next, please. In this case, on the left photo, we can see a hypervascular expansive lesion that seems like RCC, but going with corticomedullary phase, we see that this is not a lesion, but local hypertrophy of the renal parenchyma. The next, please. Here is an example of a clear cell carcinoma. This is a really very small tumor with maximum diameter for 2 centimeters. And we can mention that the tumor is bull-like, hypervascular, and heterogeneous. And this patient already undergo surgical interventions, and the diagnosis is certain. It is a clear cell carcinoma. Next, please. And this is a classic example of a papillary carcinoma that can mimic a cyst. As you can see, it is very hypovascular, homogeneous, with clear borders and low density, just like a renal cyst. The next one. Next, please. And the chromophobe RCC, the enhancement of chromophobe RCC often homogeneous and less intense than in clear cell carcinoma, but it is more than in papillary carcinoma. Next, please. And the main role of CT is to distinguish tumor from pseudotumors, benign from malignant, subtyping the tumor, characterizing contrast enhancement pattern, assessing involvement of adjacent structures, and for lesions monitoring. Next, please. MRI is prescribed in that conditions where there are contradictions to contrast-enhanced CT. for better characterization of indeterminate lesions, for local staging, and for special population. Those are young patients and those needing multiple follow-ups. Next, please. Going to nuclear medicine, I want to talk about two radiotracers that have very limited role in primary assessing of RCCs, but they are widely using for staging and for their predictive value. And the first one is FDG PET-CT with, as I mentioned, limited role in primary RCC, but widely used for staging. And its predictive value is very important, especially for assessing outcomes from TKI therapies. Next, please. And zirconium-89 bevacizumab is a PET radiotracer that combines the monoclonal antibody bevacizumab with targets VEGF-A with positron-emitting isotope zirconium-89, and it allows non-invasive imaging of tumor angiogenesis and VEGF expression across the whole body. Next, please. After intravenous injection, optimal imaging is typically performed 4 or 5 days later to achieve the best tumor to background contrast. And this technique is valuable for evaluating tumor angiogenesis and heterogeneity, for therapy monitoring, for patient selection, predict which tumors may respond to VEGF therapies. But its availability is limited and it used mostly in research programs and clinical trials. And in conclusion, the widespread use of imaging has led to more frequent detection of small renal masses. Radiology is at the heart of their evaluation, helping guide diagnosis, management, and follow-up. However, distinguishing benign from malignant lesions can still be challenging and often requires a multimodality approach. And ultimately, the best outcomes are achieved through close collaboration between radiologists, urologists, and pathologists. And the next, please. And when we talk about small renal masses, the lesions themselves may be tiny, but the decisions surrounding them are anything but small. Radiology allows us to see small, detecting subtle findings in precision, but it also challenges us to think big, to consider the wider impact on diagnosis, treatment options, and ultimately patient outcomes. This phrase captures the essence of our role as radiologists, attention to detail with the vision for the bigger picture. So see small, think big, and thank you for your attention. Small renal masses are cysts, angiomyolipomas, oncocytomas, and renal cell carcinomas. So since cysts are common, benign, and typically easy to characterize,
Hello again and welcome back. I hope you can hear me well. I would like to say that we had a slight change in our schedule. We would ask Dr. Padraig O'Malley to continue the presentation after the panel discussion. And as our panelists are here, I would like to ask them to join and be here. Yes, I'm bringing Dr. O'Malley, welcome. We're very here that you can make it here now, and I will just ask that after the panel discussion, we will hear your presentation, but we will just start with the presentation. And for that, let me introduce our panelists. Our panelist would be Dr. Maite Burlon. She's an associate professor and head of the Urologic Oncology Clínica do Instituto Nacional de Ciências Médicas y Nutrición Salvador Zubrián, director of the Genitourinary Cancers Program at Universidad Nacional Autónoma de Mexico, and chair of the ASCO Ideas Steering Group. Our panel discussion will be on small renal masses and focal approaches. And Dr. Maite is here, Dr. O'Malley is here, and Dr. Armina, I think, is here. I'll try to join her as well. Dr. Maite, I'm bringing the floor to you as you are the chair of the panel discussion and giving to you.
Thank you very much for the opportunity to be today with OncoDaily, leading this discussion about small renal masses. So I think it has become very multidisciplinary during the last years. And the first things I would like to ask you, both of you, is how do you deal with small renal masses? Do you have a special tumor board to discuss every cases? Did you get in touch with the radiation interventional radiology specialists, urologists, the medical oncologists? How's the way you run small masses in your clinic? Dr. Mali, do you want to go ahead?
Sure, yeah. Set tumor board. All renal masses, it's more on a provider basis. We do have oncologists that we work with quite a lot who reads a lot of these that help. And we also have a very good IR team that helps with biopsies if we proceed with that.
Dr. Videjan, would you want to express how do you deal with small renal masses? Is that something that's run on the urologist clinic, or do you interact with other specialists?
we don't have dedicated consiliums about small renal masses, but we can make some meetings with urologists and pathologists for some individual cases.
Great. So the next question, we had to prepare some slides, but we had trouble showing them, is whenever you have small renal mass, thinking about a case having a 1 centimeter with hyperenhancement on the CT scan, what do you think about? I mean, that's small information, but we usually think about the age, functional status, kidney function, family history, follow-up. Would you like to express what are the key factors you see on every single case whenever you analyze a case regarding small renal mass? Dr. Vajiodan, go ahead, and I'll go afterwards with Dr. O'Malley.
Is the question is dedicated to me?
Yeah. So whenever you see a patient in clinic, besides knowing, the tumor size, the characteristic of the renal mass on the CT scan or the MRI, what are the key factors you're thinking about in your patients? It's just age, functional status, kidney function, life expectancy. Please let us know what the key characteristics of each clinical case that you always think about when assessing a small renal cell mass.
For small renal masses, despite of the radiological characteristic, the other important things we have to know about patients is the gender, is the age of the patient, the renal inflammation diseases in anamnesis, some renal injuries, maybe traumas, and anamnestic factors like that.
Do you think about, a genetic counseling whenever you're seeing bilateral masses? Is that something that's concerning, and that's something you always assess on every single case?
Yes, of course. If we see bilateral multifocal lesions, we have to check the genetic factors, like are there any cases on familiars, so like von Hippel-Lindau or something like that.
And then I'll go to Dr. O'Malley. I think we have all mentioned that we always see, the age of the patient and life expectancy. Is there any geriatric tool you use to assess functional status in these patients? Is that something you do clinically? How do you assess all these functional status, life expectancy, and the cutoff of a certain age at which you will be more prone to do surveillance rather than an active treatment for these patients?
Yeah, so the functional status, age and comorbidities, unfortunately, is not great calculators that do a very good job of objectively assessing that to allow us to sort of clinically stratify patients. I do think it is a big part of who we decide may need intervention versus those who may be candidates for surveillance. So it's probably a big area of need in this primarily where we end up stratifying patients is based on their fitness and their comorbidities and the performance status. But I don't think a lot of the performance status sort of scores that we use in advanced disease aren't really pertinent.
So another question that comes usually during the chat and over, the meeting has come, how do you deal with anxiety? We usually reassure patients that, a mass less than 3 centimeters is unlikely to have metastatic disease, but we all know that there's, a percentage according to the characteristics that they may have, or an RCC or other, pathology. How do you address anxiety in your patients, and how are you dealing with this in clinic on an everyday basis? Do you want to go ahead, Dr. O'Malley?
If you could repeat it again, I'm sorry.
No problem. So absolutely, we were explaining that usually we reassure patients, and I'm going to go with you if he cannot reconnect, Dr. Badietan. We oftentimes, assess these masses, that there's a high likelihood that they will never have metastatic disease, right? We know that less than 3 centimeters is unlikely that they will even have metastatic disease, but they can harbor, RCC pathology, or they can have non-clear cell RCC. So there's oftentimes a lot of anxiety in the patients when giving the diagnosis and letting them know that we're not going to biopsy, that we're going to do surveillance, or we're going to treat. How do you deal with anxiety on an everyday basis in your clinic?
Because of in Armenia, this kind of questions are dedicated to clinicians, to urologists. I don't have that connection like that with my patients. I just write a report, and then he'll go further to his clinicist to plan treatment and biopsy or surgery.
So I'm going to go ahead and explain a little bit what we've seen. Usually it depends a lot on the age. Sometimes when they're very old, they're not so anxious because we have explained it that that's unlikely to be malignant in the long term. And if it is malignant, it's not going to harm them. So sometimes we see more anxiety, in these young people coming in with these masses and having all these issues regarding that at some point they're going to need surgery. At some point, these are going to grow enough that they're going to undergo a biopsy. So we usually try to reassure them, regarding that the probability of metastasis is almost zero. And even if they have, any RCC case, and if they're having, a malignancy, it's unlikely that it's going to grow very fast. So we usually try to reassure them with that data, which is that their likelihood of metastatic disease is very low. So welcome back, Dr. O'Malley. We were just speaking about, explaining the patient that they're going to undergo surveillance. We usually explain them that the likelihood of metastatic disease with a mass less than 3 centimeters is going to be very low. And even if they have, malignancy like renal cell carcinoma, clear cell or non-clear cell, the probability of having, harm from that neoplasm is very low. Can you let us know a little bit, in your experience, how you deal with anxiety on clinic on an everyday basis?
Yeah, so I mean, as you said, all the long-term data from both, longer-term cohorts like the DISSRM and the Toronto cohorts show that the metastatic, rate is extremely low, right? Less than 2% for those with 3 centimeters or less, and even for larger masses, it's still quite low up to a certain point. The biggest driver in patients sort of undergoing delayed intervention tends to be growth rate, and a lot of that's driven by anxiety. I think it's not a knowledge gap, but it's a big part of the influence the physician has over what patients end up doing. If your physician's not comfortable with surveillance, then no patient's going to select that. Patients already have anxiety, and that's the biggest driver in a lot of patient surveys of why they proceed with treatment. So you really have to reiterate that data to them that sort of shows that long-term, this is a very safe strategy. And there's even data for younger patients that it can be so. But knowing that, that nothing's absolute, but, the oncological outcomes with surgery are not absolute either. So, I think it takes a lot of effort on our parts to address that, but it definitely is a lot of effort.
Thanks so much. So our next question was, how do you assure your patients are going to get an adequate follow-ups? Sometimes we know that these patients need imaging every other month or on a regular basis, and then we want to have consistency, right? We want to have consistency on that the radiologist and the team that's seeing that same lesion is assessing that same lesion again. How do you do it? I mean, how do you assure that the follow-up is going to be on time and it's going to be accurate and the comparisons are going to be fair, to interpret that adequately and to, make a decision on accurate data? Can you explain us a little bit on your experience regarding follow-up?
So I think a lot of the sort of adherence and compliance and ensuring patients do well with surveillance is education right at the initial point. The better you educate the patients at the beginning, the more compliant, the easier they are going to understand why they need imaging and when they need to get it. So I think that's a big part, is making sure the patient knows when they need to do their imaging as well. And then we generally tend to order it at the time we're seeing them, for in 6 months' time or in a year's time or whenever. And a lot of times we would like to try and do that the same day that I'm going to see them back. So that way it's one day of their schedule. It's very convenient for patients. That obviously isn't practical in some health centers. For us, fortunately, it is. I'm always going to look at the images myself anyways. And so that makes it easier for me not to wait for the radiology report necessarily. But I think educating the patients goes a long way to ensuring that they get their imaging done on time.
And I'm going to go through quality of life. Sometimes we go through these unfair comparisons that we have. We know that surgery may have less recurrences, but we know that non-interventional or non-surgical strategies like ablation may have, less burden in terms of pain or regret. So how do you explain to your patients the differences in doing quality of life and interventional radiology intervention or surgery? Is there any way you can really address to them how do you think their quality of life is going to be with these different options?
So I usually lay the groundwork for most of these patients that, look, there are multiple management options. The good news is no matter which one you choose, you'll probably do very well. The bad news is you kind of have to choose one to start with. Most of the long-term quality of life data actually says that quality of life is fairly similar whether you have an intervention or you have surveillance. So in the long term, it's not a big difference. The question for most individual patients is going to be, which risks are they better able to tolerate themselves as an individual? So are they happier having no anxiety because they had their tumor removed, having this pain of having surgery and recover from that? Or are they better managing the risk of not having surgery, not having the pain that goes with that, and continuing to follow it and monitor it? So that's a very individualized thing for each patient. I often tell them, most times this is an area where a lot of patients refer to this sort of more patriarchal medical sort of environment. They're like, well, what would you do, Doc? And I tell them, my mother and my father, they're very healthy, but they are also, very educated. They would choose two different things because they're different people. And so it's not one shoe fits all. It's very dependent on that individual, what they want. And so you really have to drill down on what things are important to them to help them decide which one of those options is going to be best for them. So again, it's a lot of education, but doing it up front will set the stage for success, whether they do intervention or surveillance, because they'll have chosen the right thing for them.
Thanks so much for that helpful insight. And regarding, imaging options, we have reviewed, mostly, the CT scan, MRI. any insights of what you think the role of PET-CT could be in this scenario? Is there any radiopharmaceutical that you think could help us, better define these lesions, or you think we're done with CT and MRI?
So I think with CT and MRI, there's a lot of work in radiomics right now to try and help with this. So I think we'll see that will continue to improve. We have also used ultrasound in several centers, and most of the guidelines with the established surveillance programs use ultrasound as well as CT and MRI. PET scan obviously is very attractive because the thought is that maybe the increased avidity also reflects the characteristics of the biology. We don't have any data to support that in the small renal mass. We know PET imaging with FDG PET is very sort of hit or miss with more advanced kidney cancers, although it tends to be that if they're more aggressive, they may have more avidity. We don't know that for small renal masses. Obviously, new PETs like girentuximab, we wait to see, and I think people have a lot of optimism that that will sort of maybe give us some insight into the biology of these tumors. We have really used growth rate on the axial imaging as the predictor of biological aggressiveness. And if you look at most of the data, that's probably very inaccurate and wrong to do, because the growth rates actually don't predict biological outcomes for these small renal masses. Whether or not the PET activity does will be interesting to see, particularly with newer agents like girentuximab. Obviously, that's only going to work for clear cell and not for other non-clear cell histologies. But I think we'll see more and more agents coming out that help us address that in those other non-clear cell histologies too.
Thanks so much. And we have a question from the chat, which I want to address. Is there any particular guideline that you use for this intervention? Are you prone to use AUA guidelines or any other, algorithm that's published, or do you use more, all this information and get the best of every guideline to make your decisions?
Yeah, it's a combination. I think, most of the guidelines are all fairly reasonable. NCCN has guidelines. I generally tend to use those over AUA on a day-to-day basis for most things. The EAU also has some really well-driven, evidence-based driven guidelines. And so I think those are a little more nuanced sometimes than the AUA ones are. Fortunately, in this space, because patients are going to do very well regardless, I think, all those guidelines are reasonably used in a day-to-day practice setting. But I tend to skew more towards NCCN and maybe EAU for those.
And can you let us know a little bit about, these small renal masses? Is this something that's still seen in the community practice, or are they sent to specialized clinics in your experience? What's going on with these patients? Are they getting referred more to tertiary care centers than being seen in the community?
Yeah, I think there's a shift in urology in the United States a bit. And so I think we're seeing less and less community physicians doing those in more rural areas or less urban and dense areas. There are some large practice groups in more urban areas that you have people who are essentially private practice. But many of these patients are very well trained and have great knowledge of small renal masses. So I think there's some ebbs and flows, but I think we do see a large number of these, but a large number are seen in the community. I think the options offered in the community sometimes are not as well explored. The practice model is different, and the practices they have are different than what we have in an academic setting. We certainly do see a large number of these patients, and it is a growing number, obviously, because the incidence continues to rise. Will that shift entirely to academic centers? I don't think so. Most of your surveillance you're going to see is going to be more in academic centers because they have a better maybe infrastructure or the research background for that. But it can be done in any practice, really.
Well, thanks so much. I think we're running out of time. I think it was a wonderful session. I think, we need to think about which is the imaging strategy. I think more and more we're going to get incidental cases that these people that are not getting an imaging because of a kidney problem, but for other issues are getting this diagnosis. So I think, our incidence of this type of neoplasm is going to go up. I think, radiation is key. I think we now have more and more options to treat these patients, interventional radiology, urology, and then radiation therapy with SBRT are all promising options. So I think we have a brilliant future, to give more tailored treatment to our patients. I mean, not all patients needs exactly the same treatment as Dr. O'Malley explained today. So I'm very grateful to have you here today. I'm very grateful for OncoDaily for this invitation. And since we're out of time, I'll let you go to the next session. Thank you very much, Amelia.
Thank you so much,
Thank you
Dr.
all.
Maite, for being here with us and leading this excellent discussion, indeed, in this very important topic. Hopefully, after the end, we will have the paper on the key recommendations, and all of the recommendations you spoke just will be included in it. And thank you for chairing the session. I think I'll pass the floor to Dr. O'Malley. Dr. Frederick O'Malley is Chief of Urologic Oncology, is the Clinical Assistant Professor of the University of Florida, Department of Urology. And I'll just share the slides and leave the floor to you.
Okay, this is basically just my talk a little bit about active surveillance and patient selection and protocols. I think if you actually play it, I pre-recorded it, so you could probably put it in a presentation mode, and it may just play the presentation, the volume, and everything for you. Let me try that. So, is there any way for me to control the slides, or no? Okay, so kidney cancer, it's the most common, one of the most common cancers worldwide. Certainly in the United States where I practice, it's one of the top 10 most common cancers. Globally, we see the incidences rising. There's almost 500,000 new cases globally in 2022, the last year of global data for. The majority of these are clear cells, but about about half to 2/3 of new diagnosed masses are actually small renal masses. And those are masses that are less than 4 centimeters. Next slide. So the outline, we're just going to talk a little bit about goals of management of surveillance, and to understand that, we also have to understand the rationale and the natural history, and then we'll touch a little bit on the future direction and some of the protocols that exist out there. Next slide. So, the goals for most patients are to avoid death or be cured. Those are not always the exact same, right? So for older patients, many of them are quite happy to live with a cancer as long as it's not going to shorten the lifespan. And so for them, their real goal is avoiding death. Younger patients, because they have a larger lead time in front of them, most of them will need to be cured in order to avoid death. The second thing that's a big driver in what they're they want to do as far as management is really avoiding complications and trying to avoid an impact on the quality of life. So these are really the key things when you explore what patients are looking for and what the management strategies they're going to pursue. Next slide. So unfortunately, some of these are animated, but basically there's two axes here. One is diagnostic and the other is therapeutic. And those are sort of the management strategies can be explored along those two sort of axes. Active surveillance, by and of itself has the least diagnostic and least therapeutic benefits. You don't necessarily know if it's cancer or not, and it certainly isn't going to treat it. But it is definitely the least invasive of all the options, and so it can be very attractive in certain patient populations. Biopsy obviously is diagnostic, but it's no therapeutic benefit, but it is non-invasive. It's probably underutilized in this space, but it is a good technology. Ablative techniques, there's sort of two groups here, the classic, which are thermal-based, such as RFA and cryo, and the newer sort of modalities we've seen like radiation, such as stereotactic ablative body radiotherapy, or SBRT as it's sometimes called in North America. These, generally speaking, tend to be less invasive when compared to surgery. And by and of themselves, they are not diagnostic. They certainly are therapeutic, and often actually they work extremely well. They can be coupled with diagnostic modalities such as biopsy. So most guidelines recommend for the classic ablative techniques that they be coupled with the biopsy at the time. Radiation, it's been done before and after radiation in some cohorts. The current IROC guidelines sort of do not recommend routine biopsy for all masses undergoing radiation, and that seems reasonable in that setting. Surgery is the most invasive. And this is also the most diagnostic and therapeutic as far as you know exactly what you're dealing with. And you'll also have the best cure rate with this. Whether or not you need to use a hammer when you could just push something is a point of debate. But these are sort of the management options for small renal mass. And thinking about them in the sort of diagnostic and therapeutic capacities helps to frame them for discussion with patients. Next slide. So patient considerations, as I mentioned, diagnostic isn't a consideration. They want to know, is it cancer or not? Therapeutic is by far and away the biggest driver of what they will elect to do. And then it's sort of coupled with the cost. And the cost here is, in most cases, we're talking about complications and side effects and quality of life. In some healthcare systems, it's also a financial consideration, depending on where you practice. And then time. How much time am I going to be off work? How much time does it take to do these treatments? You know, for instance, radiation, if it's for prostate or other cancers, it can be, 5 days a week for multiple weeks. For radiation for kidney cancer, it's very nice. It's, 1 to 3 sessions. It's not time consuming. Surgery, you come in the day of surgery, most patients go home the next day. But, ablations, you get the treatment done, you're home the same day. So patients, when they're considering these, they often weigh the therapeutic benefits of treatments and the impact on quality of life is the most important. And they weigh this far more over knowing whether it's cancer or not when they're first diagnosed. Next slide. So in order to understand, the rationale for surveillance and why this makes sense, we want to look at a couple of key aspects of these masses, primarily their natural history. So, what is the rates of metastatic disease in these patients? What's the rate of death? How quickly do these grow? Is that reflective of the biological properties? And then what are the interventions? What's the rate of those? When do those occur? And then how does this impact quality of life? Next slide. So if you look at the risk of metastatic disease, this is a retrospective study that's done in Sloan Kettering by Hunter Thompson and Paul Russo back in 2009, looked at about almost 3,000 patients at Sloan Kettering who were treated for kidney cancer, and it looks at the rate of metastatic disease at diagnosis. And what's important to realize here is that if you had a mass less than 3 centimeters at diagnosis, your rate of having metastatic disease at presentation was 0. Okay, so it goes up slightly as these masses get bigger, but 3 to 4 centimeters is less than 2%. But even when we go above that 4 centimeter cutoff that we often use for surveillance or ablative technologies, it's not a dramatic rise. And I'll show you some data from larger masses and surveillance for those. But the risk of metastatic disease does go up slowly, but surely. Once you get above 7 centimeters or 6 centimeters, it starts to go up more exponentially. So there are some patients you can watch with even larger masses. But generally speaking, the reason we are comfortable with surveillance is that we know we have some wiggle room, and we know that the rates of mets in these small masses is very low to begin with. Next slide. So that study by Sloan Kettering led to some further studies. This was probably one of the landmark studies, I think, for active surveillance in kidney cancer. It was a multi-center phase 2 single-arm trial out of Canada, run by 2 of my mentors, Michael Jewett and Tony Finelli. And this looked at 178 patients with 209 masses. And they showed that the average growth of these masses is very, very low, right? So when we follow these patients, they noticed about a 1 millimeter growth per year. And a number of these patients did have biopsy, a number did not. Of those who did have biopsies, if they had cancer on the biopsy, 10% of those patients actually had a decrease in the size of the mass. So not even just a leveling, but a decrease in the size. So some of these do regress, but it also shows us that growth rate may not always be representative of the biology. Interesting in this study, there was only 2 patients that developed metastatic disease over the follow-up of the study. One of these was actually diagnosed at 12 months on a chest x-ray, and this patient actually did not have a chest x-ray on entry into the study. If you look at the long-term data, which comes from the Canadian Kidney Cancer Registry, CKIS, the 5-year metastatic rate of patients on surveillance in Canada is only about 2.3%. So consistently has shown over time that it's a very low rate of poor outcomes. Next slide. So long-term active surveillance cohorts, we talked about the sort of Canadian experience. This is probably the other big, large prospective cohort for active surveillance in renal masses. This is the later intervention and surveillance of small renal masses, which has been really spearheaded by Philip Perazio. And they just published their 12-year outcomes this summer, almost 1,000 patients. They did note that the overall survival was lower in the surveillance cohort versus those who had primary intervention. But it was clear that this really reflected non-kidney cancer causes of mortality. If you look at the bottom figure there, you can see that the risk of METs and the cumulative incidence of METs in those who had primary intervention versus surveillance was no different. And in total, out of almost 1,000 patients, only 3 patients in this study over a 12-year span actually died from kidney cancer. 2 were actually in the primary intervention arm, and only 1 was in the active surveillance arm. As opposed to that, 111 patients died from other causes. So this points out the importance of competing risk when considering strategies for these patients. how likely are they to die from other medical causes or just from life itself? Next slide. So this is these are data from two moderate-sized cohorts. One from Sloan Kettering, about 70 patients with masses above 4 centimeters. On average, these were about 5.7. I think they show that growth rate in these larger masses is higher. Those that had metastatic disease at presentation that was surveyed in this cohort had an even higher growth rate, again suggesting maybe growth kinetics are representative of biology. The bottom study is a patient cohort of about 81 patients at Queen's University in Ontario. And they showed that the 5-year cancer mortality, even in these larger masses, was still quite low in the grand scheme. It's only about 6%, whereas their mortality from other causes was much higher at 22%. And again, they showed similar sort of, increased growth rates compared to the small renal masses. But even in these larger masses in this cohort, up to 20% actually had no growth or had negative growth. So, we do see some of these larger masses will regress as well. Next slide. And so growth rate, this keeps coming up, is growth rate indicative of biology? We know that these grow slowly. So between the DISSRM and the Canadian cohorts, the growth rate's about 1 to 1.5 millimeters per year. I quote my patients about 1 to 2 millimeters a year. A significant portion you can see out of that DISSRM study with 500 patients there on the top right waterfall plot. 100 patients had actually decreasing growth or stable growth. The bottom figures are from a follow-up study from the Toronto cohort by Finelli, and it shows that based on histology, that clear cell tumors do appear to have faster growth rates, but the growth rate alone is not predictive of the subtype. So you can't say, oh, it's growing faster, it's more likely to clear cell. That does not pan out. But the question then still remains, is growth predictor of aggressiveness or biological potential? Next slide. So this is a study from the DSSRM, which, if you remember, it's delayed intervention. So, they did monitor these patients even after they had interventions, if they had them after the enrollment in the registry. Intervention obviously increases over time, but to a finite degree, right? So, no matter the size, although it's higher in those with larger masses greater than 3 centimeters, it never really seems to get above the 30% in this registry. Most of those patients who do undergo delayed intervention, but in the early setting, i.e. within 2 years of starting on surveillance, tend to do so because of this growth rate factor, right? And so these are patients you can see in the bottom waterfall plot. Those patients who had a growth rate greater than 0.5 centimeters per year were those who were most likely to undergo delayed intervention in that early setting. So again, the question is, and we keep alluding to this, and it's people sort of use this, is growth rate, equivalent to biological potential? And I think I'm going to show you, hopefully, the next slide, why that may not be accurate. Next slide. So, unfortunately, this pop-up box blocks the top figure, but there's been several meta-analyses that have been done looking at the outcomes, the oncological outcomes in patients on surveillance versus the primary interventions. In all of these meta-analysis and studies, there's been excellent oncological outcomes for patients on surveillance. It is clear from the data in these that there is a lower rate of local progression, i.e. growth, if you've had surgery or ablation or some intervention than if you just watch this. That makes sense. And several series have demonstrated differences in survival, but all of these have alluded to the fact that it's most likely due to patient selection and medical comorbidities or competing risk rather than due to the intervention. And across all these studies in the meta-analysis and prospective studies like the one on the right here, there's no significant differences independent of growth kinetics in progression of metastatic disease and cancer-related deaths. So patients who undergo interventions do not have a lower rate of progression of metastatic disease and do not have a lower rate of cancer-related deaths. So many patients, even if they have a larger growth rate or a faster growth rate, they may have no different biological outcomes. So growth predicts intervention, but it doesn't appear to predict biology or the cancer outcomes. Next slide. So complications, quality of life. The complication rate is clearly lowest with active surveillance. It's still not zero, right? You take a Tylenol, there's potential side effects. The same with active surveillance. Although you're not doing something, there are still potential side effects. I will say the interventional management strategies you use in kidney cancer generally speaking, are all quite good, and they all really have a very low rate of severe complications. You can see the highest being partial nephrectomy is only about 5.6. I do a lot of bladder cancer. I can tell you the complication rates for surgeries for those types of diseases are much higher. And so, the overall complication rate is lowest in active surveillance, but overall across all modalities, it is quite low. And so patients really do well regardless of which treatment option they pick. If you look at it from a public health standpoint, the cost-effective analysis seems to suggest active surveillance is probably the best approach to manage all small renal masses. But in fairness, it does not account for cultural or system designs or differences. And it also doesn't speak to what's best for your individual patient sitting in front of you. And that's important to keep in mind. Next slide. So where we are, we've talked about the oncological outcomes are extremely good. Interventions have complication rates, but they are low. One thing to keep in mind with any patient on surveillance is that when they see you the first time, they are not going to become more treatable down the road. That is important, but not the be-all and end-all. But it's important to keep that in mind. So are there other ways we can risk stratify patients and determine which ones are really going to benefit the most from intervention versus surveillance? So next slide. And so that comes down to patient selection. Who do we select for surveillance? If you look across a number of studies and patients who are eligible for active surveillance, only about 10 to 20% of patients who are candidates actually choose active surveillance. Now, a lot of that is put down to be due to a knowledge gap, but there's a nice study done by Geneviève Charbonneau in Quebec. And in that study, 80% of the patients involved in that study had education beyond high school, so college, trade school, university. So even in a highly educated population, the rate of uptake of active surveillance was still very low. And the main drivers in that study were really due to anxieties patients had about not treating it and basically what their physicians recommended. So a lot of this is us being comfortable with it in order to impart that comfort to our patients. Age obviously is a big part of this. Oftentimes age is used as a surrogate for competing risk. That's not always the case. Most cohorts in the surveillance with long-term data are sort of in the mid-late 60s as far as the median age. Originally it started off older and we've moved it to younger patients. There are two studies, one from Meredith Metcalf in the United States and one from Douglas Chung in Toronto, looking at surveillance in younger patients. It certainly appears on the early midterm data that it is quite safe, but there is going to be a higher rate of delayed intervention as you would expect. At a minimum, it's going to be 20%. So in some ways, this may just be kicking the can down the road for some of these patients, but that may be appropriate in certain circumstances. Next slide. So I think what we'll see going forward is that we're going to try and use different strategies to tease out who's going to be the best patients to select for surveillance. And I think a lot of this is going to come down to sort of genomics and biomarkers. This is a nice study from 2018 called TracerRx Renal. And this looked at sort of the genomic evolutionary pathways of different renal masses. And you can see in what's highlighted in red here is that those patients on the right of this first figure, on the bottom, tumor size, these are patients who had the lowest or the smallest renal masses compared to those that are darker, which are larger masses. All these small renal masses all appear to have very low intratumoral heterogeneity, right? They're not a very mixed population of cells. They're all spatially and temporally very similar. They have low amounts of genomic instability. And most of these seem to be driven by sort of a single VHL mutation. They don't have subsequent or additional mutations such as BAP1 or PBRM1. So they really seem to be these VHL monodriver mutations. The figure on the right kind of shows how that plays out as far as the heterogeneity. Those plots on the left-hand side show the sort of varying populations seen in more aggressive and more advanced cancers. They're much more sort of complex trees of evolution, whereas those on the right are the small renal masses and they're much more linear, single node evolutionary pathways. So these tumors are much less complex than the larger masses we see. And so these may be ways we can tease out who maybe needs interventions. Next slide. So biomarkers, obviously this is a hot topic in medicine as a whole. One of the hottest is circulating tumor DNA. Circulating tumor DNA for a number of reasons is not a great biomarker in kidney cancer. There are ways we can tweak it that there are some preliminary data that shows that maybe we can get around some of those workarounds. But I think it's still going to really be restricted to advanced disease setting. I think because of the ways we have to treat it, it really won't be applicable for the small renal masses. There has been some preliminary work done on urinary biomarkers such as methylated genomes and miRNA, but there has been very few follow-up studies on this. So that's sort of, I think, an area of exploration that's under investigation. Radiomics, I think, is one where the couple of artificial intelligence with imaging features. People have tried using imaging to predict histology. It's never panned out very well, but artificial intelligence may give us a way to overcome those limitations. As was discussed in the sort of panel discussion, PET imaging, not used now, nor should it be, but I think the use of things like girentuximab in the future may be a promising modality that we may be able to use to risk stratify patients. Ultimately, all these biomarkers, as I said, are used to really try and tease out those bad actors and better select patients for intervention and better select patients for surveillance. One limitation is going to be is that the adverse oncological outcomes are extremely rare in this population. They do so well, and the lead time to those events is actually usually quite long, that it's going to take a long time before we have data which actually is clinically likely to change what we do. So I think we're going to be behind a bit in this space before we have good tools to sort of risk stratify patients, but I think eventually we'll get there. Next slide. So who and how to survey? For the most part, it's really a magic box of age and comorbidities. As I mentioned in the discussion, there's not really any great validated calculators or tools to really weigh these two components against their sort of this disease specific for that patient or the intervention specific for that patient. Generally speaking, younger and fitter patients, I will offer them surveillance, but there is an expectation realization that the risk of needing a delayed intervention is significantly higher. It's going to be at least 30% or higher. Older medically comorbid patients, I do offer it to all. Most of these patients, their biggest reason for not wanting to do it is anxiety. So, initially I repeat the imaging, the confirmatory imaging within sort of 6 months. If they have anxiety, we may move to that to 3 months and tell them that, if we select surveillance now, it doesn't mean that we're committed to that forever. We can change our plan down the road. And that usually gets them over that first initial hump. Once they come back at 3 months and their scan hasn't changed at all, a large number of them really say, well, I'll just come back in 6 months from that scan. I'm like, okay. They don't need it that frequently, but it helps them with that anxiety they have, and it's a good treatment option for them. I think it's not unreasonable. But generally after confirmatory imaging, I usually do annually thereafter. Next slide. So there are a number of active surveillance protocols out there. DSSRM actually in the supplemental material, the recent publication from this summer, they did publish their sort of algorithm. I think it's quite reasonable. NCCN has some guidelines. Hopkins and Toronto have some well-established surveillance cohorts as well, and have their own sort of nuanced protocols. Some of those are modified over time depending on some of the other studies with imaging they've been doing. All of these surveillance protocols have confirmatory imaging within 6 months. It's pretty standard. All recommend the use of ultrasound, CT, or MRI. Depending on the situation, one may be more appropriate than others. I like using MRIs, for example, for cystic renal masses, some we didn't really talk about in this setting. Ultrasound can be great for patients with medical comorbidities. PET imaging is not listed here, and it really shouldn't be used in this setting at this time. Next slide. And I think that maybe, yeah, there we go. So thank you very much for OncoDaily and to Dr. McKay and Dr. Ürün for the opportunity to speak to you about this. And hopefully that's given you some good information to take into practice for yourselves. Thank you.
Thank you, Dr. O'Malley, for this wonderful presentation and indeed in this important topic. Of course, the panel discussion and later on your presentation put on everything. So this is not an easy topic, I think, neither for a patient nor for an oncologist, because there is not one way to go and you have to weigh out a lot of factors, but you have explained us very nicely. Thanks a lot for accepting our invitation and being with us today. We value a lot. And
thank you. Sorry about the connection, the IT issues earlier. Sorry about that.
No problem. At the end, you made it very well. Thanks. And we're going to move on to our next speaker. recorded video again. We will have Dr. Mariam Soleimani from Canada, who is a clinical assistant professor at University of British Columbia, Division of Medical Oncology, Medical Oncologist BC Cancer at Vancouver Center. And I will have the floor to her to discuss.
Hi, everyone. My name is Mariam Soleimani. I'm a medical oncologist at the BC Cancer Vancouver Cancer Centre here in Vancouver, Canada, and a clinical assistant professor at the University of British Columbia. I'm sorry I'm not able to join the event live today, but I'm delighted to speak with you about the important role of specialized VHL clinics. These are my disclosures. I'd like to spend some time today reviewing the clinical features and the genetic basis of von Hippel-Lindau disease, understand the challenges of managing VHL across multiple organ systems, especially in this new and exciting era of belzutifan, explain the role and the benefits of specialized multidisciplinary VHL clinics, and recognize the need for increased access to and awareness of specialized care. VHL disease really is a success story of oncology. It was only in 2001 that the relationship between the VHL protein and HIF-alpha was identified, and 2021, belzutifan was the first drug approved for VHL disease that directly targeted this pathway. VHL disease is an autosomal dominant hereditary cancer predisposition syndrome with an incidence of 1 in 36,000. It results in multi-organ tumor development, as you can see from the graphic here, and is a result of mutations in the VHL tumor suppressor gene on chromosome 3p25. Even within a family with the same genotype, there is significant phenotypic heterogeneity in the manifestations of the disease, and this is not completely well understood. VHL care is complex and starts from infancy to death, and guidelines exist for both surveillance and management. Let's talk a little bit about diagnostics. VHL disease is a clinical diagnosis that should be confirmed through genetic testing. So about 80% of cases, patients will have a clear family history of VHL, and so the presence of one typified lesion is sufficient for the diagnosis, which should then be confirmed by genetic testing. About 20% of cases are what we refer to as de novo VHL, meaning that there's no family history, and in these patients, the presence of two typified lesions is sufficient for diagnosis, which again should be confirmed through germline testing. These are clinical practice guidelines for surveillance in VHL disease. And as you can see, surveillance starts in childhood at age less than 5 in infancy and continues on into the 6th decade of life. VHL has an age-dependent near complete penetrance. So usually by the 6th decade of life, the full manifestations of the disease have been seen, and so certain aspects of surveillance can be discontinued. There are also important implications for pregnancy, which I will not be covering today. Management guidelines also exist in terms of addressing organ-specific manifestations. But one of the challenges that we face in VHL disease is that there's low adherence to guidelines and standard of care practice, which unfortunately leads to reactive management as opposed to proactive care. Current challenges include the fact that this really is a multi-organ, multidisciplinary disease, and tumors can occur at any age and repetitively. So it's important to know a patient's history and to be very familiar with their case. There's a lot of coordination that's required between specialists to address the disease as a whole, and this can be very challenging to coordinate. There's a lack of awareness about the disease, about management and surveillance guidelines, and this can unfortunately lead to delays in diagnosis and treatment. And there's a fair bit of psychosocial distress that patients unfortunately experience, not just because of their lived experience with VHL, but also the amount of self-advocacy that they have to do to seek care at specialized centers with teams that know what this disease is all about. So let's switch focus to talk specifically about renal masses. This was seminal work in 2004, which really identified for us the size cutoff that is used to intervene surgically. 3 centimeters is the size cutoff that we use that allows us to balance the risks of surgery and the ability to perform nephron-sparing procedures while reducing the risk of metastatic spread. So, if a renal mass is identified on imaging and it is 3 centimeters or larger, patients should be seen by a surgeon for ablation, for surgery, or for ablation. If a lesion is less than 3 centimeters in size, it needs to be followed closely, particularly if this is the first time the lesion is identified and we're not sure what its growth trajectory is. Close MRI surveillance is undertaken to better understand the growth trajectory to help guide decisions. So if a lesion is growing at a rate of 5 millimeters or more, you may want to be monitoring that much more closely. On the other hand, if the growth trajectory is more indolent, perhaps every 6-month imaging is sufficient until you establish its behavior. But it's important to not only look at the size of lesions, the rate of growth of lesions, but also the appearance of lesions. These are often very complex, mixed, solid, and cystic lesions that can look quite unusual. And so having access to radiology for review of imaging and surgical colleagues and interventional radiology colleagues to look at what is the best modality to treat this lesion is really valuable. Of course, the LightSpark 004 study has truly changed the landscape for VHL disease. In this study, 61 patients with VHL received belzutifan at the standard dose of 120 milligrams daily, and the primary endpoint was the objective response rate in RCC tumors. With updated data at 50 months of follow-up, we see that the objective response rate is 70%, most commonly partial responses, and that irrespective of the number and size of tumors, we do see quite excellent responses. As you can see from this graphic, belzutifan results in a dramatic decline in the number of local interventions that patients require, which is very much welcomed by these young patients who have to undergo many, many procedures throughout their lifetime. However, you will note from the dark black circles that there are patients who eventually develop resistance to belzutifan and require surgery for their most commonly RCCs. Why does this happen? Why do patients initially respond and then develop resistance? We don't quite understand why that is. Why is it that they develop resistance in their RCC while their central nervous system disease or their pancreatic neuroendocrine tumor continues to respond? We also don't quite know the answer to that yet. So perhaps a new algorithm in this era of belzutifan is that when a renal mass is identified on imaging and it is less than 3 centimeters, if it has a growth trajectory of more than 5 millimeters per year, not only should surveillance continue, but perhaps that is a suitable case for belzutifan. On the other hand, if a lesion is greater than or equal to 3 centimeters in size, but is not amendable to nephron-sparing surgery, perhaps systemic therapy is an option for this patient with close monitoring so that if the renal mass persists beyond 6 to 9 months of belzutifan treatment, local treatment modalities should be explored again. So it's important to understand that not all patients with VHL require belzutifan, and belzutifan is not a cure for VHL disease. However, discussions in multidisciplinary research teams can help us to achieve the best outcomes for patients. It's important to consider the overall burden of disease within and outside of the kidneys when making decisions. Consider the absolute size, the appearance of lesions, and the trajectory of growth. If urgent surgery is needed, then that should be undertaken. Belzutifan is not a replacement for urgent surgery. It's important to have discussions around how renal function will be compromised with local interventions. And of course, we shouldn't be making these decisions in silos as care providers. We should talk to patients and understand what are their priorities and make decisions in a shared decision-making model. So suffice to say that all of this new information with belzutifan and new strategies has really made VHL care more complex than ever. And multidisciplinary discussions in expert clinical care centers is absolutely critical to allow us to make the right decision for the patient at the right time. We can address this through these specialized coordinated care centers, which we know through many research studies in rare diseases improve outcomes with earlier detection and timely intervention while avoiding over and under treatment and improving adherence to guidelines. Importantly, coordinated care centers can also allow us to address an important gap, which is that transition of care from the pediatrics to the adult world. Coordinated care centers result in better patient experiences, providing psychosocial support, supporting and improving survivorship, and addressing regional and socioeconomic disparities in access to care. Finally, we're all researchers and we're passionate about that. And I think it's important for us to use this as an opportunity to create research, innovation, bring clinical trials, and develop multi-institutional and multinational research databases, which are absolutely critical, especially in the rare disease world. And there is data that actually shows us that specialized multidisciplinary clinics make a difference in VHL. This is a study that was done at a VHL clinic in Korea, and they showed that patients were grouped in three. Group 1 are those patients who attended a VHL clinic annually. Group 2 were those patients who attended once and never again. And group 3 in the orange were those patients who were never registered and attended a VHL clinic. And there were statistically significant differences in the rate of adherence to certain parameters of surveillance. Some work that we have done here at our own clinic, which was presented at GUASCO, showed that pre-connection with the VHL clinic, rates of surveillance were in fact fairly low in some parameters, but post-connection, most of those were able to be improved quite statistically significantly. And that 87% of patients actually had a change in their management plan, be that referral to a specialist for surgery or radiation or other assessment or initiation of systemic therapy. So I'd like you to take some time to reflect on what is available at your center and how could you possibly make this work for your institution. It may look very different from one place to one place, and I think it's important to start somewhere. So the first step is, of course, to establish the team. Having a program lead who oversees the flow and can identify the gaps and bring teams about is really valuable. And then it's important to address this in sort of organ-specific ways holistically. So for example, for CNS disease, neuro-oncology and neurosurgery are absolutely critical. For genetic testing, access to a genetic counselor and timely access to germline testing. For the renal and adrenal manifestations, a uro-oncologist, a medical oncologist to guide systemic therapy, and an endocrinologist is critical. Retinal disease can be truly life-changing for these patients, so prompt access to ophthalmology is really important. And though thankfully rare, pancreatic disease can be difficult, and so access to a hepatopancreatobiliary surgeon is very important. And finally, a care coordinator is really needed to bring it all together, to oversee and ensure that patients have a seamless sort of plan of longitudinal care. So this is an example of how our workflow works at our VHL clinic. There's referral and intake, at which point we review the diagnostic workup to date, review the family history and prior interventions. The case is then triaged, and at that point in time, we discuss with other team members what interventions may be required, imaging that should be done, and we confirm that the patient has had germline testing or not. The assessment is then done with the patient evaluating their surveillance, comorbidities, and discussing their priorities and expectations. An individual management plan is then developed, and our nurse navigator, who functions as our care coordinator in our clinic, then helps to streamline those referrals, provide education to patients, and to coordinate between different clinics and offices to connect them with specialists. And importantly, this model allows us to have longitudinal follow-up with patients and their family members. We can support them through family planning, which is important for these young patients. And of course, as medical oncologists, we follow them through systemic therapy if it's required with regular check-ins. So to conclude, belzutifan is not a cure for VHL disease or for localized RCC in this patient populations, and there are a lot of questions that need to be addressed. Primary versus secondary resistance in renal tumors is something that we need to better understand. We're committing these patients to indefinite treatment. Is intermittent therapy an option? Can this help to prevent resistance from developing? There's limited data on the impact of belzutifan on present and future fertility. So far, observational, anecdotal evidence suggests that it doesn't impact fertility, but we need firm data for this. And we need to better understand genotype correlations with response to belzutifan. The management of VHL disease has undoubtedly become much more complex and requires a true multidisciplinary team discussion. It's important to consider the overall burden of disease and to not look at organs in silo. Look at prior interventions and patient preferences. And for those reasons, a specialized VHL clinic is really just what makes sense. And so I hope that if your center does not have one, that this has inspired you to consider how you can implement something like this at your clinic. And if you do have one at your center, hopefully it inspires you to get involved. I'd like to thank the organizers for the exciting opportunity to present today. And thank you to the audience for your time. It's been a pleasure.
Thank you, Dr. Mariam Salamani, for a wonderful presentation. We will move for next speaker, Louis Au from Australia, GU and GI medical oncologist at Peter Mac Cancer Center. Dr. Louis also will be recording, so we can start. Thank you.
My name is Louis Au. I'm a medical oncologist and translational researcher at the Peter MacCallum Cancer Centre in Melbourne, Australia. Thank you to the organisers of VIRO 2025, and a special thank you to Rana and Yüksel for the kind invitation to speak, and of course thank you to OncoDaily. I'm not able to present live today, but I'm grateful to contribute to the program through this pre-recorded presentation. The topic today is about overcoming intratumor heterogeneity in tissue-based biomarker in clear cell renal cell carcinoma, and this is really based off work that I've started when I was a fellow in the UK and continuing here in Australia. These are my disclosures. When it comes to tissue-based biomarkers, the obvious first question to ask is, why has it been so difficult when it comes to kidney cancer when other biomarkers have yielded in other solid tumor types? But what I want to propose today is that one potential problem that is contributing to this issue in kidney cancer is the problem of sampling bias. Over the next 20 minutes, I want to talk about what sampling bias is, how it's relevant to clear cell renal cell carcinoma, and then I want to present some unpublished data on a potential solution through work that we're doing in deriving a spatially stable gene signature, which is prognostic of outcomes with potential application in the adjuvant setting. Last, I want to talk about a potential way forward in terms of clinical implementation, and also I want to spotlight what the current work has been for blood-based approaches in contrast to really understand where the field sits. So first, let's talk about sampling bias and what that is. And that really relates to the concept of intratumor heterogeneity. When solid cancers, individual tumor cells which make up the solid cancer mass are genetically slightly distinct from one another, and that really leads to the issue of sampling bias, where within this tumor mass, depending on where the biopsy needle lands, you may potentially get a different readout. And this issue of sampling bias, of course, then undermines the clinical utility of genomic medicine in cancer by reducing the sensitivity of whatever biomarker is being detected, and it can also lead to misassignment of risk or response categories. So this concept of intratumor heterogeneity and sampling bias is not new, but what we wanted to define and quantify better is what is the scope of the problem. And this is work that I've been involved with a couple of years back, where we asked how much of the total tumor volume is actually sampled within the research setting and also the clinical setting. What is being shown here is data derived from the TCGA pan-cancer dataset, where we're looking at the percentage of tumor sampled in relation to total volume for a patient divided by stage. And in the research setting, which typically takes larger tumor samples for analysis compared to clinical samples, which I'll get onto, is that the median fraction of tumor samples that is sampled is actually 2.3%. But what is more striking is that the issue of undersampling or underrepresentation of total tumor burden scales with increasing stage of a patient's diagnosis. And what that really means is that patients who are typically more in need of biomarkers are more underserved by this single region sampling approach. When stage 4 setting, the amount of tumor sampled drops down to 0.5% even in the research setting. So what about clinical biopsies? As you can imagine, in the clinical workflow, what is typically analyzed is probably histological slides with an H&E or perhaps genomic material derived from a few histological slides, and that really is a smaller volume of tissue analyzed compared to the research setting. What I'm showing here select tumor types to demonstrate this point, where the median fraction of tumor sampled compared to total tumor volume in the clinical setting is 0.0005%. And what is shown here is that you can see and intuitively that the problem increases with larger primary tumors compared to smaller primary tumors. As you can see, the sampling issue would be increased in large tumors like sarcoma compared to melanoma primary tumors, which are typically just millimeters in size. So how does that relate to kidney cancer? Well, if you imagine 1 cubic centimeter of tumor typically contains about 1 billion cells, a typical kidney cancer of about 10 centimeter really represents about 500 cubic centimeters of tissue, and that's about 500 billion cells. And if a clinical sample only samples less than 0.0005%, as you can imagine, even before we've done anything, we're really up against Mount Everest when it comes to tissue-based biomarkers and the issue of undersampling in kidney cancer. So is there any hope? Well, I would say there is. Despite this issue, there's been multiple prospective studies which have derived gene expression signatures within prospective clinical trials which have predicted immunotherapy outcomes. What I've listed here are gene signatures from the Emotion 150, Javelin and Javelin studies, and also the TIS score as well. Individually, each of these studies have shown utility of biomarker signatures that have predicted immunotherapy outcomes. But the problem is that these signatures really have failed to cross-validate when applied to different patient cohorts. And I would argue that sampling bias potentially may be a contributing factor to this phenomenon. So when it comes to intratumor heterogeneity, it is well established that genomic heterogeneity in relation to mutations is pervasive in RCC. But unfortunately, transcriptional heterogeneity is also pervasive, and therefore this would have impact on gene expression signatures. What I'm showing here is the figure from one of the earlier works that have first identified transcriptional heterogeneity in kidney cancer. And what this shows here with these phylogenetic figures is that each individual tumors is annotated for either CCA or CCB prognostic signature. And as you can appreciate, in almost all tumors, both signature scores are present. And depending on where the biopsy needle lands for these tumors, you may potentially get a different readout. And of course, this is unacceptable when it comes to biomarkers in the clinical setting. So against this backdrop, there comes three major questions. One is if we can detect different readouts through multi-region biopsies by sampling different areas of tumor, can we utilize multi-region biopsies to account for sampling bias in the first place? Second question really that this phenomenon raises is that, what is the quantified scale of the problem? To what degree does sampling bias impact current biomarkers in kidney cancer? And finally, the question is, can we derive the biomarker signatures which is not subject to sampling bias? And of course, evaluating these biomarkers and answering these questions robustly means doing this in the context of dedicated clinical studies. This is exactly what we've done in work that was published a few years ago. And this is looking at biomarker assessments in the first-line setting within a phase 2 study of patients treated with first-line nivolumab. But the most critical thing within this study is that patients underwent multi-region biopsies at baseline and on treatment. And we analyzed these samples in relation to biomarker assessments. In relation to clinical outcomes, it was no surprise. We saw about 25 to 30% response rate with 10 non-responders and 5 responders. But what we derived from this trial is over 100 multi-region tumor samples, and we subjected these to multi-omic profiling. And for the purposes of this talk, I will focus on the RNA-seq data, where we performed this on about 60 tumor regions. So the question is, can we leverage multi-region biopsies to reproduce gene expression associations with immunotherapy outcomes? Instead of using individual tumor gene expression readout, what we've done is simply to utilize the multi-region set and derived an average gene expression score for each patient, and we correlated that with immunotherapy outcome. And what actually showed up was that by utilizing multi-region gene expression scores, we were able to recapitulate the predictive value of previously published signatures. And what's shown here is their motion and javelin scores. So then if we can utilize multi-region readout to account for a sampling bias, the upstream question from that is how significant is the problem of multi-region sampling? And that's the question that we asked within a multi-region sample set within a cohort study that is TraceX Renal. And I'm about to show some unpublished data from this ongoing work. So the TraceX Renal study allows extensive multi-region sampling from primary tumors and at times up to 100 biopsies for large tumors. And what we can do is then derive DNA and RNA for molecular profiling. Within this work, we performed multi-region RNA-seq on 67 patients, which equals to about 200 tumor regions with a median of 3 different samples per patient. And here are the results. What we first asked is, what is the chance of discordant readouts of established gene expression scores within each patient, depending on where the expression score is derived from? This is a busy slide, and what it shows is the concordance and discordance rate of 3 established gene expression scores. And now what you want you to focus on is the middle column, where it consistently shows that the chance of discordance between different regions of these signatures is about 40% across all 3 signatures. And when it comes to gene expression scores, if our chance of detecting consistent readout is only just better than a coin flip, it's unsurprising that tissue-based biomarkers really have not translated to clinical utility when it comes to single region profiling. So what can be done? currently, one of the major clinical areas of need is actually better prediction of immunotherapy outcomes in the adjuvant setting. In the previous work that I've shown, we can see that if we took multi-region biopsies and used an average score, that would improve the accuracy. But of course, this is cost and resource prohibitive for clinical implementation. So what can be done about this? Well, conceptually, what we really need is a gene expression signature or score that is stably expressed across the tumor, primary tumor, but also is able to distinguish patients of different levels of risk for relapse. Can this be done? Well, we asked the same question within the same multi-region tumor set within TRACE-X renal, and what we saw was that 1,020 genes are stably expressed across individual primary tumors, of which 8 of these genes come together as a signature which is able to confidently prognosticate the patient and associates with relapse risk. And this is validated within the TCGA data set as well of over 500 patients. And what's shown there is the Kaplan-Meier curves of the readout for high or low expression of this 8 gene prognostic score with hazard ratio of 1.72 and statistically significant. What's more important is that this is much less subject to sampling bias, and this 8 gene score outperforms the ClearCode 34 prognostic score, which is the current benchmark for prognosticating relapse risk in relation to gene expression scores. But of course, the natural question is, is there a way to derive a predictive signature for immunotherapy response as well? And this is work, I'm not showing the results here today, but what we've done also is to curate RNA-seq data across 4 prospective studies within the CheckMate portfolio of patients treated with anti-PD-1 containing regimens. And this 8 gene signature does not correlate with immunotherapy response, but perhaps this is not surprising, because for a biomarker to both prognosticate for relapse and be predictive of immunotherapy outcomes, it really also needs to be the target of anti-PD-1 therapy as well. And perhaps what this is telling us is that the molecular features are distinct in relation to regulation of relapse versus immunotherapy outcomes. And there is ongoing work in this space as well. So last, we also need to think about how to translate these new understandings to a clinical setting. And there are, of course, practical challenges to implementing gene expression signature in the clinic. And what we're really trying to next understand is whether the 8 gene prognostic signature also associates with histological features such that it allows a point of care assessment through histology slides to predict relapse risks. And what I'm showing here is an example of how this could be done. Currently, the sarcomatoid histological change is the most robust clinical biomarker we have, and perhaps this is an analogy for potential histological features that then also maps to the 8 gene prognostic score. And we're keen to leverage the power of AI for feature extraction associations with this new 8 gene prognostic signature. So I think to really contextualize what the challenges of tissue-based biomarkers and sampling issues, we really got to think more broadly about how that compares to potential other techniques. There are, of course, emerging role for blood-based biomarkers, and the conceptual benefit of blood-based assessments is that there is no issue with the same problem with tissue-based sampling bias. So is this the way to go? The most recent exciting advance is with the biomarker via KIM1 detection And these are slides that Laurence Albigès has presented in the past, and work that she has led on as well. And this was work that was first presented in 2024 in relation to KIM1 biomarker assessment within an adjuvant immunotherapy study. And this is hot off the press, where this was just published end of last month in relation to KIM1 associations with adjuvant immunotherapy outcomes in this Emotion 010 study. So what the authors have done here is a post hoc biomarker analysis for KIM1 expression for patients treated with adjuvant anti-PD-1 or placebo. And KIM1 is a kidney injury molecule 1, which is previously identified as having potential prognostic and predictive utility, and is enriched in patients with recurrent disease at baseline within the Emotion 010 study. This is the Kaplan-Meier curve where high expression of KIM1 correlates with worse survival and relapse risk, and low expression has a lower risk of disease-free relapse. But the dynamic assessment or dynamic change of KIM1 levels also has potential utility, where a rise in KIM1 during the treatment follow-up also correlates with the disease relapse. And what's shown here are the log transformed values of patients at baseline and at disease recurrence on the left. And patients without recurrent disease have a more stable level of KIM1 throughout the course of the study. But blood-based biomarkers with KIM1 also have their own bespoke challenges. What I'm showing here are the KIM1 assessments within the Checkmate 214 study, what they've compared levels within patients treated with ipi/nivo versus sunitinib. And what I want to highlight, and these are the raw data from this work, is that the baseline range of KIM1 expression is highly variable amongst patients, ranging from 30 to 13,000. And with this dynamic, huge baseline range, deriving a cutoff that can then be implemented in a clinical setting becomes challenging as well. This also relates to the percentage change post-therapy, which is highly variable amongst patients. And what is also interesting is that the change or the behavior of KIM1 dynamics is not the same between immunotherapy treatment and sunitinib. And therefore, this really relates to the fact that the mechanism for KIM1 clearance is likely different between regimens, and understanding this mechanism is critical to knowing how to implement this in the clinical setting, especially in the stage 4 setting. Finally, when it comes to any new technology, this is the Hartner hype cycle curve that is typically shown. And when there's new technology, there's often inflated expectations of what it can be done, but it then goes through this time of what they've coined as trough of disillusionment, and with further mechanistic work and refining our understanding, identifying the challenges, we then go on this slope of enlightenment before successful clinical implementation in the setting of biomarkers. And I would argue that we're currently here. So in summary, there are significant challenges in relation to prognostic and predictive biomarkers and tissue-based assessments in clear cell renal cell carcinoma, and sampling bias is a critical challenge. But what I've shown here is a potential way forward with a stably expressed 8 genes prognostic signature, which holds promise. But I think the main message here is, we really shouldn't be giving up, and really there is still hope. This is the acknowledgement slide for the huge number of patients involved in the work that I presented, but in particular, I want to acknowledge Samra Tavalic as the laboratory head for the program. And thank you so much for the chance to speak.
Thank you so much, Dr. Lewis, for a wonderful presentation. We will have our next speaker, Ellen Baloyan from Armenia, Managing Editor of OncoDaily, Director of VIGR. Dr. Baloyan, the stage is yours.
Thank you, Mariam. Thank you very much. And thank you to all our speakers today for dedicating their time to this important event. In a field that perhaps is not under the spotlight a lot, and it is too important to give a voice to renal oncology and to bring its community together to map out the progress that we are going to make. Today, my presentation is supposed to introduce OncoDaily, who we are, and rather who we are striving to be. Mariam, am I supposed to share my presentation? So, sorry for the pause. Who we're striving to be is, our mission is to be the voice of oncology. And I thought, what a better way to introduce the voice of oncology through the lens, through the eyes of its voices. Voices of people who know what it's like to make a change, a long-lasting impact, and to lead that change towards the positive outcomes. People who support us in our mission, including Her Honor, Princess Dina Mered of Jordan, for all the cancer community to have a space. And I want you to pay attention to this one thing, because it seems to be the axis, the thought that resonates with so many of our readers. Global leaders and readers, including Oliver Bogler, previous director of NCI Center for Cancer Training, a cancer survivor himself, who recommended OncoDaily as the go-to reading source for oncology news. And he said, I quote, OncoDaily celebrates a broad range of cancer professionals, highlighting their work and fosters a community. Love to read OncoDaily. Or like Mir Mutebi, president of African Organization for Research and Training in Cancer and the NASCO Humanitarian Award winner in 2024. She appreciated OncoDaily's work for amplifying positive change globally and building a vibrant oncology community. And perhaps the most interesting description of OncoDaily was given by Larry Norton, Senior VP of Memorial Sloan Kettering Cancer Center and past president of ASCO. He compared OncoDaily to oil, in a sense that if oil used to be the most important thing once, the most valuable thing once, now it's information. And by sharing an important part of that information throughout the world, we are actually going to change the world. So who are we? We are the leading oncology media platform globally, the largest news channel in medicine, sharing nearly 100 news a day, and a community of thousands of cancer professionals, patients, advocates, and organizations. And our vision is to be the fastest, most reliable, and innovative global source of oncology information, where everyone has a space to shape the future of oncology. Well, our story dates back 2 years ago, only 2 years ago, to two co-founders and one staff member. In 2 years, we grew to 36 staff members and 20 volunteers, people who are behind this great event. Our channels, what have our channels reached? So in 2 years, we became the #1 influencer of #oncology on X. And on LinkedIn, our total engagement exceeds the largest global media channels, including BBC and CNN. And these media channels are not based in medicine. They're not surrounded around oncology. But a force of community can do what we have done. So what is it that we do that people are so attracted to? Well, you can find in OncoDaily everything that relates to oncology, from FDA and EMA approvals, scientific articles, to policymakers, policy changers, celebrities, major conference coverages, and oncologists residing near you. Our special series in most promising cancer drugs in 2024 listed drugs, and some of them got approved actually in 2025, and it was a top hit for OncoDaily in 2024. And if reading is not your thing, you can subscribe to OncoDaily TV, our YouTube channel, which in 1 year grew from 180 subscribers to 75.4K. Well, we have podcasts and interviews with starting from residents and trainees in oncology to the global leaders and change makers. And you can find motivation, endless motivation there. To highlight a few series, Global Health Dialogues with Princess Tina, or the United Against Cancer with Her Excellency Zainab Shinkafi Bagudu, the President-elect of UICC, or the NCD Frontiers. Well, these are just a few examples, and lately we have launched the Empowering Oncology series, which is thriving on all the possible platforms. And if you found your motivation there, and you are ready to apply for a grant and an award, you can find all the grants and grant opportunities all in one place in OncoDaily that is updated daily. And if the next thing is attending the major conferences in oncology, you can find all oncology events in one place that are updated daily. Well, all of this needs a little bit statistics. What is a presentation in oncology without statistics? Just to shortly state, we have increased our active user count 2.5 times in the last 6 months, and now it exceeds the million. So what is it that we share? What other products and projects is that we have? OncoDaily magazine, printed and online, is available, and it features stories of people who have endless motivation to share. And from series that you can learn about the most influential women, you can learn about the major conferences and anything you need to know in oncology. And while I'm not the one to receive this positive comment, it says, walked by the oncology clinic today, Chief is reading OncoDaily magazine. This is a comment from UCLA's pediatric surgery chief. We launched our OncoDaily magazine in 2024, and we introduced it during the ASCO annual meeting. Then we launched the second issue this year at this year's ASCO annual meeting, and then since then we have launched monthly issues that all can be found in oncodaily.com. Well, OncoDaily launches peer-reviewed scientific journal. Excuse me.
Dear Dr. Palorian, you can start from the beginning. Sorry, we were having some technical issues.
No problem. Sorry for those technical issues. I'm happy to start over again. So I think we stopped on this slide, right? I was introducing OncoDaily. So what we have done in 2 years on social media. On X, OncoDaily is the top influencer of #oncology. And on LinkedIn, our total engagement exceeds the largest global media channels, including BBC and CNN. And those channels do not share only medicine and oncology news. We do. But that is the force of community, what can be achieved. So if you have not come across on social media to our baby channels, OncoDaily GI and IO, you should definitely check them out and subscribe to them. The OncoDaily Mother channel launched its GI and IO pages not long ago. The IO channel was launched a little over a month ago and the GI only 3 days ago, but the growth is much faster and much more impressive than OncoDaily Mother channels. Sorry, can I move the slide? Thank you. And what is it that we do? What is it that you can find in OncoDaily? We share everything about oncology, everything that relates to oncology. If your thing is policy, you can find that there. If your thing is science, FDA and EMA approvals, you can find our articles in oncology. From celebrities to major conference coverages and to promising cancer drugs. That is actually a hit article in 2024. We gave a list for most promising cancer drugs in oncology, quite a few of which got approved later in 2025. Next slide, please. Next slide, please. Thank you. If reading is not your thing, then you can watch us on OncoDaily TV on YouTube. We have many series featuring from residents to global oncology leaders. We grew our subscribers in 1 year from 180 to 75.4 thousand. And to highlight a few of those series, next slide, please. Global Health Dialogues with Princess Dina, or United Against Cancer with Her Excellency Zainab Shinkafi Bagudo, or NCD Frontiers. Those are just some of the series to highlight, but lately we have launched the Empowering Oncologists, which is thriving on all platforms possible. So if you're motivated enough through this oncology series that we feature on OncoDaily TV and you're ready to apply for a grant, again, you can find all grants in one place in OncoDaily, which are updated daily. And if the next thing is attending a major conference, you can visit our Onco calendars, which is updated daily again, and shown in the next slide that you can find all oncology events again in one website. And just a few updates, we have recently, a few days ago, we have launched the OncoDaily website's new beta version. You can check it out. I hope you like it. And what would be a medical presentation without some statistics? Just to quickly give you the contrast, in the last 6 months, we increased our active user count 2.5 times, now exceeding the 1 million. So other things that we have done in these 2 years, our projects, include the launch of the OncoDaily magazine. The first issue of OncoDaily magazine, shown in the next slide, was launched during the ASCO 24 annual meeting. We disseminated over 1,000 copies, and we introduced the second issue earlier this year during the ASCO 25 annual meeting, and since then we have released issues monthly, which are shown in the next slide. Can you please move the slide? Thank you. And just a positive comment here, the UCLA's pediatric surgery chief texted our editor-in-chief saying that their chief is reading the OncoDaily magazine in the clinic. OncoDaily also launched its peer-reviewed scientific journal. Chair of the editorial board is Matti Apro, president of SPCC and past president of European Cancer Organization. And the editor-in-chief is Shushan Hovsepian, co-chair of the SciOpGH and Research and Innovation Working Group. Since then, the medical journal has published abstracts from major conferences like SciOp Asia 2025 or POEM 2025, and you can find the scientific articles there as well. Well, the beloved Yvonne Award Series. OncoDaily gave in last year, during the ASCO annual meeting, we hosted a party and Yvonne Award ceremony where we gave out the Y-shaped awards to the innovators in oncology. Over 1,200 people attended in Chicago, and 2024 co-chairs were AACR and ESMO president-elects, while the second Yvonne Ward ceremony happened this year, again during the ASCO annual meeting, and 2025 co-chairs include ASCO board chair and ASCO past presidents. You can check out the winners in our website. A very heartfelt topic is coming up. Earlier this year, we celebrated New Year, then we celebrated acquiring Cancer World magazine, which is Europe's leading and the most reputable oncology magazine, established in 2004. And now to know that something that has left a great legacy in Europe's oncology care, we are now part of that thing, is very humbling for our entire team. And the editor-in-chief is Adriana Albini and Leah Shapira, former editor-in-chief of Cancer.net. Some of the issues are highlighted in the slide. Another beloved series is the 100 Influential Women in Oncology. And by beloved, I really mean that, because the Slovak Republic's president shared the first ranking list in 2023 on her X page. Actually, 2024 list was updated a year later, and now we have already introduced the 30 influential women of 2025, and we're going to continue to introduce 10 influential women each week, so stay tuned to follow up with the 2025 list. That influential people list is given for celebrities, for different key opinion leaders in different cancer fields, and all of that led to the development of Boston Institute for Global Rankings, which I am very proud to be the director of. 2 articles are already out. If you want to become an ASCO president, you should definitely read the article, Where to Study to Become an ASCO President. And if you want to find out which universities thrived in the post-Soviet Union, you can check out the article next to the ASCO presidents. And more such rankings are coming up, so stay tuned. Well, I think the promise of this event and what it promises to be can be predicted, and the scale that it's going to have can be predicted. Only 7 months after its initiation, OncoDaily hosted a very global event, Global Summit on War and Cancer, the opening remarks of which were given by the Director General of the World Health Organization. And all policymakers and influencers of the field gathered to raise this important issue. And the outcomes were more than palpable. A manifesto was published in Lancet, and WHO initiated a working group. This is where we are headed. And a testimony to that is its continuation by Oncothon, a global telethon to raise funds and awareness for pediatric cancer research. The first Oncothon was hosted in 2024 and raised over $1 million, which was donated to OncoHeroes Biosciences for pediatric cancer research. And the second Oncothon is ongoing. It was hosted in partnership with PSYOP, and the speakers and the cast included Leo Messi, Richard Gere, and Alejandra Gere, and Princess Dina Miret, and all the presidents of major oncology societies. From research, we moved on to advocacy through the Global Cancer Movement series. OncoDaily initiated the Global Cancer Movement for every patient with cancer, and it hosted its first event, challenging the status quo in colorectal cancer, hosting over 80 leaders in the field presented. And an update is coming about that too. Next slide, please. And all of this, throughout this process, we always appreciate and are grateful to our partners that are listed in the slide. Actually, You can see them, you can read the names. I will read them one by one. European School of Oncology, sharing progress in cancer care. European Society for Radiation, Radiotherapy and Oncology, ESTRO. SIOP, International Society of Pediatric Oncology. China Anti-Cancer Association. National Foundation for Cancer Research. Asia Fund for Cancer Research. Aim High Accelerated Fund. Egyptian Cancer Society. Hellenic Cancer Federation, Act for Children. Big Media. And just today we announced a partnership with SIOP, Society of Geriatric Oncology, and the list is growing. Next slide, please. So, other than OncoDaily, we launched an OncoDaily of the Hemostasis and Thrombosis World, the Hemostasis Today. You can visit the Hemostasis Today website. You can subscribe to the LinkedIn and X pages and follow the news in the field. Hemostasis Today is actually creating a community around all fields in medicine that relate to this area. And it's, again, growing much faster than once was doing OncoDaily. And in the 2025 pipeline, we are going to introduce Ask OncoDaily, an AI tool for oncology, fertility news, the OncoDaily of the fertility world, the Oncologist, which is the most comprehensive and largest registry of oncologists from all over the world, OncoBiotechs, which is the global registry for oncology biotech companies, and we are going to open 5 global hubs. Actually, one of them has already started its function, and there's going to be an announcement soon, so stay tuned to find out which one is the first. And all of this leads us back to our goal, to what we are trying to do at OncoDaily. We're not just trying to build a platform that will exceed with numbers and performance in the field. No, we are trying to create a community that exceeds with its performance the expectations, which is much needed in oncology, a challenge that is the same worldwide. And we thank all of our community for supporting us, for being with us. And if at any point you were featured in OncoDaily, you had anything to do with OncoDaily, just know that the team that you don't see necessarily perceives you as family, and you are part of the OncoDaily family. And I want to thank you again, all our viewers, all our subscribers, and all of the speakers, the stellar list, who contributed their time and effort for this event. Thank you very much.
Thank you very much for a wonderful presentation. We will have a 3 minutes break and then we will continue. Thank you.
Hello, everyone.
Hello, everyone, and welcome back. We're going to move forward to our next session, and it is my greatest pleasure to invite here to speak Dr. Emil Družić, who is an oncology and radiotherapy resident at the Clinical Center of University of Sarajevo, and Dr. Emina Bičakčić, who is also a medical doctor at Clinical Center of University of Sarajevo. The topic of the discussion will be the current state of renal oncology in Bosnia and Herzegovina. And we're going to start with a pre-recorded video of Dr. Družić, and we'll move forward to Dr. Emina, who is also here, and I can see her.
Hello, everyone. My name is Dr. Emil Družić. I'm a radiation oncology resident at the Oncology Clinic University Clinical Center of Sarajevo. And I'm recording this talk because, unfortunately, I am unable to join live tonight. I would like to thank OncoDaily for inviting me to participate in this online congress. A very important topic, a very challenging tumor site to treat. My colleague, Dr. Emina Bičakčić, has already provided an excellent overview of the systemic and surgical management of renal cancers, because renal cancers, particularly renal cell carcinoma, as you all know, have historically been considered relatively radioresistant. The role of radiotherapy is selective rather than universal. And in the next few minutes, I will focus on where radiotherapy fits, why we use it in those situations, and how we deliver it at our site in a way that aligns with the current guidelines. So let me begin with how we work. Our service, as Emina mentioned, is built around multidisciplinary tumor board. That means urologists, medical oncologists, pathologists, radiation oncologists make decisions together, as in other institutes and cancer centers, of course. And our radiotherapy treatment is image-guided and patient-centered, with streamlined pathways that prioritize clarity, comfort, and safety, of course. We deliver care on various machines. We have our Elekta Versa HD, Elekta Harmony Pro, Variant TrueBeam, and Variant Bravo's high-dose rated brachytherapy that we use for HDR brachytherapy in other tumor sites. This platform, these machines, gives us the persistence and consistency to meet the clinical goals I'm about to describe. So, because today's scope is renal cancers, which for our purpose includes, of course, renal cell carcinoma, upper tract urothelial carcinoma, and other renal cancers, in our setting, radiotherapy has a focused role. We use it only where it clearly adds value for local control or systemic relief. And every decision is made through the multidisciplinary tumor board. The emphasis is on pragmatism, the right patient, the right target, at the right time, of course. Across contemporary European and international guidance, surgical systemic therapy.
Dr. Amina, if you're here with us, can we ask you to join and present your part? We are having trouble issues with Dr. Amil's video, and we're gonna be forward with that after.
Yes, of course. Do I need to share a screen of my presentation, or will that be done?
We are done.
Okay. Thank you. Okay, so we can start, right? Can I? Okay, so first of all, thank you. I'm really honored, and it's a privilege to be invited in such a great oncology congress. So I'm actually here to present the outcomes of renal therapy in Bosnia and Herzegovina. I'm Dr. Amina Filipovic, and I work as a medical oncologist in the Clinical Center, University of Sarajevo. So the objective of my presentation is to summarize renal cancer epidemiology, standard treatment pathways, therapy options, and reimbursement and practical considerations in Bosnia and Herzegovina. Next slide, please. Just to, can you please just change the slide? Yeah, thank you. So, important to know about Bosnia and Herzegovina. So we are a country that is a little country that is placed in the heart of Balkan. Around slightly above 3.5 million people, and considering our governmental policies, we are a little bit complicated. So we are formed by three different organizational parts of the country. So we have the district of Brčko, we have Federation of Bosnia and Herzegovina, and we have the Republic of Srpska. It's important to mention because the reimbursement policies are different between Republic of Srpska and the Federation of Bosnia and Herzegovina. So given the global data from 2022, the kidney cancer incidence and mortality data for Bosnia and Herzegovina are slightly below or lower than some Central and Eastern European countries. So we have the incidence of around 2.8% with mortality of 1.8%. However, this still remains a very clinically significant problem for oncologists. As you can see, in Bosnia and Herzegovina, we do have somewhere above 14,000 new cases of carcinoma per year. Unfortunately, more than half of that, usually we have like number of deaths is half of that. Next slide, please. Can I have a next slide? Okay, so top 5 most frequent cancers in Bosnia and Herzegovina divided by males and females. In male population, it's lung cancer followed by colorectal and prostate cancer, and in females, unfortunately, breast cancer, colorectal, and lung cancer. If we compose that to both sexes, then we see that the most common lung cancer in Bosnia and Herzegovina, unfortunately, is lung cancer, followed by colorectal and breast cancer. Next slide, please. Kidney cancer and mortality of kidney cancer in Bosnia and Herzegovina. So usually the kidney cancer incidence and mortality in Bosnia and Herzegovina is at 11th place, given the amount around 5.3% in incidence and 2.2 in mortality. When we divide that by males and females, we see that also the kidney cancer is somewhere around 11th place, just above melanoma, with 7.7% in males and only 3.2% in females. So given the diagnostic and the staging of the disease, we do follow NCCN and protocol. We do cross-sectional imaging, usually by CT of chest and abdomen. Of course, we do use MRIs or ultrasound when indicated. After the biopsy and when the histology is confirmed, if we have any suspicion of metastasis during the MDT, we decide whether the patient is a candidate for surgery or is the candidate for systemic treatment. Important for us to emphasize that every patient in Sarajevo Can you hear me? Okay, thank you, Dr. Mogerian. So just to emphasize, so every patient, regardless of the primary site of the cancer, is treated by a multidisciplinary team, in this case, urologist, medical oncologist, radiation oncologist, pathologist, and sometimes a radiologist as well. Next slide. So for the localized disease, we do as is indicated by the NCCN. So the surgical management usually for stages 1 is partial nephrectomy or radical nephrectomy for larger tumors. Whenever it's feasible, we do use a nephron-sparing surgery that is done here at the Clinical Center of Sarajevo. Unfortunately, given the marvelous results of Keynote 564, the adjuvant immunotherapy for renal cell carcinoma is not available in Bosnia and Herzegovina at present. We do surveillance protocols that are individualized for each patient based on their stage and histology. Next slide. So for the advanced or metastatic renal cell carcinoma, the first line options in Bosnia and Herzegovina. So we do have systemic therapy that consists of sunitinib, pazopanib, axitinib, and everolimus. Unfortunately, the immune checkpoint inhibitors does the combinations of two or the combinations of immunotherapy with TKIs, unfortunately, are not at this moment refundable by our healthcare system. We do have patients who are self-funding immunotherapy in combination with axitinib, so pembrolizumab. We also, when we do the systemic treatment with each of the TKIs, the choice is guided by the patient's comorbidities, tolerability, and drug availability, of course, through the fund. Unfortunately, in subsequent lines and sequencing, we do have a problem. We usually do switch between TKIs or we do offer everolimus. And you also have to take into consideration that we do use a lot of, in the metastatic setting, if we can manage a local control using radiotherapy, especially SBRT, if and when it's appropriate. For some patients, we do offer, if the TKIs were given in first-line treatment, then in second-line treatment, we do offer immunotherapy. The next slide, please. As you can see, we have this slide of NCCN guidelines for 2025, and this is actually what we can offer to our patients in the first-line treatment and its sequential lines of treatment. We do try to switch between them as best as we can and to respect EMA's and NCCN guidelines as much as we can. Next slide, please. So actually, given the very complicated form of Bosnia and Herzegovina after the war, we have problems with local availability and reimbursement. There is a difference between Federation and the Republic of Srpska, so access can actually vary even between different cantons inside of the Federation, because the Federation itself is divided into 9 cantons. The canton Sarajevo, in which I work and live, we do have a partial reimbursement for immunotherapy in metastatic setting, primarily pembrolizumab, but just up to some amount. We do have waiting lists for expensive therapies in which TKIs are also included, but the waiting lists, the patient is not on them for more than 30 to 60 days. This, unfortunately, we do face a delay due to these fragmented reimbursement pathways. Next slide, please. So what is our recommendations, or what is that we as a clinicians are focused on? We do try to follow the guidelines for staging and systemic therapy, and we do try to document high-risk patients that are candidates for adjuvant therapy so that we can either offer them to fund the therapy themselves or just to keep an eye and follow up those patients more often than we would do with some low risk or maybe even intermediate risk patients. In the past, we did use compassionate use or expanded access programs to offer patients access to immunotherapy. And in some cases, with complicated cases, we do search for help in regional clinical centers when that is possible. So next slide, please. Given if we have some clinical trials or research opportunities, we do try to set up institutional registries so that we can participate in collaborative studies with neighboring centers in Bosnia and Herzegovina and other cities, as well as in other countries. Given that we are a small population, just 3.5 million, we do do a lot of communications with centers in Croatia, in Serbia, Macedonia, Slovenia, so then that we can improve local data. Currently, in the clinical center of Sarajevo, we are gathering data from our center and practically basing our own statistics. Next slide. It's also very important to mention that we have a very good supportive care. We do integrate nephrologists, we do integrate endocrinologists, as well as psychiatrists and other specialties, so that we can establish good algorithms in managing toxicities of after nephrectomy, and also just to in symptomatic metastatic disease, so that we can actually prepare patients for the therapy that can be given. Next slide. Unfortunately, this is like a sad slide where you can see actually the differences between the international guidelines from 2025 and current state in Bosnia and Herzegovina and our practice. We do manage, but we would like to have a novel therapies that can allow us to really treat patients in the manner that is the best for them. Next slide, please. Well, what would be my conclusion and what I would like to emphasize? We are unfortunately constrained by limited drug availability. We do have TKIs that are reimbursed, but no immunotherapy options. This actually creates a significant treatment gap between us and other European Union countries, but we do try to trial participation or regional collaboration or some kind of reimbursement funds to align our list with European Union oncology standards and world standards. We do vision that we have some how can we say, unmet needs, and we are trying to engage policymakers to improve outcomes of our patients. With that, we did succeed with collaborations of our authorities, given our cantonal ministry and Ministry of Health of Federation of Bosnia and Herzegovina, that by the end of 2025 or the beginning of 2026, we expect the expansion and revision of the systemic therapy list in Bosnia and Herzegovina. Currently, we have around 150 systemic oncological therapies on that list, but we certainly hope by the June or July of 2026 to have 50 new drugs. Next slide. This will just be the resources I used. Well, thank you again for your attention, and thank you for this opportunity to present Bosnia and Herzegovina and oncologists in Bosnia and Herzegovina. Thank you.
Thank you so much, Dr. Amina, for this wonderful presentation and for sharing with us what is the situation in Bosnia and Herzegovina. And moving forward, we're going to go to Armenia, where Dr. Rana McKay, Chief of Pediatric Oncology Clinic at the Pediatric Cancer Center at the Renal Oncology Hematology Center and Assistant Professor at Yerevan State Medical University, Sayab Janan, AYA Working Group Co-Chair, will present the data from Armenia and pediatric cancers. Dr. Rana, are you here? Can you hear me?
Yeah, I can hear you. And let me share my screen. Thank you very much for the kind introduction. Let me share my screen now. I hope you can see my slides. You can see my slides, correct?
Yes, we can do it.
Amalia, can you see my slides?
Yes, we can do.
Thank you. So I'm going to talk about barriers to treatment of Wilms tumor in LMICs. We will switch briefly to the pediatric oncology now for this next minute. So I won't go deep into details about management of the Wilms tumor. However, we know that it's the most common childhood kidney cancer. It's one of the most common and curable cancer types. And we know that the long-term survival in high-income countries is more than 90%. However, the situation is different in LMICs, and in many, of course, for some countries, we cannot know the exact survival rate. However, it can range from 25 to 60%. The relapse rate can be really high and often fatal, and abatement rate is high. So what are the challenges in LMICs in the management? The first challenge is a delayed diagnosis and advanced disease, and it's one of the most critical barriers to improve the survival of Wilms tumor. The first issue is the late presentation. And unlike many high-income countries where it's common and we do not see the late presentation so often, in LMICs usually we see the stage 3 and 4 disease. And on the other hand, we have the limited early detection. If we see there is a lack of routine pediatric checkups in LMICs, it's a problem in some high-income countries as well, but in LMICs, we have that problem issue, and the parents are going to the doctor when it's really late. And the next thing is the diagnostic infrastructure gaps, and many hospitals even lack to do a simple ultrasonography, which is the first step of the diagnosis of Wilms tumor. And so this all leads to delayed diagnosis, and delayed diagnosis lead to larger tumor and metastasis at presentation, which of course worsens the prognosis. And the consequences of this delay is very severe because up to 30 to 50% of Wilms tumor cases in some LMICs present with just metastatic disease. Meanwhile, in high-income countries, this rate is 10%. And this is a study showed that which was done in low-income countries, and they showed that as you see, the 93% of the cases came with advanced disease, stage 3 up to 5. So the challenge number 2 is the limited treatment and access and abatement. So access barriers, geographic and financial barriers, we know that the specialized pediatric cancer centers are often located far away from the patient's home, and families incur significant costs to go there. And we know that in Wilms tumor, that's not just a person who is treating the patient, but it's multi-stage nature. So it's referring to chemo, radiation therapy, and surgery. And all this makes these costs very difficult for the families. Other thing are the social cultural factors, which is especially severe in LMICs, and there is a lack of adequate counseling and support, and all this often results in therapy abandonment in these countries. And about the treatment abandonment, there is a high treatment abandonment rate in LMICs. It can be exceeding 20 to 30%. Like for instance, in a survey which was done in Africa, it showed that before interventions implemented there, the survival was the abandonment rate was around 23%. And another example is in Western China. The study was there, 14% of the families abandoned the treatment despite a viability. So it's not only the treatment is viable or not, even if the treatment is viable, abandonment is high. And here I have summed up the publications available about the abandonment rate. And here we can see how high abandonment rate can be, especially here in Uganda. And here another group of the studies, we see the high abandonment rate, especially in Indonesia. And the thing that I would like to sum up from these tables is that the higher abatement rate is, the lower survival is, from all these studies which were done in Africa and Asian countries. So challenge number 3, healthcare infrastructure. There is a problem not only just with structural problems and the resources and the delays, but also the specialist shortage, because there is a lack of pediatric oncologists, surgeons, radiologists who would treat patients with Wilms tumor. There's a limited cancer centers we have talked about already, and for surgical departments, chemotherapy and radiation therapy. There's a problem with equipment and facilities, and even some scans are not viable, and supportive care measurements also are a problem, and there is a really high rate of so-called toxic deaths in LMICs. So challenge number 4 is the chemotherapy and drug viability. In LMICs, and we're facing in Armenia as well, we have sometimes shortage of this or that medications, and this can lead to not receiving the full recommended regimen of the world protocol. And what we are doing in this case is we are adapting the protocols based on the resources that we currently have, or either switching the protocols or switching the weeks of the chemotherapy. So apart from that, essential medicines which are available, the problem also is the cost of the medication. So even when available, sometimes parents have to buy it, and there is an out-of-pocket thing, and parents have to do all this by themselves. And the solutions of these problems are usually either adapted protocols or pharmacy safety issues that in LMICs people are trying to do. So we talked about chemo and about the surgeon radiotherapy limitations. So not all surgeons can do this type of surgical treatment, and timely nephrectomy, we know that is critical. I mean, if the patient is treated based on the European protocols, and a few pediatric surgeons exist in LMICs that will do that. And here we see the abandonment rate, and specifically surgical refusal, how high it is in low middle income countries, and how it can impact the survival rate. So the challenge number 5, we've talked, surgery and radiotherapy. About the radiotherapy specifically, I have to say that in some cases in Wilms tumor, radiotherapy is indicated if we're talking about stage 3 disease, and I have to say that only about 46% of African countries have any radiation therapy facilities. So you can imagine, if radiation therapy is indicated in Wilms tumor, how problematic it can be to receive it in their home countries. Okay, we know the problems. So what's the solution of this? So the solution of this can be, we know that the SAR versus COG protocols, and in many LMICs, people prefer using SAR protocol because why? Because in these cases you delay the surgery and you can plan. You have a plan to treat it. There are a number of successful protocols and implementation in LMICs. This one was done by the Pediatric Oncology in Developing Countries group, and based on their published report, they have received and they could improve the survival rate there. So just a couple of case studies, successful initiatives. The first one, collaborative Wilms Tumor Africa project, and here is the QR code, and you can scan it and have the full package and the full document to this. The next one is the National Health Insurance in Kenya, how they got the successful story of it. Next one is the twinning and partnership programs, and we know that even it's not viable and consultation not viable, there is a huge role of telemedicine and pediatric oncology. I won't go deep into details to this, but I have to say there are a number of studies, number of papers showing how impactful and helpful it can be, especially in LMICs. And this is our Armenian example, how we could overcome these problems that we had. And finally, WHO Cure All initiative, and you can again scan this and use it, and they have a roadmap or to provide the help in every scenario. And with focused cure all strategies, they saying that Wilms tumor can be a model cancer to achieve 60% survival target by 2030. So the conclusion is that every child, I won't go deep into all the detail because we are going to discuss this during the panel discussion a bit later. But one thing that I would like to concentrate is that every child with cancer, regardless of where they live, deserve a chance to cure. And strengthening the system from early diagnosis is important through the long-term follow-up will save lives. With this, thank you very much for the time and looking forward to see you in the panel discussion.
Thank you very much, Rosanna, for sharing with us the details on pediatric oncology. And we discussed on systemic therapy. And now I know Dr. Mergerian is here and waiting, and he is having clinic in just a few minutes. So we are looking very forward to your presentation on discussing the surgical management of renal tumors in children and young adults. Dr. Mergerian Paul is Division Chief Pediatric Urology at Seattle Children's Hospital and Professor of Urology at University of Washington. Can you hear me, Dr. Paul?
You can see my slides, correct? Yes.
Yes, we can.
I'm sorry, it's noontime here in Seattle, so I'm doing it to my lunchtime, and I have clinic starting at 1 o'clock, so I have 30 minutes. I was asked to talk about the surgical management of renal tumors in children. And so let me just see. The current studies are based on earlier national Wilms tumor studies, along with others. Initially and historically, the treatments have mostly been based on histology. Most recent studies have looked at really risk-based management of Wilms tumor, and biology is starting to play a bigger and bigger role in the management of these patients. So we may see a change in some of the patients, especially the more complicated patients. Biology will most likely play a role in the future management of this condition. I'm just trying to scroll. Just as a standard of management or imaging, because part of the previous recommendations for Wilms tumor surgical management of Wilms tumors are really to palpate the contralateral kidney to see if there's any tumors. This is no longer needed, as CT of the abdomen provides an excellent visualization of the retroperitoneum and the intra-abdominal structures, and that supplants intraoperative palpation. Also, ultrasound of the vessels is part of the protocol for evaluating those patients. And that may not be needed, as that CT scan has been shown to demonstrate vascular involvement. As far as the surgeon's role in removing and treating those tumors, really determining if the tumor is resectable or not, minimizing tumor spill, which is important because it has a huge factor on management, making sure that you're accurately staging those patients, including lymph node sampling, and I'll talk about that. Marking the extent of the tumor to assist radiation oncologists, and also inserting a central line for chemotherapy. We all know the stages of renal tumors. I'll just go over to the next slide. We do know that there are biological markers, especially unfavorable histology, which is but that has a poor prognosis. but also loss of heterozygosity in chromosomes 1p and 16q, and 1q gain has also been shown to have poor prognosis. And this eventually, when I'm talking about histology, these may play a role in management of these patients. So I was going to bring in a few scenarios and talk about those and the management of these. If I can get the next slide. Okay. So this is an example of a 1.5-year-old patient has a lesion on the left side. Imaging shows an 8-centimeter mass replacing the left kidney. Everything else is normal. The kidney is normal. The liver, lungs, the vessels are normal. What is the next step of management? I know our previous speaker talked about the PSYOP. So there are pretty much two protocols, the Children's Oncology Group, which is based in the United States, and the PSYOP protocols. This Children's Oncology Group relies mostly on surgery first, chemotherapy after, PSYOP chemotherapy first, surgery later. Those are long-standing differences in approaches. When you look at the outcomes are pretty much similar. There are pros and cons to each one of these approaches. It's not a matter of one being better than the other. And there's starting to be some shared approaches that are used between those two protocols. What about biopsy? Biopsy is unwarranted in most cases because it will not really change the management of most cases. And also a biopsy alone can upstage a tumor, for example, from stage 2 to the stage 3, but then will upstage the chemotherapy because you have to have 3-drug chemotherapy and possibly radiation. Biopsying through IR is poor for diagnosing unfavorable histology. If you are going to biopsy, best biopsying it through a flank approach to minimize intra-abdominal spill or intra-abdominal spread. Some protocols, especially in the UK, have used IR biopsy, and they have not shown any increase in risk in using IR biopsy. When I was in Toronto, we used to biopsy those patients, again, through the same approach. There was not an increased risk. And again, just to remind everybody, some think that the PSYOP protocols biopsy all cases. They don't. It's treated with chemotherapy first without biopsy, just based on age of patient and tumor. As far as complications of surgery, there was one study that looked at complications of surgery, and the most common complication of surgery is intestinal obstruction, but you can get 2% of patients who have hemorrhage. Some have vascular injury. And when you look at the complications, they're associated with patients that have tumor thrombi. The nephrectomy was performed through a flank incision, a paramedian incision, and not a transabdominal incision. Tumors that are greater than 10 centimeters in diameter. And if a general surgeon, as opposed to a pediatric surgeon or urologist, is doing the case. So the standard approach is basically doing a nephrectomy and a partial ureterectomy and lymph node sampling. And at the end of the case, putting clips on the sides to aid the radiation oncologists in case they need radiation. Lymph nodes are really important because they will, in order to accurately diagnose its tumors and provide the best therapy. And it's important to sample not just enlarged nodes, but also normal lymph nodes. When we looked at the NITWITs, the National Tumor Study groups, around 10% of nephrectomies did not include nodes. And it's around 10% of the studies. The likelihood of finding a positive node is higher when you get more than 7 lymph nodes. So we're basically looking at really sampling more than 7 lymph nodes. If lymph nodes are not samples, you end to understage, undertreat, have a high rate of recurrence, and possibly a lower survival rate. So I just need to stress the importance of doing lymph node sampling in these patients. As far as the adrenal gland, should we remove or not? The risk of having an adrenal involvement is around 4%. The 5-year event-free survival with or without removal of the adrenal gland is the same. Therefore, it's not really mandatory to remove the adrenal gland on that side. As far as there are a certain percentage of patients that do have ureal involvements, around 2%. You will suspect ureal involvement if there's hematuria, hydronephrosis, or if the kidney is non-functioning. In these cases, you may want to do cystoscopy with a retrograde uretropyelogram to evaluate the ureters, and then also to perform a complete resection of the ureter alongside the nephrectomies, because usually you do a partial resection. In these cases, you will have to do a complete resection all the way down to the bladder. What about the 1.5-year-old who has a right-sided lesion? The lesion itself is 13 centimeters in diameter. The right kidney is normal. How do you treat those patients? And it's a right-sided tumor. So I just talked a little bit about right-sided tumors. We do know that tumor spill is highest in patients that have tumors that are greater than 12 centimeters, mainly because of the fact that the optic field is limited, the anatomy is distorted, it's difficult to dissect the tumor from adjacent structures, difficult to handle the tumor, isolating the renal vasculature is difficult, the capsular stent makes it more difficult to resect those tumors with a higher complication rate. Right tumors are also harder because the renal arteries on the right side are more variable than on the left side. The renal vein is shorter on that side, and there are also a higher rate of renal variability in the left on the right renal vein, and the right renal vein is shorter. And also the liver is in the way, that makes it a little bit harder to take those tumors. What about a 1.5-year-old who has a small lesion on the left kidney? No lesions on the right, there's no tumor thrombi, there's no metastases. How do you treat those? So it's been shown that tumors in kids that are less than 2 years of age, less than 550 grams, stage 1, no abnormalities such as loss of heterozygosity, the nodes are negative, are very low risk for recurrence, and you can possibly treat those just with surgery, and that's current management without chemotherapy or radiation therapy. I think the future classifications will really look at biology and risk stratify those patients based on biology. What about renal sparing surgery for very low risk tumor? There have been some reports that have looked at potentially doing nephron sparing surgeries in unilateral Wilms tumors to spare nephrons. Basically, most of them were looking at smallest lesions. There was a study that looked at 60 patients with most of them were treated with chemotherapy first, but then with partial nephrectomy. The partial nephrectomy was found feasible to be on only 88% of patients. My take on this is that our adult contemporary urologists are doing a lot of partial nephrectomies using in Western countries using robotic minimally invasive surgery, and they can remove large tumors from these kidneys, and it's something that needs to be looked at as far as partial. Also, there have been studies that have advocated for minimally invasive surgery, laparoscopic surgery after chemotherapy. And there are a handful of studies that have actually looked at approaches upfront without chemotherapy. There are pros and cons to these types of approaches. But as I said, our adult urologists do those exclusively through minimally invasive approaches. And so maybe that's something we have to improve on in these patients, and really looking at the outcomes of these types of approaches, because there have been reports of peritoneal metastases following minimally invasive procedures. What about a 3-year-old that comes in with a left-sided tumor rupture? There's no tumor thrombus, no metastases. But they present with a tumor rupture. We had a kid like that last week who actually had a fall and was found to have a ruptured Wilms tumor. In these situations, I think you have to determine if the tumor is resectable or not. Usually, if you determine the tumor is unresectable, if there's a tumor thrombus above the level of the hepatic veins, it's deemed unresectable. If it involves other structures around the tumor, that makes it a high morbidity case, then you would deem this tumor unresectable. And if the surgeon deems that the nephrectomy will result in greater morbidity, then I think that should not be resected up front and treated with chemotherapy, or if there's pulmonary compromise because of severe pulmonary metastases. Just to let you know, there's a spill that upstages the tumor with potentially 3-drug chemotherapy instead of 2, and possibly radiation. What about renal vein thrombosis, or if they have a venous thrombosis? This is a 3-year-old with a left-sided tumor and thrombus. Most of us with thrombi will deem those tumors unresectable and treat up front with chemotherapy first to try and shrink the tumor. But just waiting for this to move forward. Renal involvement occurs in around 11% of cases. If it's only the renal vein, you may be able to resect that up front without previously treating with chemotherapy. But if there's involvement of vena cava, or especially if it's in suprahepatic, then or atrial, then you would treat with chemotherapy first. And same lesion, but now we have pulmonary metastases. What to do with those? If you do have pulmonary metastases, we try to withhold radiation if possible. So there's a study that actually looked at withholding radiation in rapid responders. And in these types of cases, you're able to avoid radiation around 40% of patients with lung metastases. And only those that had residual tumors received whole lung radiation. If you have any doubt as far as the nature of the pulmonary nodule, if they're small, because 1/3 of those small lesions are not metastatic, you may want to consider biopsying those lesions to rule out tumor. What about the liver lesion? So if you have a 3-year-old with a liver lesion, there are some studies that have actually shown that the event-free survival after resection of the liver lesion is higher than without resection. Most of these are on the right lobe. There's some in the left lobe. 50% can be in both lobes. Most are favorable histology. And the event-free survival is not different than lung metastases. And as I said, the survival is better if they're resected. And the event-free survival is the same whether they were treated with chemotherapy and radiation. So we would like to avoid radiation if possible, but it's not really clear at this point if we can avoid radiation in children with liver metastases. What about bilateral lesions? Again, those are usually treated even with the COG group. They're treated with chemotherapy first, and then nephron-sparing surgery. 5% of them are bilateral. Again, preoperative chemotherapy. They do not require biopsy. If there's less than 50% response after 6 weeks, we would not do an open renal biopsy, but you can do an open renal biopsy to evaluate. We would treat for another 6 weeks of chemotherapy and then reassess. And if there's a good response, they're really considering a partial nephrectomy bilaterally. And those with positive margins do well with flank radiation therapy. What if you get a 13-year-old with a left-sided lesion with no other lesions? I think when these types of cases is obvious, you've got to think renal cell carcinoma and not Wilms tumor. Those are likely therapy. There's a translocation type with the renal cell. Nodal disease is quite common, so it's really important to biopsy nodes and sample nodes for proper staging. And most of these are in teenagers or have a relatively good prognosis and good long-term outcomes. I think this was my last slide. Thank you.
Thanks a lot, Dr. Mergelian, for making it happen and for indeed this important talk. We have spoken a lot about adult population, and now it was time for pediatric and young adults. And for that, I'm going to invite our chair of the panel discussion, Dr. Raya Saab, who is the Chief of Pediatric Oncology and Professor at Stanford University School of Medicine, to lead this discussion on the management of renal tumors in pediatric and young adult population.
Not hear you. Can you hear me?
Yes.
Oh, okay. All right. And thank you to everybody who's attending and listening. So if there are any questions, of course, we're happy to address them if you can add them in the chat. And I think there are several challenges specifically in renal tumors in children. One is the evolving risk classification that a lot of times I think in lower resource settings becomes quite difficult, both in keeping up with a rapidly evolving risk classification and in molecular testing. And I know that copy number variation analyses for LOH is not easily accessible in the majority of lower resource settings. So most of the time, the risk stratification, can be a little bit different than what is done in the higher resource settings. So that's one thing that I think it would be good to see your thoughts on that and how you approach that in your settings. And then the second one is patients with bilateral tumors, where nephron-sparing surgery becomes very important. And again, this surgical approach and the availability of a surgeon who is comfortable with nephron-sparing approaches becomes sometimes a barrier in lower resource settings too, and the role of radiation in those cases. So I'll open both questions for discussion, and would love to hear what you both think.
I think one thing that we talk about with bilateral cases, if you look at our adult urology counterparts, they do a lot of nephron-sparing surgeries for renal cell carcinoma. Today, most of them, I would get over 95% of them are done minimally invasive. And so I think we can learn from them. And the problem with children is that, with the adults, they clamp the renal vessels. In children, especially with small vessels, you run the risk of causing thrombosis in those vessels and issues that loss of kidney. So I personally do not clamp the renal vessels. I would basically squeeze. I would isolate them first and make sure that I have control of the renal vessels, but then really try not to clamp the renal vessels when I do partial nephrectomy, which again runs the risk of blood loss and all these things that you have to think about when doing these types of tumors.
Thank you so much. That's I think having a global population, a global conversation among pediatric surgeons is extremely important, and pediatric urologists is extremely important because of those nuances specifically related to pediatric renal tumors. And I guess another, and that's something that I know is available through SIOP, but there's also room for that even regionally, I think, and through twinning collaborations that Rosanna touched upon, not only within oncology, but also with surgery and radiation. Regarding bilateral tumors, I think another patient population, again, where the approach is evolving is in patients who have tumor predisposition, and how to approach patients with those, when a patient who has Beckwith-Wiedemann or hemihypertrophy comes in and has a renal tumor, even if it is a small tumor, how to approach that, knowing that that patient may develop other tumors further on in life, and you really want to be minimizing surgery as much as possible, even if it is a single, easily resectable tumor. And how would you approach that in that setting?
You approach them the same way that you approach a bilateral tumor. So with those with the syndromic kids, even if it's unilateral tumor, because of the high risk of recurrence, I would approach it as a bilateral. So really looking at nephron-sparing surgery as your treatment of choice. And so with these, if the tumor is large, and I would treat with chemotherapy first, and then once the tumor is shrunk, then do partial or nephron-sparing surgery. I think when you look at globally, SIOP versus COG, and I've operated. I go to Armenia every year, so I have done some Wilms tumors there, and I think it makes a lot of sense to treat those upfront with chemotherapy, because you tend to shrink the tumor. The capsule is much thicker. It's much easier to do a partial or a complete or a radical nephrectomy once the tumor is shrunk.
And what we've done with some of those patients who are identified on surveillance imaging, patients with Beckwith-Wiedemann or hemihypertrophy, typically it's recommended to do surveillance imaging every 3 months with an ultrasound until they're around 7 years of age. So if we identify a tumor, even if it is small, potentially giving chemotherapy can shrink it even further, which is different than our approach to unilateral tumors in kids without a predisposition. And I believe in the study by the COG, a proportion of those tumors could even disappear completely. And then the question is whether you'd go after them or not. So just keeping in mind that the approach to patients who have a known predisposition is potentially different and relies more on upfront chemotherapy to shrink the tumor, I think is worth just sort of highlighting. Yeah. Rosanna, any thoughts on molecular testing and LOH testing?
Yeah.
What do you all do in Armenia?
Yeah, I was about to comment on this. Previously, it was not viable in Armenia, which was a huge problem for our country. For that cases, we usually were referring to perfume blocks abroad to have the whole testing results, and as you said, the genetic testing as well. But now, fortunately, it is viable, and we're doing all in Armenia. However, as you said, it's the one of the most important things to do, because all the other treatment issues and the risk factors and everything is dependent on that. So we're really lucky to have that. But in the cases, and I'm thinking when people are asking what to do in these cases, we usually say that you have to refer to abroad, to send blocks abroad to have the accurate diagnosis until you will have the setup in your countries. The same as we're doing for other tumors as well. Until we'll set up and we'll have everything in Armenia, we have to refer and we have to adapt and do that. And the same with the bilateral Wilms tumor, unfortunately. And the most important thing, as I've talked about the twinning programs and telemedicine and telehealth, it's really important because this way we've started learning and implementing in Armenia. And this way we have started to involve our surgeons also to these discussions. So it's not only that pediatric oncologists doing all their discussions by themselves, but also involving other team members in Armenia. It's the thing that I'm sure that in many LMS is the same. We're not doing the surgery and radiation therapy at our center, but we are referring to different centers who do that. And it's important to involve the surgeons to these discussions and conversations to have to be all in the same page, and this will work for all NMICs, in my opinion.
It's an extremely important point about a multidisciplinary approach, right from the start, including, I would say, radiation oncology as well, even if you're not sure whether you're going to need it when you're staging that patient and figuring out, especially if there are pulmonary metastases as well, to have both the surgeon and the radiation oncologist involved right from the start, which I realize can be very difficult in smaller centers or in lower resource setting, but establishing that does provide the best approach to the patient. So it's definitely worth trying to get that in place. And I know that Dr. Paul has a clinic coming up, and
question for you: do you have tumor boards? Because that's another way of really having collaboration where you have everybody involved once a week, and you discuss oncology cases.
Yeah. Initially, it was not easy thing to do because, as I said, we have surgeons from we're working with different hospitals, so you do not have like officially force on them. But initially it was difficult, but now it's getting better and better. And for some tumor, it's really very smooth. For some, it's not yet, but we're working on it. And tumor boards are mandatory part, and this should be applicable for all LMICs, are mandatory part of the treatment of children with cancer. So yes.
Yeah, and I think one way to because the issue with the lower resource settings also is that the surgeon typically has other responsibilities somewhere else, so they're not only dedicated to that particular team, as is the radiation oncologists. And like you said, sometimes they're at different hospitals, so it's very difficult to bring them all together. So having incentives, whether from a national cancer control approach or from the institution itself, having incentives to have those multidisciplinary teams set up, I think is extremely important for kidney tumors, but also for all solid tumors. And that's something that the institutional leadership can be very, very helpful in to get them on board. It's not easy for sure.
Well, thank you for having me, everyone. It's nice meeting you.
Thank you so much. Absolutely. Thank you for this great discussion, and thank you everybody for joining the session. And thank you for OncoDaily for making this happen.
Thank you very much.
All right.
Thanks everyone for being with us and for having this wonderful panel discussion for pediatric and young adult patients. And now we're gonna move forward and finish the talk from Amil Družić from Bosnia and Herzegovina, and I'll turn on the pre-recorded video shortly.
Hello, everyone. My name is Dr. Amil Druž. I'm a radiation oncology resident at the Oncology Clinic University Clinical Center of Sarajevo. And I'm recording this talk because, unfortunately, I am unable to join live tonight. I would like to thank OncoDaily for inviting me to participate in this online congress. A very important topic, a very challenging tumor site to treat. My colleague, Dr. Emina Bečavčić, has already provided an excellent overview of the systemic and surgical management of renal cancers, because renal cancers, particularly renal cell carcinoma, as you all know, have historically been considered relatively radioresistant. The role of radiotherapy is selective rather than universal. And in the next few minutes, I will focus on where radiotherapy fits, why we use it in those situations, and how we deliver it at our site in a way that aligns with the current guidelines. So let me begin with how we work. Our service, as Emina mentioned, is built around multidisciplinary tumor board. That means urologists, medical oncologists, pathologists, radiation oncologists make decisions together, as in other institutes and cancer centers, of course. And our radiotherapy treatment is image-guided and patient-centered, with streamlined pathways that prioritize clarity, comfort, and safety, of course. We deliver care on various machines. We have our Elekta Versa HD, Elekta Harmony Pro, Varian TrueBeam, and Varian Bravo's high-dose rated brachytherapy that we use for HDR brachytherapy in other tumor sites. This platform, these machines, gives us the precision and consistency to meet the clinical goals I'm about to describe. So, because today's scope is renal cancers, which for our purpose includes, of course, renal cell carcinoma, upper tract urothelial carcinoma, and other renal cancers, in our setting, radiotherapy has a focused role. We use it only where it clearly adds value for local control or systemic relief. And every decision is made through the multidisciplinary tumor board. The emphasis is on pragmatism, the right patient, the right target, at the right time, of course. Across contemporary European and international guidance, surgery and systemic therapy lead the care pathway in renal cancers. Radiotherapy is generally not used as the routine adjuvant therapy after nephrectomy. Instead, we apply radiotherapy case by case for local control or palliation. To control nodal disease that is not operable, or to relieve symptoms for metastasis. This is the philosophy we follow in our practice. So for renal cell carcinoma, nephrectomy remains central. In appropriately selected high-risk cases, adjuvant immunotherapy may be considered first. And adjuvant radiotherapy is not standard in this disease. For upper tract urothelial carcinoma, the backbone is radical nephrourectectomy with perioperative staining therapy as indicated by risk and comorbidity. Again, adjuvant radiotherapy is not routinely recommended. That broader landscape explains why our radiotherapy indications are narrow and deliberate. To be very clear, at our center, we use radiotherapy in a few situations. First, positive lymph nodes after nephrectomy when they are not amenable to further surgery. Second, metastatic diseases in the palliative settings, most commonly bone, spine, brain, and selected visceral or soft tissue sites where local control or systemic relief will make a meaningful difference. Limiting radiotherapy to those situations keeps us aligned with both evidence and patient priorities. When local regional nodal disease is conferred after nephrectomy and additional surgery is not appropriate or feasible, radiotherapy becomes a focal point of local management tool. Our goals are to achieve regional control and to prevent or relieve complications. For example, pain, pressure effects, obstruction, or mass effect on adjacent structures. We coordinate timing and sequencing with our colleagues from the medical oncology. So radiotherapy supports rather than disturbs systemic treatment. The plan is agreed and documented in the multidisciplinary tumor board, so the patient, family, and all clinicians share the same expectations. When surgery is contraindicated, guidelines outline several non-surgical pathways for renal cell carcinoma with small renal masses, particularly in frail or comorbid patients. Active surveillance or thermal ablation are acceptable options. In medically inoperable localized renal cell carcinoma, stereotactic body radiotherapy may be considered as a non-surgical local treatment option based on increasing contemporary evidence and recent updates. And for upper tract urothelial carcinoma in patients unfit for radical nephroureterectomy, kidney sparing endoscopic management may be appropriate in low-risk disease under strict surveillance. So otherwise, we prioritize systemic or palliative strategies. This is why our use of radiotherapy is selective and individualized. It fits into a broader set of safe alternatives when surgery is not an option. In the palliative setting, our North Star is quality of life, of course. Radiotherapy can rapidly alleviate pain, preserve function and mobility, and reduce unplanned hospital visits. Typical scenarios include painful bone or spine lesions, locally symptomatic brain metastasis, and selected visceral or soft tissue sites that are causing bleeding, pressure, or other focal problems. We aim for concise, well-tolerated courses scheduled to coordinate with systemic therapy and supportive care. We also set expectations. Radiographic responses can lag behind clinical symptom improvements, so we assess success by both imaging and patient-reported outcomes. For brain metastasis, multi-society guidance recommends local therapy that may be surgery, stereotactic radiosurgery, or radiotherapy for eligible patients. The key practical point is that in symptomatic disease, we do not defer local therapy because timely control can preserve neurological functions and quality of life. For bone metastasis, external beam radiotherapy is a proven effective option for pain relief and for reduction of the risk of the skeletal complications. Across both sides, we favor the least burdensome approach that reliably achieves the patient's goals and aligns with the systemic plan. So to summarize, in renal cancers, our use of radiotherapy is focused and guideline aligned. We treat positive lymph nodes after nephrectomy when surgery is not feasible, and we treat metastasis in the palliative settings to improve symptoms and achieve local control. When surgery is contraindicated, we follow guideline-supported alternatives such as active surveillance or thermal ablation, and in medically inoperable localized renal cell carcinoma, we may consider stereotactic body radiotherapy. For patients, the pathway is simple and transparent: referral, multidisciplinary tumor board review, planning, treatment, and early follow-up to confirm benefit and address any side effects. Thank you for the attention, and thanks again to my colleague, Dr. Emina Bicakcic, for covering systemic treatment in depth and other parts of our renal cancer management. I hope this clarifies where radiotherapy adds value in renal cancers in our environment, because this presentation is recorded. Please share any questions with the organizers, and I will respond in writing if I am able to. It has been a pleasure to contribute, and wish you all luck with all the lectures, and hope we see each other again. Bye-bye.
Thanks, Dr. Lambert, for sharing us insights on the Bosnia and Herzegovina and this important insight. And now we're looking forward to hearing our next speaker, who will be speaking about radiation approaches for oligometastatic disease. Dr. Chad Tang is Associate Professor in Radiation Oncology at MD Anderson Cancer Center, and we are very happy to have you here with us today. Let's try to see how your screen share works. Otherwise, we're going to upload and continue with it. Can you please try to share your screen?
Okay, let me try real quickly. Can you see?
I think so, yes. Can you try to move? The slides are moving and I'm leaving you. Yep, everything works perfect. Okay, so I'm giving the floor to you.
Okay, great. Thank you, everybody joining in virtually for this opportunity to talk about one of my favorite topics, the management of oligometastatic renal cell carcinoma. I'll have a little bit of a different angle, I think, than the previous speaker. So, as we all are familiar, and probably this slide has been seen many times before, is that oligometastatic disease exists on a spectrum. We believe that there is on one end localized disease, on the other end widely metastatic disease. In this case, it's prostate cancer for illustration. And perhaps in the middle somewhere, there is a state where there's only a few sites of metastatic disease called oligometastatic. And in this state, there's a potential that local intervention may improve outcomes. Illustrative of this is the fact that metastatic therapy has been used in renal cell carcinoma much longer than there has been systemic therapy options for renal cell carcinoma. This is an illustrative paper that was from 1938 about a patient who had nephrectomy followed 5 years later by subtotal lobectomy of a pulmonary nodule. And after 5 years later, the patient was doing well, disease-free. And this treatment happened initially in 1933 and was reported in 1938, way precedes the systemic therapy use. However, since then, systemic therapy has taken great strides. It has robust phase 3 data showing benefit. However, there are problems associated with some systemic therapy combinations. We know that they're not without their costs. There is a high level of grade 3 toxicity in some of the combinations. The phase 3 studies do show 40 to 80% grade 3 higher toxicities. These drug combinations can be quite expensive, $300,000 to $300,000 per year, and require monthly visits or even more frequent visits for toxicity monitoring and for infusion of the PD-1 inhibitor. And efficacy, which is promising, is limited to possibly 1 to 2 years in most of these studies with PFS. So great options, but perhaps there's room for improvement in some patient populations. Now, I show this. This is the NCCN guidelines in 2024, and most recently they haven't changed in 2025 or 6. It shows clinical trials, first-line systemic therapy, metastasis-directed therapy, mastectomy, or best supportive care, and there really isn't much guidance on who should get what. This is essentially all the possibilities that one can do for this type of cancer. So it's a bit of a wide open field on what you can do. Now, in renal cell carcinoma, in clear cell and in non-clear cell, there is a wide spread of phenotypes. There are some patients with very fast-paced aggressive disease, and there are some patients with slower, more indolent disease that you may be able to de-escalate therapy for. And one of the first studies to look at this was done by Brian Reaney, and he looked at a cohort of 48 patients who were systemic therapy naive, found to have more indolent disease, and they were just surveilled off systemic therapy. And the primary endpoint of this study was time on surveillance. What they found was after a median of 38 months, that time on surveillance was pretty favorable, at 14.9 months, so more than a year. Progression-free survival was 9 months. And as illustrated on this swimmer's plot on the right side, as you can see here, the surveillance was punctuated with local therapy. There are these little green dots that you can see in the swimmer's plot. Most of this was surgery, but as you can see, surveillance wasn't just observation, it was possibly also adding local therapy. And there probably was a cohort of patients who had local therapy and then went on surveillance, which is quite a common scenario that we do a lot, at least at MD Anderson. How many of those, I don't know, but local therapy was a part of surveillance in the study, not as well described though. So we wanted to see, well, let's just do local therapy and see how patients do with that. So this was our first study published back in 2021, which looked at oligometastatic renal cell carcinoma with clear cell histology. And patients received local therapy with SBRT to all sites of the disease, off systemic therapy, and they were monitored. Now, at the time of progression, if the progression was limited, meaning up to 3 sites of the disease, then they had radiation therapy to all these 3 sites, and then went back around staying off systemic therapy. Now, this could go on and on. This circle could go on and on for years. I tell my patients my record is 14 years. But if the patient has more widespread disease or disease is not amenable to further treatment, then they have to start the frontline doublet systemic therapy. So initially, we did not know if this was, a viable option for patients. We did require a biopsy at 3 months just to make sure that the cancer was on its way regressing. And what we saw in this feasibility cohort of 30 patients was that the progression-free survival was very promising at 22.7 months, was that the systemic therapy-free survival was good at about 80% at about a year to 2. And the toxicity rate was very modest at 10% at 3 to 4 years. 10% for grade 3 to 4. All these toxicities were reversible. The one grade 4 was hyperglycemia, which was reversed with systemic with insulin. So, in addition to our study, about a year later, Dr. Hanan published a second totally independent study with 23 patients, mixed histologies, who had radiation therapy and very similar paradigm, could have serial radiation therapy if disease was limited. And similarly, the PFS at 1 year was quite good, 83%. Systemic therapy survival was 91%, very comparable. Grade 3 toxicity rate with 4%. Now, following on this trial, although it took us probably 2 months to enroll the first patient, another 2 months to enroll the second patient, we started getting a lot of patients for this therapy. So we decided to expand our cohort to include a efficacy cohort. And this efficacy cohort was published last week. So brand new results. We enrolled 121 patients here with clear cell renal cell carcinoma, limited metastatic disease. And then we said for this efficacy cohort that the median time to surveillance on the RENI study on surveillance was 14.9 months, with the upper threshold was 25 months. We said that it would be a successful study if we saw systemic therapy-free survival of 24 months, which corresponded roughly to the upper bounds of the surveillance study. And we said if we exceeded this, then we'd be successful. So after a median follow-up of about 3 years, 36.3 months, what we found was that systemic therapy-free survival in the 120 patient cohort was 34 months, so nearly 3 years. And overall survival was very good, 87% at 3 years. Toxicities were quite modest. What we saw was no grade 5 toxicities, 7% grade 3 to 4 toxicities, and then grade 2 or higher was 21%. Most of them resulted in pain was the main issue. So what's a reasonable next step? Well, we know from Keynote 564 that pembrolizumab after nephrectomy resulted in an overall survival benefit and a disease-free survival benefit versus placebo afterwards. And not only did it allow patients who were localized and had high-risk features, but they also allowed patients who are M1 NED, meaning they are oligometastatic and had resection and were rendered NED by resection. As we know, this was overall a positive study, but the cohort that's most interesting to us is this M1 NED cohort, which had a really high degree of benefit with adding pembrolizumab in terms of shown disease-free survival here. Now, looking at adding pembrolizumab afterward, there was a single-arm phase 2 study, the rapport study done by Shankar Seaver at European Urology. This was a 30-patient study, all clear cell renal cell carcinoma, received SABR or palliative radiation therapy, followed by 6 months of pembrolizumab, and the progression-free survival was quite promising. So interestingly, this will be, I think, tested in future combinations. Now, just to kind of put it all together in terms of treatments for oligometastatic renal cell carcinoma, here's a table summarizing the different studies. So from Brian Reeney's study showing median systemic therapy-free survival of 14.9 months, our updated results showing 34 months. Dr. Hanan's, and also another study in University of Chicago showing also very promising progression systemic therapy survival. And then Dr. Siva is showing that adding pembro was not much more toxic, and I think we'll need more follow-up to see if the PFS is going to be exceeding our follow-up. But because of these results, we're now enrolling on the ASTRO study, which is our current study. It is enrolling 144 patients with oligometastatic clear cell renal cell carcinoma. All patients are receiving radiation therapy to all sites of the disease, followed by observation, versus radiation therapy to all sites of the disease, followed by pembrolizumab for a year. They are allowed to have another round of radiation if oligometastatic progression, followed by the contralateral arm. So if they had radiation to all disease, followed by observation, they could have radiation the next round, followed by pembro, and vice versa. The primary endpoint is going to be progression-free survival, and we're more than halfway accrued, so we anticipate probably accrual completion at the end of 2026 or early 2027. In addition to this study, another study is currently ongoing called the PP study, which is looking at 81 patients, and this is run in, I think, 30 centers around Italy, and is looking at one cycle of neoadjuvant pembrolizumab followed by resection or SBRT, and then 8 more cycles, so about a year total, given every 6 weeks, versus tumor resection or SBRT alone. So a second study looking at this space, and it'll be interesting to see how they both read out in the future. Now, it is one thing to just do radiation, but I think we need more quantifiable biomarkers to kind of identify which patients are going to do better or do worse. And one biomarker that we've been interested a lot in is circulating tumor DNA. Now, we know that renal cell carcinoma is a difficult tumor for circulating tumor DNA. We know from a number of studies as a low shedding tumor that there's a lot of intra-patient heterogeneity, where there's a number of private mutations that are only existing in one MET, potentially not existing in other METs. And compared to other more common kidney cancers or other more common solid tumors, it had a generally low mutation burden. And this is all amplified by the fact that we are treating in oligometastatic patients low volume, more indolent disease. It's going to make this all even more pronounced. So what assay did we use? We used a next generation ultra-precise assay, ultra-sensitive assay by Myriad Genetics. What this assay entails is whole genome sequencing with 30x depth and identification of 1,000 to 2,000 somatic candidate sites. So in reference, Natera does 16 somatic candidate sites with whole exome sequencing. And then it uses these to look at the STREC2 plasma and then define the amount of circulating tumor DNA and whether ctDNA is positive or not. Now, this is the ctDNA positivity rate across the studies at baseline. 60% of patients were ctDNA positive, and about a quarter of them at 3-month follow-up reverted to ctDNA negative when we had both paired baseline and 3-month follow-up ctDNA measurements. As you can see here, that most of the patients who are ctDNA positive, they did not have 2 years of systemic therapy-free survival. About half of them didn't have it. But the majority of patients who are ctDNA negative, especially at 3-month follow-up, the blue line showing them to have more than 2 years of systemic therapy-free survival. Now, looking at Kaplan-Meier curves, looking at MRD rates specifically, here is the association of baseline ctDNA positivity with outcomes on the left, which shows a favorable hazard ratio, meaning if you are ctDNA negative, you're going to do much better. And at 3 months on the right, which means larger hazard ratio, when you have ctDNA positive at 3 months, that you're going to do much worse than if you were ctDNA negative. Now, as an illustration, here's a case of a patient I had treated on trial. In this patient, 2020, he had nephrectomy and IVC thrombectomy for clear cell renal cell carcinoma. At that time, the CT scan showed a number of 2 to 7 millimeter nodules, more than 10. These were too small biopsies at that time. It was given the benefit of the doubt not to be metastatic disease. At the follow-up in 2021, there's slower progression. One nodule has exceeded 1 centimeter. So it's 1.2 centimeter. Everything else was about stable to 1 to 2 millimeters larger. And what we did was with SBRT to this one nodule and then follow up afterward. Here's the SBRT plan. So we SBRT'd, and as we do number of biomarkers, we did the MRD here. There was MRD before our radiation, then this should be end of radiation to become MRD negative, and then at 3 months it was MRD negative. And here's the parts per million for ctDNA, very low, 1.3 parts per million, right on the threshold of detectability. There are other markers that one can use. We looked also at KIM1. Here's a KIM1 with 75 at before RT, 75 after RT, and then 101 3 months afterwards. But radiation can cause kidney injury on itself, so it is unclear whether that bump in KIM1 is from the radiation or it is from the disease. Now, another year later, another 3 slow-growing nodules to 1 centimeter. Still meets the criteria for more radiation therapy. We did radiation therapy to all 3 of these nodules, and once again, we saw that in this round, it went from MRD positive, once again to MRD negative. And the KIM1 fell from 103 to 87 to 60 to 70, showing a good response molecularly. Finally, in December, another 2 nodules grew to greater than a centimeter. And then ultimately, though, unfortunately, in January and February 2024, FDG PET showed some more nodules growing, and then a brain MRI showing that there was a new metastasis there. So this led us to start systemic therapy. But if you look at the ctDNA and KIM1 across time, you kind of see a good response with a positive MRD before RT becoming negative afterwards, again in January 2022, and then again in December 2022 when we treated the other 2 nodules. But when it is time with a new brain met and there's more growing nodules, we see it becomes MRD positive much higher, 246 parts per million. And the KIM1 was also much higher, 814. And this shows the general trend as well over time in this patient, showing a good correlation with radiation and the patient outcomes. So in summary, systemic therapy has made incredible advances, but they have downsides, including substantial and often cumulative toxicities, hospital clinic visits, and financial costs. Surveillance has been explored in subset indolent renal cell carcinomas, but in at least the trials that are published to date, they incorporate MDT. In our trial and others, we do demonstrate the feasibility and clinical effectiveness of radiation therapy alone. Another point is an open question is whether adjuvant maintenance pembro for a limited time will improve patient outcomes compared to surveillance. Currently being tested in a number of randomized phase 2 clinical trials. And I also think that biomarkers are needed. Circulating tumor DNA has prognostic utility in this patient set, and KIM1, as we'll show in future publications. So more to come here, and we're all moving towards more of a unified prognostic model to help select patients who should get systemic therapy versus those who do not. Thank you for your attention. And here's my contact information and my kids.
Thank you so much for sharing as radiation oncologist perspective. We were having medical oncologists and surgical oncologists, and it was indeed very informative. Can we ask for you to stay until the panel discussion? We would love to have your opinion also on that. And for that, we'll move forward with our next speaker, who is Kubul Hanan, and we will be speaking about radiation approaches for oligoprogressive disease. And I can see the camera here. Dr. Hanan is Professor of Radiation Oncology and Chief of Genito Union Radiation Oncology Service at UT Southwestern Medical Center. And I'll give floor to you. Can I ask to share the screen, please? And yeah. Let's just try to see whether it's moving. Can you try to move the slides? No, from your presentation. Yep, perfect. I'm giving to you.
So if good afternoon, everyone, and thank you for OncoDaily for
I'm very sorry.
me.
Can we ask to go on your presenter mode and at your
Okay,
now it's
got it.
better.
All right. Okay. So thank you again for inviting me to talk about radiation approaches for oligoprogressive RCC, a topic that is very dear to my heart. And I have no relevant disclosures. These are my current and previous funding supports. So I always try to start with a brief introduction to SBRT or SABR, and I think that's probably unnecessary given that excellent talk that Dr. Tang just presented. But historically, radiation considered resistant for RCC treatment. But with the advent of new technology, which allows us to deliver the very high dose, precise radiation conveniently in 1 to 5 treatments, that delivers a very high ablative dose for the kidney tumors and shown to be very effective in local control with minimal toxicity. And I will interchangeably use the term SABR or SBRT for this. And a number of studies have been done to show that SBRT or SABR is very effective on the order of 95% or higher local control with minimal toxicity. And one of the applications of that is the oligometastasis that Dr. Tang already talked about. Now, in the oligoprogressive setting, first let me define what is oligoprogression. So oligoprogression is patients with metastatic RCC on systemic therapy, could be any line, and they're progressing on 1 to 5 sites of metastasis after some time, and they have already shown some disease control or response to ongoing systemic therapy. That is how we are defining oligoprogressive RCC. And in this setting, the current standard of care is that we move on and go on to the next line of systemic therapy, which, as we know from the previous talks, that there aren't too many effective systemic therapies available for kidney cancer, and subsequent lines are even less effective, and eventually patients do run out of systemic therapy options. So it does make a lot of sense to bring in a local therapy here. Why? Because we know from our extensive sequencing studies of primary and metastatic sites of RCC that additional mutations do build up in metastatic sites that can selectively make 1 or 2 metastases resistant to the ongoing systemic therapy, while the rest continues to respond. And this is where we think that bringing in SABR for local control makes a lot of sense. Now, the key thing has to be that there has to be response to ongoing systemic therapy, because if that is not working, you just need to find the right systemic therapy for these patients. So we have applied this approach for quite some time at UT Southwestern that allows us to publish a retrospective study back in 2021. We're now in the process of updating that experience. So in this study, we treated 51 patients with metastatic RCC with oligoprogression, the way I define, and we did SABR to 71 sites. We allowed sequential SABR as long as there were certain criteria that were met, and patient continued to derive benefit from the ongoing systemic therapy. And if additional metastasis progress, we would take that out with stereotactic radiation. We included both IO and TKI in this patient cohort. For the TKIs, we typically would exercise caution, particularly when doing radiation to sites that are near GI organs. and we would hold TKI for at least a few days before and after each radiation treatment. With a median follow-up of 19 months, we reported a PFS of 16.3 months, which is interesting. Again, not comparable to the most modern IO-TKI combination, but recall that these are mostly single-agent therapies. And the more important question here is how much did we extend the duration of ongoing systemic therapy? And that's outlined in this figure. And the median extension of the systemic therapy was 8.6 months, which was interesting and fairly significant, because for the most part, these patients were second, third, and fourth line systemic therapy. So then the next question we asked is, which are the patients that benefits the most? So we looked at Cox regression with IMDC risk groups, synchronous versus metachronous, a number of variables, including metastatic burden, types of systemic therapy. And what we found was that the only variable that provided higher duration of PFS was actually when the ongoing systemic therapy was IO. All the other parameters we investigated did not show an improvement in progression-free survival. So a prospective multi-center phase 2 study coming from the CCTG Canadian group looked at and enrolled 37 patients, treated oligoprogressive sites with stereotactic radiation to 57 sites, and reported a 1-year local control rate of 93% and a median PFS of 9.3 months, with a median time to change of systemic therapy for 12.6 months. So this is, again, consistent and encouraging results to our retrospective study. There were no grade 3 or 5 toxicity. We parallelly ran our own phase 2 prospective study. So the Canadian study primarily included patients on sunitinib and a few on pazopanib, so mainly TKIs. Our study, a small prospective phase 2 study, we included both IO and TKI patients, and we enrolled 20 patients and reported a median PFS of 24.4 months, which is significantly higher than before, but the median extension was about 11 months, so about a year. Again, interestingly, we observed that the PFS when the ongoing systemic therapy was immunotherapy, it was significantly higher when it was not TKI. So this is an interesting observation. I mean, it remains to be seen whether the benefit is only in IO versus IO and TKI, but certainly it indicates that the benefit is more during IO rather than TKI. So in this study, we also looked at patient-reported quality of life as well as toxicity analysis reported by the physicians. And comparing pre and post, we showed that there was no significant decline in patients' quality of life with radiation, and the toxicity was only one patient experienced grade 3 toxicity, suggesting safety and feasibility of this approach. So a few ongoing oligoprogressive studies are currently enrolling. One is the JETUG Storm 01 by the JETUG group, single-arm phase 2 trial, and they are enrolling both IO and TKI patients. And another study at MD Anderson Extend Up is enrolling patients of 1 to 5 sites of oligoprogression. It is a randomized trial, randomizing between SABR plus ongoing systemic therapy versus the next line of systemic therapy. This study does include non-RCC patients as well, but also includes RCC, and hopefully we will learn a lot from these ongoing studies. So the next thing to think about is, what we noticed is there is some increased benefit when the ongoing systemic therapy is immunotherapy. So it begs the question whether there is a synergy between SABR and IO, and whether oligoprogressive RCCs is the ideal setting to harness such synergy. Now, we know of the radiation-induced immune modulation and immune stimulatory benefits from a wealth of preclinical studies where radiation is known to induce antigen presentation and can bring in the dendritic cells to start the antigen presentation and may improve the outcome of immunotherapy. Again, nothing that was proven in clinical trials yet. So let's revisit this a little bit and look through briefly the studies that has been completed for this. So, and this is taking in advantage of the possible in situ vaccination effect of radiation that, as you may all know, has shown to lead to abscopal effects in rare patients. So we looked at this in an earlier study combining high-dose IL-2, which is considered a standard of care for metastatic kidney cancer patients, combined that with SBRT or SABR, enrolled 30 patients, and we saw that we did not increase the response rate of the baseline response rate for high dose IL-2 typically ranges from 16 to 20%. We did not increase it. Complete response was perhaps slightly increased, but again, nothing that is powered. The study was powered to measure. We did see some increased response rate when the SBRT was done in patients that were having lung metastasis. So overall, a negative trial. So a second trial, the NIVS trial, looked at SABR combining with nivolumab alone in the second line setting, again, trying to improve the outcome or response rate compared to the historic landmark study of Checkmate 025 that showed a response rate of 25%. This study had an objective response rate of 17%, so another negative study. A third negative study is the RADVAX trial, which I did not bring in because it was not published in a manuscript, but was presented in one of the ASCO GU conferences and suggested an increase in response rate of EP-Nivo combined with SBRT, increasing the response rate to 60% from 40%. But however, again, we don't have a manuscript for that study yet. So then the question is, with the setting of all the negative trials so far, does it make sense to bring in SABR in the oligoprogressive setting? Do we really think that is the best place to harness the synergy, or if there is any synergy? So one of the things to notice is that all of these previous trials was not in the oligoprogressive setting, meaning that the failure could be the failure of IO altogether. We have shown some response to the IO, but now perhaps has an escape of antigen where you need additional antigen presentation by stereotactic radiation. And that may still, it's still a question that is not answered. And of course, we don't know the answer until we do a clinical trial. So we are doing a trial in this setting. And to introduce the trial, I will briefly introduce you to PULSAR. We're calling that personalized ultrafractionated stereotactic adaptive radiation, which simply is SABR or SBRT, but spaced out in every 2 to 4 week intervals to take advantage of a cancer vaccination type schedule. Whereas in previous SBRTs, you would give radiation every other day. You would first give radiation, bring in the dendritic cells, and the next radiation dose, you will kill the dendritic cells. Rather than 2 to 4 weeks allows the time for the dendritic cells to take up the dying tumor cells, migrate out, and then you bring in this next dose of radiation. And at the same time, you adapt based on the response from the first radiation. So you shrink or increase the field of radiation as needed. So using PULSAR, we have designed a single-arm phase 2 feasibility study of oligoprogressive metastatic RCC patients progressing in 1 to 5 sites after initial EP-Nivo and going to be continuing on maintenance Nivo. We will give radiation PULSAR to each site of progression, and at least one of the sites we will also inject intratumorally with STING agonist, which in our hands, at least in preclinical setting, has shown significant increase in dendritic cell activation and antigen presentation by stereotactic radiation. Again, another trial that we will see if it pans out eventually. A few other studies I wanted to bring your attention that also looking into combining IO with SABR. Both of them are in the cytoreductive setting, in the setting of primary RCC. CytoShrink completed enrollment, and Samurai is ongoing. So these studies will also provide more answer in terms of whether there indeed is a synergy between IO and SABR. So in conclusion, SABR in the setting of oligoprogression for metastatic RCC is effective in providing local control without high-grade toxicity of concurrent SABR and the ongoing systemic therapy, both IO and TKI. It does preserve patients' quality of life. It extends the duration of ongoing systemic therapy, and it is supported by single-arm phase 2 data. Now, no phase 3 randomized trial is ongoing. We are currently designing one with the cooperative group ECOG-ACRIN, but we don't know yet if this will lead to overall survival benefit, because you can always think that by delaying the systemic therapy or change of systemic therapy, you may be making that next line of systemic therapy less effective, even though you're clearly increasing the PFS of ongoing systemic therapy. So a randomized evidence with overall survival endpoint is still very important, and that is currently lacking. The benefit may be higher with ongoing systemic therapy with IO. At least that is what we are seeing in our updated about 100 patient retrospective analysis that is currently going through peer review. So it will hopefully be published in the future. And lastly, this type of, in the lack of randomized level 3 evidence, what we really need to do is combine forces, and we are building a consortium to combine multi-institutional database for oligomet and oligoprogressive RCC patients. If you do have such patients to contribute, please reach out to me. We would be happy to have you on board. With that, thank you very much for your time.
Thank you so much, Dr. Hanan, for this insightful discussion and indeed very important topic. And now it's time for our panel discussion, and I will invite our discussant to be here. Let me introduce Dr. Yosef Zakaria from USA, who is the Vice Chair of the Genital Urinary Malignancy Disease Group and Medical Oncologist at the Mayo Clinical Comprehensive Cancer Center. And you already had the chance to meet Dr. Tang and Dr. Hanan, and I'll give floor to Dr. Yosef to initiate the discussion and be the lead. Yes, we can hear
you. Hear me? Yeah, thank you, Amalia. Good afternoon, everybody, or good evening throughout the world. Thank you, Rakib and Chad, for very innovative and interesting talks. Historically speaking, kidney cancer has always been thought to be resistant to radiation therapy, and clearly that is changing nowadays, and thanks to your efforts among many others in the field leading this change. And indeed, in my practice now, I utilize radiation therapy relatively, more frequent nowadays compared to 10 years ago when I started my career. So I would like us to have a very interactive discussion with the audience here from the chat. So please, if you have any questions to our experts, please list them in the chat here. I do see one question came through. It says, what treatment guidelines do you use for the Sunnymeter? I would, if I were to interpret this correctly, maybe what size of kidney masses you would utilize if, let's say, the patient had kidney mass that is not amenable to surgery for comorbidities, and you're going to use SBRT in this setting. Maybe the audience is asking, like, what size criteria you would use for SBRT. And I would add to that, how much renal insufficiency do you expect from SBRT of the kidney?
Very good question. I'll take the first attempt, and then maybe I'll pass on to Chad. So I do get this question very frequently, and I give the same answer that size is really not an issue. It's really the location. So we have treated, even 15 centimeter tumors or higher. It's really the location. So if you have a tumor and that is completely exophytic and in the anterior wrapped around bowel, that becomes challenging. But really, vast majority of the kidney tumors are not that. So it is fairly easy for us to treat it. And then the other thing to consider is the changing and advancement of technology. So it would depend on what technology is available to you. So with standard SBRT setup, the vast majority of the kidney tumors can be treated. But with more advancing technology like adaptive treatment, MR-guided radiation, and others, and these adaptive platforms allows us to take into account even bowel motion that happen daily or even during the treatment. And then during treatment tracking, all of these technologies allows or increases our breadth in terms of what we can treat going forward. And lastly, the decline in kidney function as a result of radiation is also something very dependent on the location of the tumor. So if you have an endophytic tumor that has a lot of normal kidney parenchyma surrounding it, yes, we should see some decline in kidney function. Typically, we see it on the order of 10 to 14 mLs in eGFR decline. And that always starts a discussion because many of the patients coming with kidney cancer actually have baseline kidney function decline. So you would want to consider that and build that into your discussion and recommendation for the patients.
Great. Thank you so much. I don't know, Chad, do you have anything to add? You're muted. We cannot hear you still.
Something to do with your microphone, probably.
Yeah, probably the microphone. We see you here. We see you talking, but we cannot hear you, unfortunately. So I'm going to continue with you then, Rakib. So if you have a central mass in the kidney, let's say it's a urothelial, upper tract disease, would you feel comfortable radiating that, or you focus just on the?
That's a very good question. So, and that's a key distinction between radiation and all the other ablative techniques. So, in fact, the pelvis of the kidney, we don't even put a constraint. There is no constraints. So as opposed to in ablation and other techniques where you're destroying the tissue, radiation is actually not destroying the tissue. It's killing the tumors by doing DNA damage. So the tumor dies, but the rest of the architecture stays intact. There is some fibrosis, which does not make the renal pelvis non-functional. So the only thing that will make the renal pelvis non-functional is if you put a hole in it. But radiation creating fibrosis is not doing that. So yes, we are treating kidney tumors in the pelvis, including renal hilum, all the time. In fact, urothelial cancer originating from renal pelvis is completely another separate topic. And I think it's in a very good place where stereotactic radiation would have an indication. But even for renal, yes, I think that's not a problem for us at all.
Great. Thank you. I think we have Dr. Tang now back. Chad, do you have anything to add about? Do you hear us?
Upper? You hear me now?
Yeah. About what is your cutoff size for in your practice? I know Dr. Hanan already alluded to that, but in your practice, do you have any cutoff size?
I think Dr. Hanan had an excellent explanation of everything, and I really agree with everything he said. I think to add to his points, it's always for me when there's a smaller renal mass, whether surveillance makes a lot of sense. So it depends on whether we should surveil or SBRT, because a lot of times they're not a candidate for surgery when they're seeing us. Ablation is another option, less than 3 centimeters, but usually our urologists at least will send to IR before they send to us. So we usually talk about surveillance versus not. My only thing is if it gets larger, greater than 8 centimeters, I start doing more fractionated approaches. I'll do one or 3 fraction for smaller tumors, but as it gets larger to 8+ centimeters, I'll start doing 5 fraction treatments a lot more often, just because I'm not sure of all the interface of bowel and I want to spread it out a little bit more. Now, in terms of the GFR cutoff, I agree with Dr. Hanan. In the trials that have been reported out, the most recent one being Fast Track 2, the prospective one, the median GFR on enrollment was 60, and it decreased to 15 points to about 45 at 2 years. And so that's about a quarter of the GFR function. So I always titrate that to the patient. They're coming in at 40. I say you may lose 10 points. You don't have, if you're 30, you may lose another few points, not as much as 15 probably. But I'll usually say about a quarter. And if you have a single kidney, that's probably going to be a little bit more pronounced because you don't have a second kidney to compensate for any reductions. So just some additions to Dr. Hanan's excellent points.
Cool. Thank you so much. I want to ask about the histology of kidney cancer. Like, do you see the responses for clear cell similar to non-clear cell? I just had a chromophobe histology recently. I was not sure if radiation would be an option. And towards that end, how much do you care about getting a biopsy prior on a single kidney, let's say, prior to starting your radiation? Do you care for a biopsy, or if you believe clear cell and non-clear cell respond the same, you would just treat it without a biopsy?
So I can again take a stab and then maybe give it to Chad, or unless you want to do it vice versa.
Go for it.
So in all of our retrospective experience, both primary and metastatic, we looked at clear cell and non-clear cell, and we never found a difference in local control. So very recently, which just came out online, available last week, I believe, in the Red Journal, the IROC Consortium's multi-institutional experience on primary renal specifically looked at this question of clear cell versus non-clear cell, and again showed no difference in local control. So we know stereotactic radiation works just as effectively for pretty much all histologies, and specifically even chromophobe. I have had experience treating those patients effectively with giving them local control with radiation. So biopsy is the next question, right? So, again, with the improvement of MRIs and even sometimes giving us clear cell scores, I think we have seen that in some of the talks previously, the need for actual biopsy to confirm malignancy is becoming less and less important and necessary. However, and again, some of these patients are not surgical candidates. They're on anticoagulation and multiple other comorbidities, and some of them don't also want anything invasive. So in that setting, if I'm reasonably sure based on the imaging, then I would proceed without a biopsy. But with any doubt, yes, we want to get a biopsy confirmation.
Cool. Thank you. Thank you, Rakib. Chad, any?
Yeah, I think to add to that, so other considerations for metastatic sites. There are a number of kidney cancers that are more rare that actually are quite sensitive to radiation. We see through just referral patterns a lot of renal medullary carcinoma, and they just act very differently. Their chemotherapy is what we use to treat, and generally chemotherapy responsive tumors or radiation responsive tumors. So we found those to be actually very radiation sensitive. I stopped doing SBRT for those almost because they're just so sensitive to radiation. They kind of melt away. Translocations I've generally also seen to be quite sensitive to radiation. I think chromophobe and papillaries radiographically seem to behave a lot like clear cells, although Dr. Hanan told me if you see differently. And I think especially for chromophobes, we're more often in the metastatic setting asked to do local therapy because there's a lot less systemic therapy options for these. So just that when there's less systemic therapy options, we tend to try to do local therapy more. So just additional thoughts.
Great. Thank you, Chad. I'm going to stay with you for the next question. And please, from the audience, I still do not see any question in the chat. So, Chad, we know like from the melanoma data, targeted therapy like BRAF inhibitor and radiation, I know the radiation oncologists do not like that combination. How much do you worry about TKI and radiation combination? Do you hold TKI while you are doing radiation, or you don't?
Yeah, it's a good question. So, they all have different half-lives. The TKIs, cabo, it's in very short. But what we've done recently to make things less confusing is just stop a day to 2 days prior and then restart a day to 2 days after. Just so that I know a lot of, for like cabo, we're probably not out of the system yet. It's not definitely not 5 half-lives. But at least it's not peaking while we're doing radiation. However, I don't have data yet to support this, but I do worry about the long-term effects of radiation and being on TKIs. Just talking to my colleagues of surgery, the tissue becomes a lot more frailer when a patient's on TKIs for many, especially after on it for many years. And we get telangiectasia after radiation after 2 or 3 years, especially. So I worry in 2 or 3 years the patient is doing excellently on the cabo or their EXI, and they have a problem with the telangiectasia bleeds, will they heal afterwards? And we've seen a few times where, it's hard to tell because there's a lot of different medical history that happens in between the radiation and when they have these problems. But I worry if 2 or 3 years later that they just won't heal so well from, maybe just a little bleeding from a telangiectasia caused by radiation. So that's where I worry about. But I don't know if stopping the systemic therapy during the radiation is going to make 2 or 3 years, that's going to be that event will occur less commonly. So I worry, but I don't have a good answer.
Sure. Yeah, I actually, in my practice, I tend to hold the TKI. I don't have any concern with the immunotherapy. I just keep going with it. But the TKI, certainly, I'm a little bit more worried about. Rakib, do you have any
Yeah, I
thoughts
could
on
just
that?
add a few things. So especially when the GI organs are involved, I have seen a few cases of toxicity with concurrent TKI and SBRT. So with GI organs involved, I would be more careful. But other than that, I calculate at least 2 half-lives or so, and then try to hold the systemic therapy day before and after. And the other approach of pulsar that I discussed briefly helps with that, because we can space out the SBRT and you're not holding the TKI for too long. You're only holding it for 3 to 4 days with each treatment, and then you're giving the treatments farther apart. For the most part, and there is data for it, that IO and SBRT has been safe combination. There is only one case I saw where I gave a treatment to an intra-abdominal tumor, and the colon received only mild doses of radiation, but the patient eventually, it was not my patient, then eventually started combination IO, developed colitis exactly at that location, and eventually had a perforation. So it was interesting, because with SBRT alone, we would never see that toxicity because of the amount of radiation. In mind, therapies that become approved for kidney cancer.
Certainly, I would, with the IO combination, I would be more concerned about gas, colitis, autoimmune colitis. So adding radiation to that area, certainly perforation can worsen. I do have a few more questions I can answer. I can ask. I will wait until Amelia tells us when the next session is going. So the next question is about the timing. When do you utilize, like, let's say a patient had nephrectomy and now they are recurring with localized disease. When do you use radiation for local disease without like distant metastatic sites? Speaking to your oligometastatic too, that the timing of recurrence. I just saw a patient yesterday, like recurred after 3 months, from nephrectomy. I was more tempted to start, even for local recurrence, I was more tempted to start systemic therapy on, as opposed to someone who had nephrectomy like 2 years ago and now they are recurring. I would be more tempted towards radiation. Is that a fair approach, or do you have a different cutoff for when to intervene with radiation versus systemic?
Yeah, that's a great question, and I'm sure Dr. Hanan has thoughts too, but I'll start off. So this is a gray area when it's within a year, right? Because now you're also in Keynote 564 territory, where they did mastectomy and then did adjuvant pembro. So you almost have 3 options, right? Mastectomy alone, radiation, or otherwise mastectomy plus pembro, or frontline double systemic therapy plus minus mastectomy. I don't think there's a good answer for which one's the best, and there's no randomized evidence, obviously. We did look at time from nephrectomy to met diagnosis as like a prognostic marker. Admittedly, we didn't have a lot of patients who were just 3 months after, so that's going to be a little bit underrepresented. But we didn't see like a strong association. At least that was with a p-value of 0.05. So at this point, I would say I would be okay with doing it at any time. But 3 months means 1 scan afterwards. It almost begs at least another short-term follow-up of 6 weeks before you start doing radiation alone, just to make sure that one is not the tip of the iceberg.
Sure.
So Yusuf, so this is a patient that came back with local recurrence a few months after nephrectomy, right? So to me, local, yes. So to me, a local recurrence requires a local therapy. And I would not necessarily think of starting systemic therapy other than, what Chad said based on Keynote 654, if you have aggressive features, high-risk features, or this is not considered M1. So I would treat this with stereotactic radiation and then just wait and watch. And if patient develop METs, then consider systemic therapy. Again, no randomized data available. we are rolling out our retrospective experience of about 20 some patients with similar setting of partial or radical nephrectomy and using SABR as a salvage, and we are seeing very good results.
So even within 3 months, you still would consider. I worry about more systemic disease in that setting, microscopic disease. So that's why I was more tempted to do systemic therapy. So you feel comfortable in that setting 3 months after nephrectomy still with SRS?
Because I mean, you could potentially have positive margins from surgery, and that's what is leading to a local recurrence. I mean, you are not showing me that there is any evidence that there is systemic disease. Nothing wrong with doing adjuvant pembro from the data if the patient fits the criteria, and there will be some benefit. As you know, that part is controversial in terms of how much benefit and which patients benefit. And in this setting, some of the biomarkers that Chad alluded to with ctDNA and KIM1 would be great to investigate. But initially, how much are you losing by delaying the systemic therapy and waiting to see the mets to surface? I think that's a question, we're not going to know until we do a trial.
Fair enough. Yeah, I guess that takes us to the end of this session. I want to thank you for your expertise and for leading the field of radiation in kidney cancer. And I will turn it back to Amelia.
Thank you so much for inviting us.
Thank you. Thank you.
Thank you so much for wonderful discussion. And we can move for our next speaker, Yeva Markaryan, Managing Editor of Cancer World Magazine. Her presentation will be per recording, so it's going to be live now.
Hello, everyone. It's a great pleasure to be here today among the global leaders in the field of renal oncology. My name is Yeva Markaryan, and I'm the managing editor of Cancer World. And today I'm here to give you an overview of Cancer World, of our mission, of what we do and why we do that, about our readership and our future plans. So let's move forward. First, I will give you some short introduction to our history. So Cancer World, as you may know, is one of the oldest and most prestigious oncology publications, and it has been founded in 2004 by the European School of Oncology. And for over 2 decades, it was featuring the most important news, breakthroughs, findings, voices in the field of oncology. And from 2020 to 2024, Cancer World was founded by the Sharing Progress in Cancer Care, and they continued its mission, and they did just fantastically. Then in 2025, Cancer World was acquired by OncoDaily and is now owned and published by P53 Incorporated. And starting from January 2025, I became the managing editor of Cancer World. To be honest, it was really hard because I knew that there's such a big responsibility on my shoulders to keep that legacy, that high quality publication that Cancer World was known for, and to also try to bring some novelty to it. But so far so good. And now I'm happy to give you more information about what has been done during this 7 months and what progress we made in general. So first of all, I would like to tell you about our mission, our audience, and the impact that we have and we hope to have. So the mission of Cancer World is to connect oncologists, researchers, policymakers, and patient advocates to explore critical issues in cancer care and provide patient-focused, inclusive coverage of cutting-edge science, treatment and policy while fostering a dynamic online community for collaborative learning and discussion. Our audience is mostly healthcare specialists, researchers, patient advocates, policymakers, and other key opinion leaders in the field of oncology. And the impact that we have and that we hope to maintain is fostering collaboration, raising awareness, influencing policy, connecting key opinion leaders, and empowering patients by giving them a platform and highlighting breakthroughs in cancer care. So our editorial team consists of Professor Adriana Albini, who is also the scientific collaborator at the European Institute of Oncology. She's the past chair at Cancer Prevention Working Group at the American Association for Cancer Research and president of European Women's Management Development. Our next co-editor-in-chief is Lydia Shapira, who has recently joined our team and has already been actively participating in all decision-making process and strategies, giving valuable advices and promoting the progress. She's also professor of medicine oncology at Stanford University, director of cancer survivorship program at Stanford Cancer Institute, and director of CME program development at the Department of Medicine at Stanford School of Medicine. The managing editor, myself, and Janet Fricker, who's our news editor, has been working with Cancer World since the beginning and delivering fantastic news pieces, always up to date, and also not only news pieces, but also editorial pieces, featured articles, and etc. Besides the editorial team, of course, we have international journalists and contributors from almost all over the world. We have journalists from North America, from Africa, from Europe, Asia, and we plan to expand our list of journalists and contributors to be even more inclusive. These people give wonderful pieces from all over the world, first-hand experiences, first-hand stories, interviewing people in their native languages and delivering articles, delivering news pieces, delivering important messages from all over the world, messages that travel the world through our pages and let the people know from other continents and globally what's happening and what are the most important disparities, issues, breakthroughs in different parts of the world. So what kind of content formats we develop? As I said, we try to be as inclusive as possible. We try to be always up to date, and we always try to include the most important points, the most important issues in the field of oncology. We do it through news pieces, which are the most up-to-date information, usually covered by Janet, and they are the new research findings, the breakthroughs, the promising therapies, the award-winning stories, and she always interviewed the principal investigators, the people behind all these breakthroughs, to have that first-hand information from them. And we also plan to include a third point of view in all these news pieces to be even more inclusive and interactive. The editorials, which are usually bigger pieces about important issues, about cancer prevention, about genetics, about developments in the field of oncology. interviews to experts and profile articles, which are usually in every issue. We have not only the cover stories, but also interviews with key opinion leaders in the field of oncology. And they usually share their career insights, personal and professional advice. They tell their story, their mission, the driving forces of their career. And the voices, which are usually about communities or people who has been affected by cancer and who tell about the disparities and the issues that they were impacted by. We try to be a platform from them and to raise awareness about all these issues and to help their voice travel through the continent. And once P53 OncoDaily acquired Cancer World, we decided that we will be back to print. So for the last few years, Cancer World was exclusively digital, but we think that some articles, some pieces, some works are too important to just scroll them and forget. They need to be read again and again. They need to be held and they need to be kept somewhere. So we decided that we will have the magazines, we will distribute them through the world, we will distribute them during the major oncology congresses and events, and we will succeed. So during the 7 months, we had 7 issues graced by important decision makers in the field of oncology. Our first issue was had a cover story of Dr. Mehdi Apro and the cancer breakthrough from no response to no recurrence about Bodbal treatment, promising treatment. Then we had the second issue of Lorelei Mucci and Philip Kantov. The April issue was graced by Dr. Samuel Danielian and Arnaud Lalut. And the January issue was graced by Princess Adila from Saudi Arabia and Alberto Costa. Then it came then it came Suhair Rasul and Albertina, which is actually the AI that as our contributor as well. We decided that we need to have AI helper, AI contributor that will show that the other side of AI in oncology, not the side that will replace people, but the side that will help them to generate millions of articles and lots of data to help people to make decisions more easily. We had Jennifer Buell and Jay Iyer on our dual covers of August issue, and Patrick Sunshine and Royal Highness Princess Dina on our recent September issue. All of these issues were presented in major oncology events and congresses such as ASCO, SIOP Europe, and etc. Then, as I already said, besides having the cover stories in all our magazines, we also feature global voices in the field of oncology, the leading voices that share their stories, their missions, starting from their childhood till their future plans, and revealing not only their career but also some personal details to learn more about the people behind all these breakthroughs and actually learning about themselves, not just their career. And we also keep partnering with European School of Oncology. We feature the European School of Oncology college members, their stories, and we also have European School of Oncology College Voices contest. So the first one was organized recently, and the topic was social media friend for cancer patients, with 27 proposals from ESO college members across 20 countries, and based on the several criteria such as the editorial style of Cancer World, the importance of having different point of views and comprehensive research, we decided to move forward with two winners, Dr. Ina Supan and Dr. Joanna Mijutic. And their articles will be, one of them was featured in our September issue, Dr. Ina Supan's piece, and the next one will be featured in our upcoming issue. Then we also increased our digital presence, and we continue to work in that direction. We had 600% rise in our website visits since acquisition. We now have a LinkedIn profile, and we formerly had Twitter X profile, and we kept developing it. We already have Cancer World Facebook page, and now we continue also to have our bi-weekly newsletters, which have 60% open rate, and deliver the most important articles published in Cancer World, both digital and magazines. And I would also like to share the feedback from our interviewees, the opinion leaders, policymakers, advocates, cancer patients who were grateful for being featured in Cancer World and for raising awareness about the work they do, about their story, and beautiful articles that we were honored to have in our magazine. And in the end, I'm happy to share that recently I had an opportunity to finally meet Dr. Alberto Costa, the founder of Cancer World, discuss with him millions of things about Cancer World, about its past, legacy, and our future plans. And I think that we have lots of things to come, so stay with us. You can contact me via provided contact information if you have any suggestions, if you have any questions regarding our publication. And we're also open to contributors from all over the world. So if you have interesting topics to raise awareness about, if you have interesting ideas, do not hesitate to contact us, to send your pieces, and after our editorial review, you will have a chance to be published in Cancer World. So thank you very much, and enjoy the Congress.
Thank you once again for a great presentation. And now we can move on with Dr. Elizabeth Leo from Australia, medical oncologist and head of Australian KRAB Registry and adjunct lecturer at Monash University. Please, Dr. Leo, can you share the screen so we can check that everything is correct? Great, we can see your screen. Please show the next page so we can see that it is moving. Yes, that's great. So stage is yours.
Lovely. Good day, everyone. It's a real privilege to be here to share some perspectives on the evolving kidney cancer landscape from an Australian lens. What I'd like to do is to walk you through where we're at in Australia, what's happening in our clinics and our multidisciplinary meetings, the wins, the gaps, and the work that's still ahead where we can do better. I'll walk through some Australian data that's come from CRAB, our National Kidney Cancer Registry, and show how we've turned CRAB into more than just a data collection tool. It's helped us understand who gets treated, how they're treated, and when they're treated. And using that window into real-world practice, we've turned it into a springboard for insight and hopefully a platform for change. And finally, I'll touch on where we're heading, the questions that we're asking next, what's needed, and how we hope to align our future work with what really matters in practice. Thanks very much for the opportunity to be part of the discussion. To give you a sense of the scale, kidney cancer is the 7th most common cancer in Australia, with around 4,500 new diagnoses and around 900 deaths each year. At any one time, about 14,000 Australians are living with the disease. And so while it's not the most headline-grabbing cancer, the burden is significant. And the biggest pressure point is not surprisingly in the advanced disease space. That's where the system feels it the most, in care, in cost, and in complexity. We are very much aligned with global best practice when it comes with kidney cancer care in Australia, but just as importantly, we're actively contributing to the push to better and more personalised care. I want to spotlight some of the key Australian contributions to the kidney cancer landscape and highlight some areas that are in vogue here. Let's start with diagnostics. Here, we're seeing cutting-edge developments like carbonic anhydrase 9 targeted imaging. And we're also making really great strides into mainstream precision oncology with a free national molecular screening program that's making comprehensive genomic profiling accessible to many, many patients. In the management of primary tumors, surgery remains the mainstay, and where a robot is available, robotic techniques are being pushed out. Our surgeons are pretty united in their nephron-sparing mindset, and wherever feasible, they have a clear preference for partial nephrectomies. We're also seeing some novel non-surgical approaches to primary tumor management. Ablative techniques, radiofrequency ablation, microwave ablation, and cryoablation are gaining traction as alternatives to surgery, particularly in patients who are borderline or not surgical candidates. The Fast Track trial run here in Australia showed remarkable success in using stereotactic radiation in older or non-operable kidney cancer patients. On the adjuvant front, when the Rampart trial reads out, we would have made our contribution to the global adjuvant evidence base with durvalumab and tremelimumab. Metastasis-directed therapy is firmly part of our practice for oligometastatic or oligoprogressive disease cases. And we take particular pride in our growing expertise in stereotactic radiation, not just for primary tumors, as I've previously mentioned, but for metastatic disease too. And we do this as part of our strategy to spare patients the need for systemic therapy as much as possible. And in the advanced disease space, we are definitely keeping pace with systemic therapy evolution, but we're not just adopting new treatments, we're helping to come up with new ones. In metropolitan centers, we're proud to champion early drug development, including trials with radioimmunotherapy agents, cancer vaccines, and CAR T therapy. Let's take a closer look at a few key areas where we're seeing significant momentum and exciting developments. One standout example of Australian diagnostic innovation comes from right here in Melbourne. Telix Pharmaceuticals have developed a diagnostic platform that's changing the way we detect kidney cancer. Their phase 3 ZIRCON trial using zirconium-labeled girentuximab, a monoclonal antibody that binds to carbonic anhydrase 9, which is highly expressed in clear cell kidney cancer. This is mirroring the utility of PSMA-targeted approaches in prostate cancer. This radiotracer performed really well, 85% sensitivity, 87% specificity, meaning that this tool could potentially reduce the need for biopsy in certain patients, especially those in whom biopsy wouldn't be very safe. This case that you're seeing is a 40-year-old male with a very small 12 millimeter lesion, in fact, in the right kidney, glowing positive very nicely on zirconium girentuximab PET scan, and this was later histologically confirmed to be clear cell kidney cancer. Following zirconium girentuximab, I'm proud to say that the next leap in carbonic anhydrase 9 targeted imaging is also coming from right here in Melbourne. Michael Hoffman and Ben Tran and team are spearheading the use of a radio-labeled small molecule peptide that offers faster kinetics with same-day imaging capabilities and potentially broader utility. What you're looking at on screen are outstanding images from gallium-68 labeled carbonic anhydrase binding peptide, DPI 4452. And this platform is extraordinary, as you can see. It visualized many tumors not seen on CT. What's also exciting is how quickly it works post-injection. Tumor uptake is seen in just 15 minutes. It persists for 4 hours, and then it's just very quickly cleared. Tumor to background contrast is so high, contrast is so clean that the background organs are nearly invisible. The optimal imaging time point is just 1 hour post-injection, which is dramatically faster than the 3 to 7 days that it takes for zirconium girentuximab. Now, in prostate cancer, we've all witnessed the impact of PSMA-targeted diagnostics and therapeutics. And with these strong imaging results, this peptide is now being pushed forward into theranostic territory using lutetium-177. I want to spend a moment talking about belzutifan because it's a great example of how Australia can do really well in adopting novel therapies, especially for rare and complex cancers like VHL-associated kidney cancer. As we know, LightSpark 004 delivered a landmark breakthrough in how we approach VHL-associated kidney cancer. But what makes this belzutifan story extra special in Australia is the role of patient advocacy. The work of NECA, Neuroendocrine Cancer Australia, helped get this drug reimbursed a lot more quickly than usual, making it instantly affordable. The price tag fell from $12,000 per month to as low as $7 a month for patients. Later, I'll share why this is unusual and why it's such a big deal, because many drugs take years to get approved for reimbursement. Plus, this approval is boosting genetic testing and has led to better care pathways for patients with hereditary cancers nationwide. Next, very quickly, I want to highlight a truly transformative national initiative underway in Australia right now, a world-leading, no-cost, comprehensive genomic profiling program for patients with metastatic solid tumors. Patients who are referred have their archival tumor specimen retrieved. The molecular profiling is done, and the results are reviewed by a molecular tumor board, which then provides a comprehensive report to the referring clinician, including information on matched clinical trials. I think this is nothing short of groundbreaking because this program has brought precision medicine into routine care on a national scale. I'm a PhD candidate at the Walter and Liza Hall Institute, or WEHI, which happens to be Australia's oldest medical research institute. And what excites me about WEHI is how we bridge the gap from basic science to real-world impact, especially in cancer. And we're not just in the lab, we're working alongside doctors, patients, and policymakers to turn discoveries into better treatments and care. One of our key tools at WEHI is CRAB, our National Kidney Cancer Registry. I'd like to acknowledge Ben Tran, my esteemed mentor who first brought the idea of CRAB to life, and he set the direction from the very beginning. It's a real privilege to be part of CRAB and to carry this work forward with his mentorship. CRAB is now a growing data set of over 1,000 patients across Australia, and we track treatments and outcomes with a fair bit of granularity. And ultimately, CRAB lets us see the big picture. It lets us spot trends and find gaps in our local practice. We're pleased to contribute CRAB data to the IMDC, and we're very grateful to Danny Hain, who has graciously welcomed CRAB into the fold, a collaboration that's helping connect our local insights to the global real-world kidney cancer landscape. One of the really valuable things that CRAB allows us to see is treatment sequencing, who's getting what and in what order. These Sankey diagrams give a high-level view of how therapies are being prescribed across the country. And our Kaplan-Meier curves align with standard expectations on how patients might fare based on IMDC risk stratification. And we can go further, analyzing survival based on first-line treatment options, which really opens the door to some really interesting insights, especially in areas where randomized trials are not really easy to do. For example, I think that everyone's interested in how IO-IO and IO-TKI regimens compare. I now want to highlight some challenges in treatment access to systemic therapy that are pretty unique to Australia, and I'll pitch it against global timelines and access to give you the full picture. But first, let me start with some context on Australia's healthcare system. We have a robust, socialised medicine model centred around Medicare, which provides universal healthcare coverage to all Australians. A key pillar in this system is the Pharmaceutical Benefit Scheme, PBS, which subsidises the cost of medicines, including cancer therapies. Once a drug is listed under PBS, patients pay only a small co-payment, typically $10 to $30, and the government covers the rest. That's great for equity, but getting a drug under PBS is a whole process in itself. After the drug is approved by the TGA, our equivalent of the FDA, it must go through additional processes. Health Technology Assessment via the Pharmaceutical Benefits Advisory Committee, PBAC. And the PBAC doesn't just look at whether a drug works. It looks at clinical effectiveness, cost effectiveness, comparative outcomes, and the overall value to the healthcare system. It's a rigorous, evidence-based process rooted in the principle of value-based care. The PBAC aims to recommend treatments that deliver meaningful outcomes at a sustainable cost. Now, this model is important for long-term equity and sustainability, but it does come with trade-offs. And specifically, it introduces an extra step that often delays access to new therapies compared to countries that don't have such structured processes. It's thorough, it's evidence-based, but it's slow. And so when we look at how Australia compares to the US or Europe in terms of access to kidney cancer therapies, it's important to view it through this lens. Our system works well, but it works slowly. I've made this chart, which I hope tells a nice, clear visual story about how long it actually takes for patients in different countries to get access to treatments after the science is out. On the x-axis, from left to right, we've got the 4 game-changing trials in advanced kidney cancer: CheckMate 214, Keynote 426, CheckMate 9ER, and CLEAR. And the y-axis is time in months. And each colored bar shows the time it took for key regulatory agencies to approve the corresponding regimen, starting from date of publication. So you'll see the FDA in light blue, the EMA in dark blue, Health Canada in yellow, our TGA in orange, and finally PBS listing in maroon, which is when the drug actually becomes publicly reimbursed and accessible in Australia. As expected, the FDA moves quickly, sometimes faster than publication, thanks to mechanisms like accelerated review or breakthrough designation. The EMA and Health Canada follow with a lag of a few months. And then there's Australia. The TGA is slower to approve, but even after a drug is approved, the real delay often comes after that, the time it takes to be listed on the PBS so it's accessible to patients in the public system. And if you're wondering, yes, this chart took me ages to make, but still not as long as it's taken to get pembrolizumab lenvatinib on the PBS. So this is a closer focus on the last mile problem, our bottleneck for access. The science is done, the drug is approved, but patients still can't get it, sometimes for years. And that's where we're at right now with 426 and 9ER, excellent regimens that are still not PBS listed. It's not a simple issue. It involves health technology assessment, pricing submissions, and budget impact reviews, but the outcome is straightforward. Access delayed is access denied. I now want to bring in some real-world data from Australian clinical practice that sheds light on how access policies affect treatment decisions. After publication of Checkmate 214, which we all know demonstrated the benefit of combination immunotherapy in intermediate and poor risk patients with advanced kidney cancer, prescribing patterns in Australia barely changed. So in the first line of blue syringes, as you can see there, utilization of ipilimumab/nivolumab was 2% pre-Checkmate 214. It stayed at 2% after publication of Checkmate 214. However, once PBS reimbursement was secured, we saw a sharp and immediate shift in real-world prescribing, which leapt up to 55%, as you can see in the third line of blue syringes. And in the bottom half of the screen, you see the corresponding changes in the use of tyrosine kinase inhibitors in the same time frames. Pre-Checkmate 214, the rates of tyrosine kinase inhibitor use was 79%. Post-publication of Checkmate 214, it remained static at 76%. But post-PBS listing of ipilimumab/nivolumab, TKI prescribing fell to just 21%. Now you may think, are Australian clinicians simply slow to pivot? Well, no, because if you look at surgical practices in the realm of oncology, which do not depend on the PBS, changes in practice happened very quickly following publication of another seminal trial, Carmina. Our rates of upfront cytoreductive nephrectomy fell from 70% pre-Carmina to 33% post-Carmina. And this highlights how evidence alone is not sufficient to drive practice change in Australia without concurrent policy and funding support. In other words, PBS reimbursement is the key inflection point and the main gatekeeper for translating science into real patient care. So the next question becomes, if a new treatment were to get approved, how many patients does it apply to in the real world, and who stands to benefit? And that's where CRAB becomes incredibly useful again. With this registry, we can start asking forward-looking questions like who would qualify for the next big treatment and what kind of impact would it have at a population level. Let's take Keynote 564 as an example. And as we all know, this study has positioned adjuvant pembrolizumab as a new standard of care for patients with high risk of recurrence after surgery for clear cell kidney cancer. Now, I've already shown you that Australia's approval and reimbursement processes take time, so this is not yet available to our patients. But if it were, how many people would be eligible? We turned to CRAB to find out. Specifically, we looked at data from my home state of Victoria and identified 464 patients who underwent curative intent nephrectomy between 2016 and 2022. And among those with clear cell kidney cancer, 21% met Keynote 564 criteria for adjuvant pembrolizumab. Using this proportion, we did a rough national extrapolation. In 2022, there were 4,552 new kidney cancer diagnoses in Australia. Around 15% present with synchronous metastases, so that leaves approximately 3,600 patients with localized disease each year. If 21% of those would meet Keynote 564 criteria, that's roughly 765 patients per year who would be eligible for adjuvant pembrolizumab based on histology and risk features. Now, of course, this is an estimate. Not all eligible patients will go on to have treatment due to age, comorbidities, preference, and other access issues. But it still gives us a ballpark figure that's useful not just for clinical planning, but also for health economics. In Australia, we know that the PBS plays a crucial role in determining what's accessible to patients. And data like this, drawn from CRAB, helps inform cost projections for new therapies. And to bring this back to the human level, the median age in our cohort was 64. The median life expectancy in Australia is around 83 years. And if adjuvant pembrolizumab results in an additional 8% of patients being cured each year, that's roughly 61 people gaining an average of 19 additional years of life. That's about 1,159 life years saved annually. So as you can see, these kind of estimates are useful not just for understanding potential clinical impact, but also for informing PBS cost effectiveness, resource planning, and population health modeling. I now want to turn briefly to non-clear cell kidney cancer. In Australia, because of the PBS processes that I outlined earlier, there was until recently nothing reimbursed for patients with non-clear cell disease. We now have a single reimbursed option, cabozantinib, in the frontline setting, and even getting that far required significant effort. And this is where ANZUP, the Australian New Zealand Urogenital and Prostate Cancer Trials Group, deserves enormous credit. So this is our national cooperative group, and they stepped up with two huge efforts to fill this gap, Unison and UniCab. Unison opened up access to immunotherapy for non-clear cell patients at 19 sites across the country. Patients received nivolumab, and if they progressed, they had the opportunity to escalate to nivolumab plus ipilimumab. And then came UniCab, which provided many of the same patients a second-line option with cabozantinib. These were landmark efforts, not just for generating evidence, but for giving our patients access to therapies that they wouldn't have otherwise had. As an investigator on these studies, I have patients who are now in complete remission, so these weren't just studies, they were lifelines. And therefore, when we talk about slow approvals or no approvals, this is what meaningful homegrown solutions can look like. And sometimes when the system doesn't move fast enough, ends up to the rescue. And lastly, we talk a lot about evidence, innovation, and access, but there's a tough truth in Australia. Where you live can determine how long you live. And one of the things that quietly shapes kidney cancer care in Australia that doesn't make the headlines is distance. Our centres of excellence where trials run and specialists work are mostly in major cities. But many of our patients live far outside these hubs, often needing to travel hundreds or even thousands of kilometres for care. A patient living in suburban Melbourne might see a medical oncologist, join a trial, and access PBS-funded treatments all in the one day. But for some patients, getting to treatment means long drives, overnight stays, and sometimes multiple flights. And the strain on patients and their families, logistically, financially, and emotionally, is not to be underestimated. Telehealth has helped, but it doesn't replace systemic therapy or trials. And the reality is that disparities in access remains. You see here an image from the Cancer Atlas Australia showing survival patterns by geography. Blue means above average survival, yellow means survival at the national average, and red is below average. And at first glance, it looks okay, mostly yellow. But as we zoom in, a sobering picture emerges. Melbourne and Sydney glow blue, the outcomes are excellent. But you drive just an hour or two out, and suddenly it's red. And then there's the Northern Territory, a sea of orange. And on the periphery, the red is back. It's a pretty blunt reminder that your postcode matters. Distance from care translates into real outcome differences. At the start of this talk, I told you I'd give you an Australian lens on kidney cancer. And what I hope you've seen is that while we face very real challenges in access, in geography, and in timing, we also have the tools to do something about them. And CRAB is one of them. I'll leave you with a slide of our wish list. And because I'm a registry girl, this list is registry orientated. And these are some innovations which I hope you'll find interesting. Some of the things that we hope to do are things like national linkages to make our data even more impactful. We want to embed patient-centric enhancements, really cool things like direct choice experiments. We want to have more sophisticated research enablement like genomics and molecular data linkage. And we want to be able to tag a cohort that's trial ready. We want to use data to guide and improve everyday clinical practice. We want to create benchmarking programs and feedback loops. Thank you so much for the opportunity to share a bit of our Australian story. I've been so excited to show you where we're at and where we're headed next. Thank you.
Great. Thank you very much. Appreciate the opportunity to be here. My name is Brian Lewis. I'm the CEO of KidneyCan, and I wanted to take this opportunity to thank the organizers, OncoDaily, and as well as Drs. Rana McKay, Dr. Yüksel Ürün. Thank you very much for having the patient voice be heard on your programming. We appreciate it. Appreciate the opportunity to be here. I want to put a disclaimer up right at the beginning. I'm going to be talking quite a bit about the United States and our government and the way we are allowed, or our government funds medical research. So much of this will be centered on the United States in terms of our legislative process. I hope that doesn't bore people. I just wanted to use this as an example to other patient advocacy groups around the globe, that your voice does matter and your voice counts. And so we hope that you can use some of the lessons from what we've done here across the globe. With that being said, thank you very much again. The next slide is my disclosures. KidneyCan is an organization. We're a nonprofit organization organized in the United States. We receive funding from not only pharmaceutical partners, but also patients and caregivers and families around the world. I'm on a couple of guidelines panels, as well as the NCI, the National Cancer Institute's Renal Task Force, and on the board of directors of the International Kidney Cancer Coalition. My story started in 2007, and I am a patient survivor. And part of the reason for me being here today is to drive home some of the messages that I learned early on and propelled me to want to be giving back what I've learned in the patient advocacy community. So KidneyCan, just wanted to share with you, has been formed by a number of patients and their families. It's built out by caregivers and folks that are directly impacted by this disease. And we're run by a board of directors that has a number of patient advocates as well. Next slide, please. So how does our mission at KidneyCan is to accelerate cures. And we do that, and we represent it in this circular diagram here. And if you can sort of bear with me, it usually is scrolling around, but in this instance, you might have to turn your head a little bit. if you begin with the awareness green down on the left-hand side, we believe that bringing awareness to kidney cancer is our first role. And just because the landscape is littered with a number of disease groups and everybody's vying for attention, so we have to raise kidney cancer up to be a part of the conversation. Many of you might know that in the United States, it's number 8 or 9 in terms of men's and women's cancers, incidence, and mortality. And we keep driving the message home that we've been underfunded for many years and we're trying to catch up. And so in order to build that awareness, we feel like awareness then leads to actual patients and caregivers and researchers becoming advocates and going to speak to other people about the importance of research and funding. And we've been, and I'll share a little bit about how we've done that in just a couple of slides, but we've been very fortunate in getting some funding from our government for kidney cancer research, specifically for kidney cancer research. And that's helped generate a whole new younger generation of early researchers, as well as mentors and that are out there bringing along the community. And our hope is that the funding that funds that research will ultimately lead to a cure. And that's our circular diagram there that we work off as our mission at KidneyCan. Next slide, please. Aside from that, KidneyCan does have quite a few resources that we refer to and ask patients to refer to. We've not gone out and created a lot of new material. We've used existing organizations, created content and material, and tried to bring that together and synthesize it. And so on our website, you can find a number of resources for early diagnosis, getting to an academic center of excellence, building a care team, on and on to living well with kidney cancer. Our second area that we highlight is what we call our town hall series. And that's a way that we bring experts in kidney cancer on screen in a situation sort of like this, where we ask them to present latest information on kidney cancer. And we do it on a themed basis across the year. And then we invite patients and caregivers to come on live onto the broadcast and ask their questions of the experts. And so we'll do a program on looking back and looking forward, where we're looking at the research that's come down to phase 2 or 3. And then we'll also be talking about new research that's going to be coming forward in the next coming months or years. And that's our town hall programming, along with some other just general topics throughout the year on nutrition or living with kidney cancer, other topics. You can check our website for those topics. We have another one that's going to be coming up at the end of October. It's going to be focused on nurses. Anyway, the third area that I just want to highlight real briefly is we are a member of what is called Smart Patients, which is a global network of more like a family of kidney cancer patients and caregivers. And those folks as well, we highly recommend. So here's just some examples of some of the topics on our patient education and support. You can see, you can feel free to look through that material and get additional information and other resources. Next slide, please. Here again are some of the folks that we've had, some of the topics that we've had over the years on clinical trials and immunotherapy topics, and a variety of topics with some of the thought leaders in kidney cancer. And these are as well on our YouTube library if you'd ever like to look at them. The next slide, please. And this was Smart Patients that I'm talking about. If you're out there and you're looking for a community, it is a gated community in that you have to be approved to join. It's not open to the general public. You have to have a connection to kidney cancer, being either a patient or a caregiver or someone related. And in that community, you can either be anonymous or you can be yourself, and you give yourself a tag name and you go in, and topics range from what it's like to have side effects to references of terminology, what a certain test results mean. Just about anything is open for discussion. They do limit it to, they don't allow political conversations or fundraising, and of course no rude or obscene remarks, and otherwise it's a great forum for folks to be able to share. Then we share our Kidney Can social media links here. If folks, we'd love for you to follow us and be a part of our community as well. That being said, we can move on. We'll talk a little bit about advocacy here and what we've been doing in the United States. So next slide, please. So what does it take really to accelerate cures? And we know it takes a lot of people and it takes a lot of money. And here's just a quick diagram of recent funding in the United States. The American Cancer Society was funding different grants, and you can see kidney cancer way over on the right is one of the lowest funded groups. We could get into discussions as to why that is, but overall we feel like it's a lack of awareness and a lack of advocates, and now we're trying to change that landscape. We hope our graph moves over to the left over the years to come. Next slide, please. So over the years, and this was supposed to rain down with a number of pictures coming in. I'm sorry, we can't seem to get that to be happening, but there are about 15 or 20 pictures here of what we've done going up to our government in the United States in Washington, D.C. We're allowed by our Constitution to petition our government. And so we take that literally to mean we want to go up and meet with our congressional representatives in their offices and talk to them about kidney cancer. So since 2017, we've had over 2,200 meetings with our government officials. And this is the grassroots or the hands-on advocacy that I'd like to encourage others. I know everybody that's listening here is probably operating under a different type of environment than maybe we do in the United States, but I have heard numbers of times from folks around the globe, your voice matters and your influence can be shown by being an expert, being evidence-based, and going in and talking to your government leaders. How you go about doing that, I know is very difficult, but I encourage you to try, because those folks many times have influence and the ability to help get resources to different diseases. And so we've been fortunate in that front. Next slide, please. So again, this was my circle here that was going around in a circle, but most recently in this year, we had a big crack, and you can see that sort of through the light blue funding. Unfortunately, the Congress this year decided they were going to do what's called a continuing resolution and just not fund anything going forward and just leave it at last year's figures. And so historically, kidney cancer finally got some funding, and we had built that funding up over the years and had been flat funded for the last couple of years. And then with the new administration that came in, new folks came in and they decided to just start cutting across the board. And so unfortunately, kidney cancer, its funding was cut out entirely from our government's budget. So that next slide, please. So we embarked on what we're calling a Restore the Research campaign. And starting this past spring, we started writing letters. We started making phone calls. We started asking grassroots folks around the country to call and speak to their representatives. We've been to Washington a number of times, and there were some hearings held on Capitol Hill. And thankfully, medical research is one of the issues in Washington that a lot of people do support. It's called bipartisan support. And so we're fortunate that, unfortunately, that cancer does affect just about everybody. And so people in our government have an interest in trying to work to solve some of these problems. So we've been having a very receptive audience. And the good news is we're going to be going back to Washington in just 2 weeks' time. We're going to be down there the 22nd and 23rd. We have about 40 appointments set up with our senators and our representatives in Washington. And then we have about 150 appointments via Zoom, via hybrid, phone-in calls with representatives to tell them our issues and make what we call our asks of the government. And so that'll be taking place. We have about 200 people involved in the next couple of weeks helping us do that. And we just encourage you all to do the same thing as you can in your countries to get your voice heard with your representatives. with your government officials. Next slide, please. So here's a quick but sad story. You can see that the KCRP, the Kidney Cancer Research Program, was established back in 2016. It started with $10 million was given out for research entirely, and we had 22 grants given out that first year, and then that funding, you can see, grew over the years. We got it up to $50 million per year. That money goes entirely to research, doesn't come to KidneyCan in any way. And then over the years, we've stayed at 50 million, and then you can see where it suddenly drops down. That was the beginning of this year when there was a big cut in the government program, and we were down to $0. And then the Restore the Research has been kicking in. So next slide, please. So the good news is we do have this advocacy event coming up in the next couple of weeks, and we have heard from some of the offices that a new appropriation of 15 million has been included for kidney cancer. So we're going back to Washington over the next couple of weeks, and we're going to really fight hard to see if we can make sure that the $15 million does remain for kidney cancer research grants over the next year. So stay tuned, and we'll have more news for you in the future, but we're very hopeful that we'll be able to bring some money to the kidney cancer research community here very shortly. And I think that might be the last slide, but mind checking? Yep, I think that's it. So great.
Thank you so much for this wonderful presentation and for this remark at our closing part. This was the last speech of our today's event, and it was a wonderful recap of what we have spoken all over the day. And indeed, the initiative of advocacy is very important in this stage, and we have spoken a lot from systemic therapies to surgical management and radiation treatment, and now we are there to raise the awareness. And all this event is all about it. It's about science, and at the end about the patients. Thank you so much, Dr. Levis, for being with us. And okay, not Dr.
Sorry, Brian.
My bad. Sorry.
Great.
And with this, I would like to say that day one of the VIRO event is coming to the end. It was a wonderful event. We had speakers from all over the world discussing all over the aspects of the treatment of GU cancers, and I would like to announce that we had around 6,000 live viewers at our event. And thank you everyone who are joining. It's great to hear that so many people were interested in hearing and learning about it. And we're gonna see you tomorrow for day 2 of our event. Thanks a lot.
Thank you. Thanks for the opportunity.